kick off? Great. We'll just get everyone into the room who's outside. Thank you. Welcome. Take a seat. I'm loving the buzz in the room, and I think it entirely... Oh, and I should just say hello to this live stream as well. The buzz in the room is mirroring the buzz on the WhatsApp group, and I'll remind you how to join that, or in fact how to get WhatsApp if that's not an app that you're familiar with. A very warm welcome back to the 2025 Equally Well Conference. To you here in person, let's hear you. Yes. That's the vibe I want. And to you joining us on the live stream, there's a good vibe in the room, and I hope there's a good vibe where you are. Thank you so much for joining us on the live stream today. I'm not always looking at the camera, but I'm always thinking of you as you're joining in today. If you are, who's just joining us today for the first time? Oh, excellent. Okay, welcome. It was a fantastic day yesterday. I think you'll get a feel for we're going to do a summary session early on in the morning, so you get a sense of what happened yesterday in some of the rooms. And obviously the rest of you were here yesterday. So that's great, good, excellent. If you are just joining today, to introduce myself, I'm Natasha Mitchell. I'm a broadcaster, presenter, podcaster, all of those things at ABC Radio National, and host a show called Big Ideas. But a big focus of my work over some decades now, and my passion, has been really connecting mental health, and human rights. And I set up a show called All in the Mind, which I hosted for a decade at the ABC. Then I hosted our social affairs daily show called Life Matters, which again engages with this conversation that you are all part of. And now I host Big Ideas. So yeah, interested in those crossovers between health, human rights, justice, social justice, ethics, policy, politics and science. That's my shtick. So day two, a fantastic day ahead. Really, what a fantastic set of speakers, giving you a tangible sense of what can happen when this Equally Well network is really firing on 25 cylinders. We are on the beautiful country of the Kaurna people of the Adelaide Plains, where it's been known for over 2,000 generations that the health of country is intimately related, fundamentally tied to the health of us as a species, Homo sapiens, but also the health of all other beings that call this place home. And I pay my respect to Kaurna elders and all First Nations people across all of time and in this room as part of your community. And to give the acknowledgement of lived experience, please welcome Dave Peters, the fantastic, motivated, energised, frank, fearless, very open co-chair of the Equally Well Alliance. Thanks, Dave.
Thank you very much. It's my pleasure to be back here today, and I'm sure that everyone, welcome to everyone who is back today, welcome to everyone who is new today, and welcome to those online who are both here today and or new today. Just to cover all my bases. We'd just like to offer an acknowledgement and recognition of those with lived experience of mental health conditions, distress, psychological distress, their carers, supporters, families, and their support teams as well. But we really want to acknowledge that the work that we do here really can't happen without all of you. It's your willingness to share, to contribute, to fight the fight where you can. Russell says, do what you can, where you can, when you can. And that's really what we try and do every day, to try and make our lives a bit better. But we couldn't do our work without your input and your generosity of spirit. We all try and follow the trailblazers that came before us and stand on the shoulders of giants, but it's being willing to come back and continue that fight and demand better. So thank you very much for continuing to be involved. I did just want to offer a very quick, in my other hat again, just a very quick thank you to our generous sponsors. Last night we didn't organise a microphone for our little networking, but I just want to thank you for our generous sponsors for their support in helping making this gathering possible. It wasn't, if not for them, we wouldn't have been able to offer those bursaries to get about 30 lived experience attendees to support them to attend that otherwise wouldn't be able to. So thank you very much to the Commonwealth Government Department of Health, Disability and Ageing, the Queensland Mental Health Commission, the WA Mental Health Commission, South Australia Health, Primary Health Tasmania, Country South Australia PHN, the Mental Health Professionals Network, and New South Wales Government Department of Health, and last but very much not least, EMI National. Some of these sponsors have been with us for many years and have supported us pretty consistently throughout that time. So thank you very much for making this possible. All right.
I could hear you talk for hours.
Oh, well, if you want me to. You heard the one about the... Thank you.
Thanks, Dave. So, just a couple of quick housekeeping, useful things, especially if you've just arrived. Hashtag for all social media posts. Share away, please, because that really helps amplify this movement and this conversation. Hashtag equallywell25. The conference WhatsApp group is going off. If you're not familiar with WhatsApp, the registration desk can help download it to your phone or get you set up on that. You just need to use your phone number. I can help you too. And if you want to join the WhatsApp group, you can go to the registration desk, or if you're online, email admin@equallywell.org.au, admin@equallywell.org.au. Toilets, important, round there, just on this level, just sort of behind there. Emergency exits, there are two, one beside the lifts, another one at the far end of the building on that side, and then the meeting point is in the Hindmarsh Street at the park in the front of the hotel. Just that's important to know. Another thing, yesterday I mentioned this, but I'd like to really emphasise it today because one person offered to book themselves in for this. On the Equally Well website, you'll be familiar with the call to action page. As part of that page, there's a share your story offer. And stories change this movement. Stories amplify this movement. When stories are heard, people are changed and they take action, which is emblematic of everything you're doing in this room. There is another way to share your story today, and we're talking about all stories that are relevant to the Equally Well cause. So it might be a lived experience story of an experience that you've had around your physical health or improving your physical health, what helped. It might be, you might be a researcher, you might be a lived experience researcher, or you might be a clinical researcher, and you might have a story about work that you're doing, data that you've gathered, whatever it is. You might be a scientist, you might be a service provider, you might be, look, we're after all your stories that really amplify the Equally Well movement, and it doesn't have to be anything, you don't have to have a big body of research or anything like that. Everything counts. So if you've just got a minute or two, it might be 5, it might be 30 seconds, it might be just one statement. We would love you to book in, and at lunch they'll be collected. So in morning tea, if you have an opportunity to go to the registration desk, just have a think about something that you want to amplify, and let's record that today. Now's your chance. While we've all got you in the room, it's a really important opportunity for advocacy, and you're in control of what you want to share. So there's that. Thank you very much for doing that, because there's how many people? 300 people at this conference. Let's really just go for it. Yesterday was a big day. Let's get all caught up on what was talked about in some of the workshops. So this is an opportunity for different participants in those workshops to share some updates from the facilitators of the workshops. And first up, we have John Allen. Please join us.
Good morning, everybody, and let me just add my thanks with Dave as well to our sponsors. It's very important. Now, I had a really great group. We were talking about vaccination. We had some great presentations from our colleagues in New South Wales who've been doing a vaccination program for people with serious mental illness, and then some assistance from our colleagues in South Australia who do the regulatory arm of vaccinations. And they talked about how we get through the hoops and how easy it could be to do that. And we came up with 9 recommendations. And then Lee told me we were only allowed to have one, because I wasn't speaking of that. So I'll do my best. But it was a bit of a no-brainer for us that we recommended that there should be a national vaccination program for people with serious mental illness, particularly focusing on influenza and COVID. And to do that, we need to collect the evidence, which we're doing through the New South Wales trial, but also have data linkage so we can get that done. We need to look at the international evidence. There are a few countries that have been doing this as well. It sort of came as a COVID thing that during COVID, Equally Well actually made a call to action around vaccinations, and we were actually able to influence the early stage of the Australian vaccinations, where we were able to add people with serious mental illness to the list of those conditions where you got early vaccination. And then, of course, everybody got vaccination. So, we have got some track record in doing that. We need to do that well. But also not to forget that in this world where vaccination is under some threat through vaccine hesitancy and through the erosion of the CDC and people whose name I won't even give at this conference, that we also need to think about the whole vaccination program, what that actually brings to our own physical health and what people are doing. And again, talking of that, drawing on that opportunity we talked about, when people get admitted, you can go through the whole program with them as well and fix up their tetanus and do stuff like that. So we talked about that. And then, one more minute, we also talked about, of course, that the thing that was lacking, that is needed in these programs, is the lived experience of why people want to or don't want to get vaccinated and how to help them get vaccinated. So that needs to be the thing the whole way. We've got great support from the regular vaccine programs. We need to partner with them to get that done. And really it's about those things where we need to train people to give vaccinations, then we have to set up to make sure that they can do the vaccinations, and we have to count and measure to get that done. And there were some very good models of implementation from high resource to low resource that New South Wales have trialled that we could all trial. And it turned out, of course, that in the discussion, someone who's running an over 65 service said, well, why can't we do that? And the vaccination people from South Australia said, well, of course you can do that. It's all set up. You've just got to apply, and you've just got to get the training, and you can set it up. And so, there are opportunities even now without doing that we could do. And then the last one was that someone said, I must say, could South Australia please finalise the draft physical health standards? It's very important. So thank you very much.
Fantastic. Solid recommendations. Next up, we've got Caroline Johnson. Welcome, Caroline. Great. Awesome. I sat at the beginning of your session.
Hi everyone. Yeah, we talked about Equally Well in primary care, and because it was run by a couple of GPs, a pharmacist and a primary care nurse, we kind of mainly talked about general practice, but of course it is much broader than that. So I want to thank Simone, Amanda and Regina. Hands up wave if you're here. They helped a lot in this workshop. So we tried to get people thinking about the biggest thing they would like to fix about primary care in the Equally Well space, and we got people to identify who they wanted to speak with, who they wanted to be, so whether they wanted to be a lived experience or whether they were clinicians, and we broke them all up according to who was in the room. And then everybody's issues were all stuck on the wall, and then I did a very quick, being the good qualitative researcher I am and good at time management because I'm a GP, I tried to kind of synthesise them very quickly into 4 big themes, and the themes were, I hope I get this right, one was around how we fund primary care to do this work, one was around how professionals collaborate to work in a connected way, one was around sort of models of how we think about mental illness intersection with physical health, so issues like discrimination and the language we use, that kind of thing. And then a 4th theme was around resources that we need, so they might be education resources or language resources, and again across everyone. But for those 4 themes, we then remixed the room, so we had people identifying as different things sitting around the table together, and of course that's when you really realise how hard these problems are to solve, because everybody has different ideas. But it was really helpful that everyone could have what I think was a really good listening exercise. We, like John, also had, every group was very diligent. Each group managed to make 1 recommendation, but that would have been 4 recommendations, and Lee wouldn't let us have 4. We have sent your words to Lee. We've photographed them, written them down, sent them, but Simone very, very sensibly put them into some kind of AI thing and has come up with really quite a beautiful thing that summarises what I think represents what we talked about for primary care. A unified, holistic health model should integrate funding, digital systems and clear clinical pathways to connect GPs, mental health and community services, supported by peer navigators and education programs co-designed with live experience. This approach promotes efficiency, equity, and improved patient and workforce outcomes through collaboration, accessibility, and a blame-free culture. AI works, for once. So thanks very much for the opportunity.
Damn ChatGPT. It's taken our jobs. Anyway, but it has a purpose, doesn't it? Even if it is to plagiarise. Controversial. Okay, next up. Thank you so much for that, Caroline. Appreciate it. And all those involved in your workshop. Fiona Crawford Williams and Kate Whittaker, please take the stage. Thank you. Who have we got? Kate. Yes, Kate Whittaker. Great.
Thank you. Fiona's unwell today, so it is just me. So I'm Kate Whittaker. I'm from Cancer Council Australia, and I just first want to say thank you for the invitation, to be a part of this workshop. And also, it's been really wonderful to meet you, especially everyone working in mental health services, whether it's in the community, in the tertiary setting, in research, lived experience. I think for us in cancer, it's a really exciting space to build better collaborations, and through this workshop, we were hoping that we could start to do that. So we have one recommendation, but it is quite a big recommendation, that we need cancer services and clinicians to be upskilled in the person-centred, trauma-informed care that can identify the holistic needs of people with mental health challenges. And how we came to that was that we've just had the Australian Cancer Plan launch 2 years ago, but it does set out a 10-year ambition for cancer in Australia, and that's from prevention, screening, treatment, supportive care across all cancer control. And as part of that, Cancer Australia, who is the government body for cancer control in Australia, has identified what they term as priority populations, so people, groups of people who have poorer cancer outcomes and experience inequities in our health system. So through that, there is a greater focus that we can leverage through our collaborations and funding opportunities to do some of this work that might help reduce those disparities. So our workshop really talked about a framework for doing that, and we have the optimal care pathways, particularly in cancer control, and they set out what is best cancer care for so not only people affected by cancer, but this is also covering prevention, screening, early detection as well, so the whole continuum. And so there is an opportunity for us to all work together to develop what could be the first optimal care pathway for people living with mental illness, distress, and across sort of the whole, range of mental health challenges. And so we framed that to our workshop around, could you talk about the barriers and enablers at the moment to preventative activities, to screening services, and to other services in general. And that was really informative around providing guidance of trauma-informed care, the role of other support networks, whether it's formal social workers. I hadn't quite appreciated, the great role of social workers, and being the bridge between psychology, other mental health support services and clinical services, and the needing to reframe what healthcare is for people, and actually getting back to the core of it, something for you to do for yourself for the benefit of you and your family and others. And so how do we actually create those enabling environments that are supportive, that focus on why you need to be there, and that it's not a clinical transaction or a wrap around the wrist because you've missed an appointment. It's addressing all of the accessibility issues that we need people to be coming to health services. We need to be going to people as well to engage them in activities like screening and preventive activities, and also enabling connections to the wider allied health. It's really connecting people to this together. So sorry, that was a very big brain dump of mine, but I've just been really challenged about how we can put that into an opportunity that we've got around optimal care pathways. So we actually ran a Mentimeter sort of session. We've got a lot of info that's come from that, and so I'd be really excited to put that into a more formal report and provide that back for some more input.
That would be great, and I'll just get the mic up.
Thank
So
you.
much.
Yeah.
That's great. That additional context was really useful, so thank you for that. Let's keep that conversation alive today. Who else works in the cancer space? Yeah, okay, this is good. So it's fantastic that you're here today. Excellent. Maybe the conversation might continue. So, and on the WhatsApp group, if people have questions for you, you might. That's another way to engage. Are you on WhatsApp? You are? Yeah, great. All right. Well, next up we have Chris Jones, Phoebe Marshall-Liu and Claire Keogh. Is it a three-way tango? Is it Claire? Phoebe. Oh, Phoebe. Yeah, great. Excellent. Come on down.
Hi everyone. So I am speaking on behalf of my co-facilitators Chris Jones and Claire Keogh. Claire can't make it today, but what I first want to share is a perspective particularly from Claire, because she was our wonderful GP in our session, and Chris and I are from the Sydney Primary Health Network. So our workshop was around GP shared care, which is really a program that we fund with our local health districts in Sydney for people with severe and enduring mental health issues to have formal shared care arrangements between a GP and their public mental health service that they work with. So again, we had a number of recommendations, so I'll try and keep it quick, but our main one should be on the screen there. But the first one I just want to mention was on behalf of Claire. So it was from the perspective, which was incredibly valuable for Chris and I, being across the shared care program within the PHN. This is the kind of feedback and an enormous amount of feedback from the audience as well that we'll be taking back to shape the redesign of our program. So Claire was saying from a general practitioner's perspective, a really key recommendation is to prioritise communication and collaboration in implementing shared care arrangements for mental health and physical health. Because essentially, GPs really value shared care arrangements because it means that not only can the person receive that holistic support, so they're not just having their mental health needs focused on or just their physical health needs focused on, but it's that holistic approach. But it also means that the professionals working with that person receive the benefit of working together as part of a coordinated team response, which helps everybody. The key recommendation that came out of it, particularly again for us at the PHN to be able to take back into the redesign of the program that we're looking at, was around the fact that so currently GP shared care arrangements in our program are primarily available to individuals with severe mental illness who are engaged with local public mental health services. So we had a long discussion, and we continue to talk about it after, about how do we open up those same referral pathways and same level of care for people that aren't and don't need to be engaged with public mental health services. So how do they still receive that holistic support? So that's something that we'll definitely be looking at. Just two other quick mentions is a really great idea that came out of it, again from a PHN perspective, was someone mentioned creating a resource around something that really helps patients or consumers understand what is it that my GP can help me with when it comes to not only my physical health but my mental health. And we felt from a PHN perspective that's something we could engage our GPs with, so that as a person you're empowered to sort of go into your GP appointment and know what sort of things you can be asking for. And then, again, for our GPs was looking at increased support for them at the primary care level, so assistance with care coordination, expert guidance on medication management, and access to particularly multidisciplinary team support. So that's us. Thanks, everyone.
Thanks so much, Claire. That sounds terrific. And thank you for sharing all your conversations from yesterday. That's excellent. Maybe we can talk more about those throughout the day. Well, we've got a special launch now. The Equally Well Network's all about collaborating, clearly. And this is a fantastic collaboration between Niamai and Equally Well Australia. They're launching right now, right here, an updated Niamai. Now, I don't quite get there. I pronounce that slightly oddly, I realise, but there we go. Niamai. I've heard it actually pronounced 3 different ways this week. So, Nimai, thank you. I do know that. So, what they're launching is the Nimai Health Prompt. It's an updated version, which is a physical health assessment tool for the community mental health and social services sector. So, this is Australia's first tool designed for both consumers and health professionals to address physical health needs in community mental health, and it's been refreshed with a partnership with Equally Well Australia to reflect new data. Excellent. Data shines a light about leading physical health risks for people living with mental health conditions. And I'd like to welcome to the stage possibly 3 of you, but I'm realising that it might be 1. I don't know. Tom Dalton, have we got the Nimai National CEO? Hello, Tom. Have we got Dave Peters? Yes, we do, Equally Well Alliance Co-Chair, and Russell Roberts of Equally Well. Thank you.
Thank you all for being here for this exciting launch of the updated or refreshed Nimai Health Prompt. I first encountered the Health Prompt when I was actually a consumer of Nimai services, and it was probably back in 2013 or something like that. But it was the exposure to the Health Prompt and looking at all the other things that kind of get deprioritised or missed or unaddressed that got me involved with Equally Well in the first place. Learning about the life expectancy discrepancy and learning about all these contributors to causes for premature mortality that could potentially be treated, managed or avoided completely. So it was really thanks to the Nimai Health Prompt that changed my attitude in how I want to live my life day to day, but also directed me to something that I'm intensely passionate about and really excited to see all of the positive change that is happening. Not just within Equally Well, obviously, but seeing the opportunity for this partnership to grow and develop, and to see the combination or the collaboration to co-design and improve this refresh. So, look, thank you both to Russell and to Tom for being willing to go through the process and bring it all together. Thank you.
You may have noticed in the conference that this conference begins and ends with lived experience. And that's not an accident. And thanks to the committee, we've thought through this very carefully. And that's how it should be. And when we think about in the middle, we have all our partners, we have the governments, and the wonderful things that are happening in Queensland with the smoking cessation across the whole nation, saved as many lives as having zero suicide in Queensland, by the way, over the last 5 years. Magnificent. The work that's happening in New South Wales, big projects, vaccination, free vaccination, a rolled out program, saving lives. The work that's happening in Victoria, embedding the strategy in everything that's happening. And that magnificent work that's happening here in South Australia over so many areas. The new standards, the work around live reporting, the work about embedding Equally Well in teams and having plans and teams and regularly refreshing that, and the other work that we're going to hear about today. Our partnerships with the PHNs, our partnerships with the mental health professionals networks, our partnerships with MHPod, where we do things together to create resources that are freely, universally available. Partnering with researchers, with policy makers, with people with lived experience, those who care and support for them. The providers, practitioners, advocates, anyone with a passion for equality and good health. It's deliberate, and it's a partnership. Why am I saying this now? You know, our system is fragmented, isn't it? But we don't have to be. We have agency. We're active agents in the system. We don't have to behave that way, and we are better together. The Nehemiah Health Prompt embodies all of this, the development of this. I've got to call out to Chris Jones from the PHN, who contacted me, and it's the organic way as well, said, oh, we'd like to use this in PHN land, but how do we get it? We can't seem to access it. So then at a committee meeting with Tom, I go, Tom, can we do something about this? Can we refresh it and make this available? He goes, yeah, sure, let's do it. And then I'll call out to Maddie and Sarah and Helen and the team, and we basically went and partnered and did this. Co-designed, bringing the latest, the best researchers around the country, updating it consistent with current research, lived experience, beginning and end, providers, practitioners, service makers, service providers and policy makers, all together to co-design the refresh in a rather rapid way, I've got to say, but record time, so well done, and real shout out to Maddie and her team. But this also embodies equally well, doesn't it, in terms of working together. And you know, the wonderful thing about this is now we've got a resource that's freely and universally available that will do it. And this says so much about the collective impact of what we can do and the difference it makes, and the difference it's already making. This is going to really transform and save lives. Scores, hundreds, possibly thousands of lives by rolling this out. So, Tom, it's been an absolute pleasure working with your team, and I'll hand over to you that you've got to be really proud of the team, of your Nehemiah team, and it's been an absolute pleasure to partner with you in the production of this resource. So thanks.
So thanks. I guess, you know, when I thought I was coming to the Equally Well conference on day 2 for a presentation at 8:50, I hadn't quite imagined there'd be so many people in the room. So it is really fantastic to see that you're all committed and curious enough to be here to learn about this refresh tool. And I'm sure none of you are here because it's the way to avoid a health screen or because you've been told to by your GP. But I'm sure there are probably some of you who are here probably preferencing Dave or Russell or the Minister over me, so I'll try and keep it brief. Nehemiah has a long history in Adelaide. We're an organisation that started in Melbourne. We're national, as our name suggests. But in Adelaide, we've long provided psychosocial support and homelessness support for communities. We run the Wellness Connect psychosocial program here, the Safe and Secure Housing program, which supports families fleeing domestic and family violence, and the statewide for the Adelaide, also for the Adelaide PHN and the South Australian PHN, the statewide mental health Medicare, so they rebrand it so often I forget the name, Medicare mental health phone lines, and we've got services in Port Pirie and Port Lincoln. We're proud here in Adelaide to work on Kaurna land, and I just want to acknowledge that their sovereignty was never ceded on invasion and pay my respects to their elders. I don't need to go into the reasons why we're here. The fact that people who experience mental health challenges have a disproportionate life expectancy than others, they've got poorer health outcomes, and that they're unable or sometimes reluctant to access the screening that they need to enable early intervention. But this tool is designed to change that. As Russell said, it's a fantastic example of the collaboration that happens across the Equally Well Consortia, bringing service providers, researchers, people with lived experience, their carers and kin together to bring what has been an existing tool for Nehemiah. This has been around since 2012, but what it aims to do is equip staff to have supportive conversations with consumers across the social services sector. So it's not a mental health specific tool, but it was developed by NEMI and used, as I said, in our services since 2012. Its development and its refinement over the years has primarily been influenced by people with lived experience and their families and carers. I'd like to express my appreciation for the input that they provided us over the years on this, and really, particularly in this latest iteration, how it's been informed by people who bring their lived experience in designated roles within the organisation, because obviously that makes our services so much richer. In its time, it's been championed by many people in NEMI, and I want to particularly call out Vicky Langan and the team that sat around health promotion in NEMI when I first came 6 years ago, because they really pushed this tool hard across our services and worked to make sure that it was evidence-informed. And more recently, as Russell shouted out, to Maddie Prince, who's our National Practice Lead, and her team, and the comms team, the engagement team, everyone for putting in an enormous effort to doing the work on refreshing this tool, which has, as you said, Russell, happened in record time. And we were really excited to be approached by Equally Well to do this, because we know it's valuable. We know we've also adapted this tool ourselves. So there's a specific Indigenous health prompt and a version for older people and for young people as well. And we look forward to working on a refresh on those particular tools as well to make them publicly available. At NEMI, we know that context and connection matter when we work with people with mental health challenges. And what this tool tries to do is not be a tick box approach, but it tries to provide a framework for strength-based conversations with people about their health, to explore their confidence. So it's not just what's your health problems, it also seeks to look at and understand what people's confidence is in seeking care and their experience in healthcare services previously, to build and enable them to move forward to get the screening or health care that they need. Staff can use particular elements of it. You don't have to use the whole tool at once, and it's designed so that over time it can be used every 6 months. The most recent refresh, as we said, has been a real team effort across all organisations. We know this tool works for staff and for service users. It's about connecting consumers to the right healthcare, the right screening, so we address the issues that Equally Well was set up to address. There's no point in having a tool like this if it just sits in NEMI services or in the laptops and G drives of our organisation, which is why we want to share it across all social services. So you've all got copies that staff have handed out. At NEMI, we really value learning and we really value connection. So there is this is really dangerous when I get the clicker, but I could have gone to that one earlier, couldn't I? We know it works. We've had the feedback from staff, we've had the feedback from the people who we walk alongside that this is a really effective tool. You can access it there. If your fine motor skills and eyesight are good enough that you can get your camera on that, that's really great. If you can't, maybe think about going and having a vision screen and testing your eyesight. But we want this to be available. We'll be pushing it out to all primary health networks across the country in the coming week. We want this to be available for everyone, because it's pointless if it just sits within NEMI services in a NEMI context. As I said, we know it works. It's been a fantastic collaboration between all of us, and I'm really hope that you're able to go back, use this tool, distribute it widely, sit with consumers to have meaningful conversations to enable them to remove the need for this organisation. Thank you.
I've got a little present for you all.
5 minutes?
Why not? You do.
Fantastic.
Thank you.
Thank you.
You should have got 5 of those. What a fantastic tool. It's been passed out throughout the room on your tables. Take this brochure with you. Don't put it in the recycling. Put it in a very public space in the environment that you work in or participate in. I just think some of these questions are just, they are profound portals into support. So, for example, I know, being a paleface, I've got to go and get a skin screening check every 6 months now, and invariably that results in things being chopped off. That question, have you been offered a free skin screening check? Have you noticed any changes to your skin that you were concerned about? No one asks those questions. What a powerful, powerful tool, just the act of asking that question. And do you feel your bladder and bowel function is consistent and comfortable for you? Hugely important question. And then, have you had access to a dental checkup in the last 6 months? We know that dental health is a portal into heart health and all sorts of other aspects of our physical well-being. So that's a really under-discussed public health issue in Australia, despite everyone's best efforts to try and get dental health care on Medicare, hey? So thank you very much to Nimai and Equally Well for that incredible tool. Let's really get it out there and spread the word. That sounds obvious to do, but let's do it. Excellent. And what I love about this right throughout the 2 days is that this network is all about collaboration. Things don't have to stay the way they are, even though we as a species love a good silo. We love a good specialisation and a silo. We can dismantle them with conversations, and I'm blown away by what you're all doing here. And how else is it, other than through collaboration, that we can break down these health disparities? I'm stating the obvious here, but thank you for doing the work that you're doing. And also just a reminder that the Pharmacy Guild is back today and they are doing free health checks out there, which is another great way to start a conversation about how you're feeling about your body. Well, now I'm very pleased to say that South Australia's Minister for Health and Wellbeing has made the time to be with us today, which is absolutely excellent. The Honourable Chris Picton is joining us to give today's welcome and opening address. He is the member for Ghana in the southern suburbs of beautiful Adelaide. He's previously served as a Minister for Police, Correctional Services, Emergency Services and Road Safety. Huge. Before his election to Parliament, he served in roles that were very relevant to today's conversation as Senior Advisor and Chief of Staff to former state and federal health ministers, so health ministers, and Associate Director at Deloitte Access Economics. His areas of policy work included tobacco plain packaging, huge, national public hospital funding, huge, and the reforms thereof. And so we give a very warm welcome to the Minister. Thank you so much for being here.
Look, thank you very much. And firstly, can I acknowledge that we meet on the traditional lands of the Kaurna people and pay my respects to elders past, present and emerging. Can I acknowledge John Allen and Dave Peters, the co-chairs of the Alliance, Professor Russell Roberts, the Equally Well National Director, but all of you who have come from around the country to be here as part of this important conference. Yesterday we had some sad news that Adelaide is not going to be hosting COP, but at least we are hosting the Equally Well conference here in South Australia for the first time, which is more important, exactly. Now, welcome to day 2 of the conference, and it's wonderful to see so many of you here, researchers, clinicians, advocates, policy leaders, and importantly, people with lived and living experience. And I want to begin by recognising the extraordinary work of the Equally Well Australia. You've created a movement that stretches across governments, services, regions and disciplines, all united by a shared purpose: to improve the well-being and the life expectancy of people living with mental health conditions. Since governments first formally committed to the Equally Well National Consensus Statement in 2016, the movement has grown into a powerful national collaboration, one that elevates lived experience, strengthens evidence-based practice and shines a light on unacceptable life expectancy gaps. And thank you for choosing Adelaide to have your conference. We are here because every life cut short is a story unfinished and a family forever changed. Across Australia, our collective effort can rewrite these stories. And we know that the inequalities are stark. People living with mental health conditions experience poorer physical health, barriers to care, and significantly shorter life expectancy. The national data tells us that these lives are being shortened by 14 to 23 years. We know that people living with mental illness are twice as likely to experience chronic physical conditions, 56% more likely to smoke, and 6 times more likely to have dental issues. As the Equally Well Consensus Statement reminds us, Aboriginal and Torres Strait Islander people already face a 10-year life expectancy gap, which widens even further for those living with mental illness. And when a person's cultural identity and integrity is disrupted, culturally grounded responses aren't optional, they are essential. A holistic approach built on lived experience and cultural understanding is the only way to deliver care that truly heals. These aren't theoretical challenges. These are real people, real lives, real communities, and that's exactly why Equally Well matters. And Equally Well is more than a policy platform, it's a roadmap for a healthier, fairer future. It calls for care that is connected, preventive and whole. Its goals are clear: to close the life expectancy gap, to make physical health inseparable from mental health care, to strengthen cross-disciplinary partnerships and to turn evidence into practical solutions that change lives. And SA Health is proud to support the National Consensus Statement. It's embedded in our state mental health services plan, backed by ongoing work and grounded in a long history of collaborative action. The South Australian Government is committed to transforming research into real-world change built on decades of that groundwork. It goes back to 2008 when we launched a mental health-led metabolic health action plan, supported by online health promotion tools and multidisciplinary collaboration across services. This work helped embed consistent physical health assessments, including weight, waist circumference, blood pressure, across our mental health services. The message was clear then and remains clear today. Physical and mental health are inseparable. And we've continued this work through strong engagement with general practice, led first by dedicated GPs and more recently through the SA Health GP Liaison Group. This group brings together GPs, mental health clinicians, lived experience leaders to champion shared care and promote equally well principles. And through education sessions, learning forums and cross-sector collaboration, we're strengthening integrated care at the front line. And last year, SA formed a statewide Equally Well and General Practice Shared Care Working Group to drive physical health reform. The aim is to drive change with the same discipline and momentum used on work on issues such as restrictive practices. With membership from lived experience, universities, GPs, NGOs and our local health networks, the group is now supporting local health networks to implement their own Equally Well action plans, with most of those already underway. And our Chief Psychiatrist who's here, Dr. John Brayley, is also working on his physical health standard, currently being refined and headed towards broader consultation. This will support services to meet physical health requirements already outlined in our Mental Health Act. We know that there's more to do, but the foundation is strong and innovation continues to grow. Internationally, the WHO recognises immunisation as a core component to the human right for health. Yet vaccination remains one of the largest and most persistent health gaps for people with mental health conditions. In Australia, influenza vaccination rates remain low among people experiencing mental health illness, and the consequences are serious. We see higher hospitalisation rates, increased mortality, and missed opportunities for prevention. People experiencing frequent mental distress are 21% less likely to be vaccinated. In South Australia, they accounted for nearly 28% of vaccine-preventable hospital admissions last year. Nationally, more than 2,000 deaths occur each year from the flu and pneumonia amongst people with mental health conditions. And together with New South Wales, South Australia has presented evidence to ATAGI advocating for people who experience a chronic mental health condition to be eligible for a free flu vaccination. A New South Wales study has demonstrated that people accessing mental health services were 3.2 times more likely to be hospitalised for vaccine-preventable disease and 2.7 times more likely to be hospitalised for influenza. And the average length of stay for pneumonia is 14 days. But for a person with a mental health condition and pneumonia, it is 19.5 days. This correlates into a potential additional cost of $15,000 per admission. Increased vaccination rate would see a benefit to individuals and families, and the impact on the health system could be enormous. So we will continue to advocate for that national change. Closing these gaps isn't just the right thing to do, it saves lives. Over the past 3 years, the South Australian Government has invested $1.7 billion to expand our mental health services, opening new pathways for treatment and recovery. We're delivering 72 new rehabilitation beds across 3 major new units in our hospitals, embedding in those new units equally well principles into rehabilitation models through exercise physiology, dietetics and physical health programs. And we've strengthened our community mental health teams with $8 million investment. And to see the fruits of these investments equally well must form an integral part of the care that we are providing. Lived experience doesn't just highlight the gaps, it shapes solutions, sets priorities, and keeps us grounded in what matters. And in South Australia, lived experience is not just symbolic, it is central. We provide ongoing funding to support our lived experience leadership and advocacy network, ensuring voices remain embedded in service design and mental health reform. From GP liaison programs to co-design initiatives, shared care models and statewide committees, lived experience leadership continues to grow and continues to guide every decision we make. So when lived experience leads, change is not only possible, it is lasting. Real progress happens when expertise, evidence and commitment converge. Equally Well was one of the strongest examples of this convergence. Every action you take helps to close these gaps. Every effort moves us closer to a system where care is seamless, integrated and fair. Thank you very much for having me, and I look forward to hearing the outcomes of the conference.
Thank you so much, Minister. Excellent, and great to hear you centring the lived experience leadership in South Australia, and this conversation about free vaccinations and the data that shows that that works. Also vital. We're grateful that you were here today and are really celebrating and acknowledging the Equally Well movement. Now, we've got a little prezi for you, so come on down. Yes, you'll need those nuts today to get you out there and on the road. Let's give it up for the Minister. Thank you. And you might like to also partake in what we're about to do now. I'm delighted to welcome back to the stage Zulia Jupan, who is working in Noongar with a critical mental health service, critical care service, and she's an exercise physiologist. You can do everything that she's going to take you through seated as well. Come on down. Let's get...
Thank you, Natasha. Good morning. So I'd like to pose a bit of a scenario to you this morning. I want you to imagine that you're working with a consumer. You haven't seen them maybe for a little while. The last few months have been quite tough for them. Maybe they've had a few hospital admissions. There's a lot of psychosocial stresses going on, maybe housing instability, interpersonal issues. And it's been a difficult time. They've maybe just started on clozapine when they were in their last hospital admission. So while you're sitting with them, you notice on their file that they have a few cardiometabolic markers that are not quite in the right place. Maybe they're pre-diabetic now, their blood lipid profile is deranged. You look at them and you notice maybe that they've gained some weight as well since they've been on the medication. And so you decide to say 6 magical words that are going to fix everything. Have you ever thought about exercise? And you notice the look glazes over in their eyes, and you're sure that they're about to trudge out of your office and never think about exercise again. But fear not, you have an exercise physiologist part of your service, and you know exactly what they do. And you know the importance of mind and body connection. And you know how difficult it can be to start exercise, particularly if they have come from a place of never exercising before, if they struggle with confidence, or if they've got a trauma history. And so maybe you make a referral to the exercise physiologist if they consent, and then the exercise physiologist will run through some trauma-sensitive movement practices to begin with, to support someone reintegrating that mind-body connection, noticing where their body is in space and feeling safe within their body, having control and autonomy over their body. Now, I'm sure most of you have heard of the book, The Body Keeps the Score, and we know how integrated that relationship is between the mind, trauma, physical health, and how important it is for us to address it. So today, although I know you all wanted to be doing burpees this morning, we're going to run through a really gentle mind-body practice. So I'm just going to invite you to get comfortable in your chair. And you might just like to recline, relax, find something that feels nice for you, where you don't have to focus too much on holding your body upright. Now, the language that I'm going to be using during this brief session is going to be very invitational, and that's intentional because I want to facilitate a sense of control over what you're doing. You might like to follow along with what I'm doing. You might like to stop. It might even be a bit confronting to you to notice your body for the first time. So just listen to your body and find what works for you. You might like to have your eyes open and maybe rest your gaze somewhere, or you may even feel comfortable enough to close your eyes. And I'm just going to invite you to begin by just relaxing the body, maybe just taking a deep breath in and out. I'd like to invite you to just begin by noticing the rhythm and the depth of your breath. Is it fast or slow? Is it deep or shallow? And where do you notice your breath? Do you notice the rise and fall of your chest as your lungs expand and relax? Maybe you notice the movement of your belly, fabric of your clothes against your skin, or maybe the flow of air in and out through the nose or the mouth. And you might just stay here noticing the breath, or you might like to join me in gently bringing the right ear down to the right shoulder, stretching the left side of the neck. And I'd like to invite you here to just tune into what sensations you can feel. Where does a stretch start? Where does it end? Can you experiment with the stretch? You might even place a hand gently on top of the head and deepen the stretch, using your own hand to pull your head down. You might stay here, or you might slowly roll the chin down to the chest, stretching through the back of the neck. You might like to link the fingers together and reach the hands away from the body here, stretching the shoulder blades. Notice what muscles are working through the shoulders, down the arms, into the wrists and the fingers as well. And again, you might stay here or you might relax back. Just take a moment to notice the muscles that you just worked and used. And then you might join me in bringing the left ear to the left shoulder. Maybe this side feels a little different, just noticing what you notice here. Maybe you notice your breath in this position too. Does it feel any different? And then maybe you slowly roll the head back, lift the chin up to the sky. And you might just experiment here. Maybe you clench your jaw. Maybe you wriggle the lips, just maybe turning the head from side to side, even creating different sensations in the neck. Noticing what you notice. And then coming back to the center when you're ready. You might like to join me in maybe extending one leg and just wriggling the toes, moving the ankle. Can you notice the sensation of your shoe or socks against your foot? You might like to straighten the knee and bring the toe up to the nose, squeezing all of the muscles. Maybe you hold it here. Notice which muscles are tight. And then you might let it relax. Maybe you try the other side. Wriggle the toes, move the ankle, however feels good for you. Again, just notice what sensations you can feel in this part of the body. And once again, just lifting that foot up, toe to the nose, squeezing the muscles of the thigh, holding here. Notice the tension. And then maybe you relax. And finally, I'd like to invite you to join me by maybe sitting up nice and tall. And you might like to take your right hand, place it on the left side of the chair. Left hand goes behind the body and just twisting over the left shoulder as far as you can go. You might hear a crick and a crack in the back, that's okay. Holding here and just noticing how this changes the sensations as you breathe. Might be a little harder. Just tuning into whatever you feel. Maybe one more breath. Slowly swapping sides. Left hand to the left side. Right hand goes behind the body. And just noticing what you notice here. Slowly coming back to the center. You might like to relax again. And I'd like to invite you to join me in finishing by just placing a hand over your heart. Maybe you notice the rhythm of your breath or the beat of your pulse. Just spend a moment here. And then I'd like to invite you to draw to your mind the image of something, someone, or somewhere in the world that brings you a sense of joy or peace. And just hold on to that for a few moments. You might slowly open your eyes. You might have a little bit of a freestyle stretch now, just whatever feels good for you. Thanks for joining in on that practice. You did a great job. Thank you.
Wow. You don't know how much I needed that. Wasn't that a beautiful exercise? Just an anchoring back into the body, and there's something really special about doing that in a large group, I think, and hearing the symphony of back clicks as we do a twist and a turn. Well, thank you so much, Natalia, for being part of the conference this 2 days. It's just really wonderful to have you here. Let's thank Natalia. Well, I'm very excited for this next session on cultural mental health and wellbeing, an approach for First Nations people. And joining you now is Ian James. We've got a partnership here on stage next. Ian James is the Principal Aboriginal Mental Health Advisor for Mental Health Strategy and Planning and the Office of the Chief Psychiatrist, South Australian Health. He's worked in mental health for the past 14 years. He's a proud descendant of the First Peoples of the River Murray and Mallee region and Southern Arrernte of Central Australia. And joining Ian, I'm pleased to say, is Robert Ledig. He's a proud Ramanjeri man from South Australia, born on the ancestral lands of the Bangala, Nukunu peoples in Port Augusta, now living on gorgeous Kaurna country. He is the founder and CEO of a not-for-profit charity organisation called the National Indigenous Network Initiative, and NINI, or NINI, N-I-N-I, and has worked across justice and housing and homelessness and mental health, leading programs across South Australia, the Northern Territory, and across the APY lands. His vision is to transform trauma, to improve mental health and foster self-care, healing and connection. Please welcome to the stage Ian and Robert. Thank you.
Good morning, everyone. My name's Ian James, and I won't go through my title again and introduction. That was really well done. And this is Rob. I'll let you introduce yourself, Rob.
Yeah, hello everyone. Robert Leidig, as our MC just mentioned. Just before we get into it too, that was a beautiful stretch. I'm nice and relaxed now. I was a little bit stressed earlier. But just before we get into it, just to fill the room, can we just get some hands up? How many people in the room identify as Aboriginal and Torres Strait Islander? Fantastic. How many live and work in Adelaide? And how many are from interstate or overseas? Wow. And how many needed 2 coffees and that stretching this morning? Fantastic.
I didn't do the stretching, though. No. Okay. First of all, yeah, we'll go past that one. First of all, like most of our ways that we do things out of cultural respect is to acknowledge the traditional owners of the lands that we meet on today, which is the Kaurna people, and we pay our respects to their elders past, present and emerging. We also would like to pay our respects to people with lived experience and living experience. Their input into the system design of mental health and wellbeing is very vital, and to make sure that we are well supported across all age groups. Sorry. So I guess the reason why Rob and I are up here presenting, and I dragged Rob up basically because he is the CEO of NINI, but he is also the lead for the Aboriginal Mental Health or Aboriginal Social and Emotional Wellbeing Centre, which we'll go into a little bit. The centre is actually the first of its kind in this country. It actually it's designed to support Aboriginal people and Torres Strait Islander people in South Australia around their mental health and wellbeing. And it's also all of age, which is the only model that we believe of its kind in this country. It's designed to actually support community members who are dealing with mental illness and their well-being from a very early age to their older people. So basically from birth to death, in a sense. It's that continuous care model that we are been talking about for many years. We've been talking about the holistic approach to mental health and wellbeing, and I believe that the centre that we've designed through its model of care and through its, knowledge of culture, which is the core basis of what the centre is designed to do, is to use the knowledge and understanding of 60,000 years of Aboriginal and Torres Strait Islander culture to actually support and improve Aboriginal and Torres Strait Islanders' mental health and wellbeing. And as it says on the board, the reality is that the past keeps asserting itself as it leaves echoes, ripples for you to see if you look. Most Aboriginal and Torres Strait Islander people go to mainstream services. Unfortunately, most of those mainstream services have very little cultural understanding of why they're attending their services in the first place. They either have some kind of knowledge or they choose not to understand the reasoning why they are actually attending their service. The centre actually is drawing on that knowledge, drawing on their culture, drawing on their experience, and drawing on the continuous intergenerational trauma that has been affected Aboriginal and Torres Strait Islander people for centuries. And I think it's very important for us to be very aware that we, as Aboriginal and Torres Strait Islander people, still are out or still have high rates of suicide, mental health presentations across the board, no matter what age it is. Usually it's the youth, to be quite honest, that have the highest impact. We have had recently a number of passings in our country area in South Australia where, unfortunately, they're all preventable. These deaths should never have occurred if the supports were in place in the first place. Now, most of the time, our communities have very little knowledge of what services are around in their country or metro space. And a lot of them, too, do not want to go from one place to the next. We don't support them in that sense. We don't provide the opportunity for them to get the wellness or the care that we all expect to get if we go into a mental health or wellbeing service. So this centre was based on all of that. This centre was based on the lack of support for communities. This centre was based on the lack of Aboriginal engagement in services. And this centre was based on building up our own workforce to actually improve our outcomes across the board. So I'm going to stop talking and let Rob talk now.
That microphone there. Hello? Oh, look out. Thanks, Ian. As well, I just want to say how honoured NINI, the National Indigenous Network Initiative, is to lead the very first all-aged Aboriginal social and emotional wellbeing and mental health centre in the country. We're Aboriginal community controlled, we're Aboriginal community led. We listen to the voices of our mob. We gongen, we listen. And we see them, we knuckin' them. It's very important. We're not into correction, we're into connection. That's how we roll. Couple of things. Myself, I'm a narrative therapist. I love narrative therapy. Part-time existentialist, part-time logotherapist. I'm sure you all know what that stuff is. But for me, when we look at decolonising mental health, we use many culturally safe modalities. The social and emotional, the National Strategic Framework for SUB is really important. It provides a roadmap. I want to acknowledge all the work that Brother Ian has put in to developing our model of care. 12 plus years of community yarns and connections to shape this beautiful vision. And in terms of we use these culturally safe modalities is I and the team use a lot of narrative. And for those who know narrative, there are two key positions, statement of position map 1, statement of position map 2. And the first thing we need to do is we need to identify and name the problem. Because I'll tell you what, there's a big problem. Big problem. And then we need to figure out what the effects of that problem are. And the effects for our mob are really big. And that's why we're into transformation and reauthoring the problem story to the preferred story. We need to look at Western models. For a lot of our mob don't fit. We're about justice as well as therapy and healing. As we all know, you can't medicate away the impacts of racism. You can't medicate the impacts of poverty. You can't medicate the impacts of dispossession. We need to look at these social determinants of health. We need to look at the past in order to deal with the present and the future. I might leave it there, brother.
So actually, I'll go back. So with what Rob was talking about is basically what we're trying to do is reconstruct how we do mental health and wellbeing for our own mob, for our own communities. And that's basically understanding those impacts, those intergenerational traumas, the history of centuries of colonisation, the impact of drugs and alcohol, dispossession, racism, language barriers, everything that you can think of that don't affect you, but may affect Aboriginal and Torres Strait Islander people. And that effect actually then impacts them and their family and their community through the situations that they find themselves in, but none of their fault. None of their fault. They weren't put into missions, they weren't kicked off their land, they weren't told to stop speaking their language when they went into these missions and reserves. None of their fault. But the impact that they are now having and continuously to have is seen as their fault. And so we try to develop a model or a plan to actually support them in their journey, to support them to understand that we understand that this has been an issue and continuous issue. So what can we do to support them? And the basis of the Wellbeing Centre is actually the culture. We try to really draw on the culture and its strengths, its knowledge and its traditions. We find ourselves now today with a lot of influences outside of our own, particularly our Aboriginal youth and children, child and youth, and this goes across all boards, all races. But the impact that we find ourselves in with our child and youth is that they think they've lost their way, they have lost their cultural understanding, they've lost their cultural identity. And the centre actually is trying to incorporate that or instill that, I guess, the understanding of what culture is, making them proud, basically, of being an Aboriginal and Torres Strait Islander people, understanding that their lineage goes past, 60,000 years plus. So being really proud of who they are, standing up to who they are, is a very important aspect of why this Wellbeing Centre is actually being developed. We got 20 minutes left?
5 minutes left.
So, like most things, we've got a script, but we're actually way off it at the moment.
Who needs it?
Who needs it? Just ad-lib everything. So back in 2022, and I'll go back onto this script a bit, the South Australian Government entered into a state mental health bilateral agreement with the Commonwealth. Out of that agreement, $10 million was set aside or put up to establish the Aboriginal Mental Health and Wellbeing Centre. So this didn't start in 2022. This started 10 years or 12 years before that, with a lot of discussions, a lot of community engagement. Because we talked a lot about having that co-design. We talk a lot about having Aboriginal and Torres Strait Islander understanding and having input into how a service should look like and how well it will be supported by them. And so from the early stages, and I must admit, when I first began this journey, I really struggled to see where an Aboriginal person could actually go and get well supported in their mental health and wellbeing in this state. I really struggled to work out, well, I know there is a lot of issues, where do they go? How can they be well supported? I found models in WA which I really kind of stole their model when I went and visited them. They were very supportive. I said, look, this is what I want to do in SA. They said, here's a model that you can probably base it on. I said, thank you very much. Put it in my bag. Caught the next flight out. But they were very generous. They were very generous in their knowledge, very generous in their information and sharing, and I really respected them for that. And the model that we've based our Aboriginal social and emotional wellbeing in is basically on that model, because it was a well-coordinated statewide service, which basically, and I'm going to get to my page actually, I'm going to flip all the script actually, because I think it's around emphasising the significance of Aboriginal culture and understanding. With that in mind, we did a lot of those consultations, and we did that across 5 country sites, including Mount Gambier, Port Augusta, Whyalla, Port Lincoln and the APY lands. And we did 6 metro workshops across Central Adelaide, Southern Adelaide, Northern Adelaide, Western Adelaide. We included 2 key cohorts, which was the LGBTIQ community, our rainbow community, who really struggle with their identity, who struggle with trying to get the right service for them, and our child and youth. Was a very big important part of why we wanted to develop a service. I think that over the years of rewrite, I'm up to my probably 14th version of the model of care, because unfortunately you just cannot keep on saying, okay, here's 3 versions that'll do. This is a growing document. It's always going to be changed. And I think it's important for us to adapt to the changes and the needs of our community, because the model of care aligns itself with primary health care services, GPs, allied health, etc. It's entering into MOUs with government and non-government agencies to embed better and open communication, partnerships and pathways to make sure that there is a clear, continuous pathway for our mob from an early age to the end age. And I think that's important, because we've had feedback that Aboriginal people get very disillusioned with services if they have to go from one place to the next, continuously. And I don't just mean mental health, I mean drug and alcohol, housing, education, all those so forth. I mean, no, that's no different to any other community, I think. It's no different to any other race, but it's more, I think, identified as an issue within our own community, because if they don't show up, they will never show up. So this centre is trying to make sure that they do show up, stay in the service, until they're ready to turn away and say, I don't need you anymore, but we'll always be there to make sure that they get the support that they need. I'll let you have a yarn now.
We have to make it quick, brother.
I have no idea where we are.
We're probably going to wrap it up directly. But just, I suppose, a couple of other quick things. So our interim service model was already underway. I didn't make mention that Nini has also 2 amazing partners. One is Sonda, and our other partner is Oars Community Transitions. Nini is the lead of that consortium, and we will be fully operational around March, April next year, based in Adelaide CBD. I'm happy to leave some of my business cards out the front, or jump on the Nini website and reach out to me. I'd love to have a yarn. We're about collaboration. We can't do this on our own. We're big on partnerships, informal and formal. And if you have any Aboriginal or Torres Strait Islander, we refer to our mob as guests, not clients, not consumers. They're guests. And in terms of some of that stuff, we're always learning as well. We don't have all the answers, so we want to do this together. That'll be great. I think just from me, before I hand over to Ian in closing, is, again, we're not into reinventing wheels, but we are about community leadership, and we are about Aboriginal leadership, and we're about systemic reform. It's very difficult to change systems that have been around for a very long time. And the beauty of this, and we've got the full support of SA Health, the state and Commonwealth governments, is this is innovative, this is creative, this is led by a community. And we greet our mob, we say, who you mob, where you from? That's that identity. And a lot of our mob in this SUB and mental health space, they don't know who they are. And they don't know where they're from. And they don't know what their hopes and dreams are. And they don't know that pain is actually normal, it's a part of life. And we're not into fixing all of this, we're into building the resilience of our mob. So that's some of the exciting things we're doing. Reach out to me, I'll get back to you, I always do. Not straight away, but...
He does eventually.
I do eventually.
He does eventually. So, in conclusion, and I must apologise, I've done this a few times, and every time I do it, I go totally off script. And I should never even put a PowerPoint presentation together, to be quite honest. I should just stand up here with a microphone. So, in conclusion, it's taken a long time for us to get to where we are today. We've got a strong Aboriginal NGO who are going to lead this wellbeing centre. All the pressure is now on Nini, Sonder and Oars. We've done the background work, we've done the model of care, the philosophy of care, all the structured stuff. We are hoping that the centre will be in its site in March next year. Unfortunately, due to unforeseen circumstances, they're in an interim site at the moment on South Terrace, doing a lot of outreach, and which is a good part because they're actually building the relationships they need to with agencies across the board, both metro and country. So once they do move into their established site in March next year, everything will be running. We'll have a full complement of social and emotional wellbeing staff along with the clinical staff. We'll have supported services across from clinicians, GPs, social workers, so on and so forth. Traditional healing, thank you, sorry, that's the biggest point of it too. The centre will offer traditional healing alongside mainstream supports around their wellbeing. It's important that we really reintroduce the history of traditional healers and what they actually bring to the table, because their understanding around healing from a cultural perspective actually does a lot more for them, for the individual, than any medication that they can come up with. It's important that we bring into this, I guess, narrative 60,000 years of history, because that's where the basis for our wellbeing is and lies. So the Wellbeing Centre, and being led by Rob and Sonder and Oars, have got a lot of work to do. We know that, we understand that, and the expectation from, I guess, not only within the state but across the country, being our first all-of-age mental health and wellbeing service is going to be huge. But I think they're up to the fight, and actually we will find some very good outcomes for it. So thank you very much.
Wowee. Wowee. And I'm really glad you subverted the dominant paradigm and chucked out your PowerPoint and anchored yourself back in the beautiful images of those kids as well. That was awesome. And, you know, themes, powerful themes. Consumers as guests, not consumers or patients. Guests. Wow. I mean, just the change of terminology is always powerful, isn't it? Bringing everything into the one space, not making people chop themselves up into little pieces to go into different services and travel to different places. Powerful. What can we all learn across every service about that? Connection, not correction. Yes. Pride. Yes. And also this idea that, you know, people hold on to the blame and the stigma and the shame that is not theirs to carry, but it's chucked on them, isn't it? So thank you for just upending everything with what you're doing, and I really wish you the best of success. And I love the fact that you also described it as stealing from WA when they were, you know, politely giving it to you with great enthusiasm. So can other states, if you're from other states, can you arrange a Zoom meeting with this team and find out and connect the dots with other people in your community with this team, so that you know, these models can go national but also be grounded in local understanding, local values, local history. Thank you. we would like to just... Does anyone have a burning question that they'd like to ask or a comment that they'd like to add from their own perspective? We're just running a bit behind, but I would like to hear from someone if you'd like to add a comment or a thought, just so that we get lubricated on the questions and interaction. Any thoughts? Can we continue the conversation into morning tea after the next few sessions? Yeah, great, okay. That was just fantastic, thank you. So when's launch day, just can I ask? When do you think?
Technically, the service is running at the moment as an interim.
I'll hold it.
Okay, yeah, so technically it's an interim service at the moment. Excuse me, hopefully by March next year when they move into the established site, then once the doors opens, it'll be working. It'll be happening.
And it's statewide, and where will it be?
In the city here, South Terrace, Adelaide. Yep, so we take walk-ins as well as referrals.
Oh wow, you're going to be busy.
We're busy, that's why we want a partner. We've got to do this via a shared care model and approach.
So this is a good place to be right now, today. Yeah, good. All right. Are you here throughout the day or just for a little bit of time?
Unfortunately, right now we're getting our photocopy installed and all our IT equipment, so I need to get out of the site.
The tech infrastructure. All right, so you know how to reach out, and we've got a prezzies for you. Thank you. Enjoy. Thank you. Give it up for Ian and Robert. Wow, what a morning so far. As a science journalist, I do love the stories that data tells us. I love a lot of data. Without data, we are in the dark. We know this. Yes, on PowerPoints, it can make you glaze over and want to die. But data is everything. It's power. Knowledge is power. Data is power, and it can be the driver for change. So I'm really intrigued about this next presentation, talking about whole person data in action. We're joined now by Lisa Wilton, an award-winning advanced nurse consultant. I've got that slightly mixed up. A nurse consultant in the Office of the Chief Psychiatrist with over 37 years of mental health experience. She led statewide initiatives including South Australia Health's mental health general practice shared care model of care. My God, these are big titles, aren't they? The metabolic health program, the nationally recognised clozapine training and nurse-led clinics. We've got April Symes is a data queen, I will say, Senior Business Analyst for South Australian Mental Health Clinic Program and the Office of the Chief Psychiatrist. Extensive experience in mental health and other health data sets, data warehousing, reporting tools, the whole bit. These two are a force. Let's hear from them. Welcome, Lisa and April.
Thank you. And might I add, it's always hard to follow Ian. But they did the best segue ever with needing to go and do some technical work there. So thank you very much for having us. Now, which one do I press? The green one, the green firework. Okay. Did that work? Not that one. The top green one, the one with the big green arrow on it. Yeah, that's better than the firework. Okay, of course, we'd like to acknowledge the Kaurna people and our lived experience as well. So we're here to tell you about the plan. So our presentation today is a very quick overview of the mental health operational data domain. Now, a bit of a caveat here is that we would have loved to have shown you this live, but due to confidentiality, we couldn't do that. So you have to put up with screenshots and a little bit of animation. But we're going to look at the issue that we had here in South Australia and the unique opportunity that we had to be fortunate enough to have some very talented people, April being very talented here next to me, to design, create and realise a solution to a problem that we had. But first of all, I'll just let you know about our digital landscape in South Australia. So some of these, I will use the acronyms, but let's explain first. So our Open Architecture Clinical Information System, we call it OASIS. That's our original and still utilised, the one-stop shop for blood results, location of a person, alerts, and where we generally pull the data. The issue with this one is that all the reports required are manually processed, which meant, for example, once we put our clozapine alert, which Scott showed you a little bit from that data yesterday, If someone was admitted to hospital on a Friday night and then discharged by Sunday, they didn't show up on the reports because the reports are manually run Sunday through Friday. The next one is our community-based information system, or CBIS as we call it, and that's specifically customised for SA Health use, and we have internal people who build the screens, create the reports and respond to our ever-changing reporting requirements, and it's generally Tammy and I going, can you do this? And they go, sure. And then we have our country version of that, which is our Country Consolidated Client Management Engine, or CCCME as we call it, which is the country version of CBIS. And then, of course, we have our electronic record as well. So prior to Sunrise is our inpatient services medical record. We all used CBIS for both inpatients and CCCME for inpatients and community. Now, the thing with the CBIS, CCCME and Sunrise systems is that they don't actually talk to each other. And what we actually say is CBIS has no friends. And while Sunrise can actually import some CBIS reports and services, it's limited to about 10, and they're not live. So all of these systems also have a unique identifier number. So to collate or cross-match the data, all the identifiers for a person are required to be done individually, manually, which is, of course, a really time-consuming system. So what our problem was is that we needed to define the problem that we wanted a solution to, and basically it came down to not being able to identify where people were in the system. So we had no visibility where a person was, and if a person was in an inpatient bedded service that wasn't a mental health service, then we had no idea, unless somebody actually told us, and then it was usually after the fact. So we required access to multiple systems to get the data, the Sunrise, the Oasis, and there was no one domain that could actually pull all of this information together for us. And so we weren't able to be proactive about care. So we had no ability to in-reach for offering any opportunity for collaborative care. And for things like, reminding if they were in an orthopaedic ward that they had a mental health appointment coming, or if they were in a mental health unit and they needed to go and have an outpatient appointment for some physical health thing, we had no way of knowing. So we have all these multiple systems that don't talk to each other, and it doesn't provide a complete journey for the person. Now we're going to get into the technical bit. This is where my eyes glaze over. And April comes to life, and I nod very politely, and I know April's got me covered, and she has all my data once.
Thank you. Yes, thanks, Lisa. So have we switched it already? No. Top green one, right. Yep, onto it. Okay, so this is just to show you a little bit about where we started, and it's a visual of the problem that we had and what we faced. On this screen here, you can see that at the bottom, the source systems and the manual source collection. So some of those things had to be put together by reporting teams who didn't work in the same divisions, all in separate areas, probably duplication of effort, working around to create the reports required for operational business. And then they manually produced those and emailed them to people. And then those things would be emailed on. And in their journeys, what we found is a lot of the times the data would change, which leads to a difference between reporting, and that leads to no confidence in what you're getting given in the first place. So that was where we've come from. So that gave us the opportunity to bring the data together. We don't want to be asking people, which we have been doing, to create shadow episodes in different systems to duplicate data. Well, then you end up with data integrity issues. So we were very lucky in South Australia that our Office of the Chief Medical Information Office came along at a very fortuitous time for us with a whole range of data tools that they spread across SA Health. Prior to just prior to that, when I started in SA Health in 2021, my first task was to create a business requirements document for a single source mental health data domain. I spent 12 months doing that, and at the end of that 12 months is when the Chief Medical Information Office came about with these tools. So we formalised a group. We had clinical leaders, we had the Chief Psychiatrist's Office, we had systems administrators, and we all got together to review the business requirements and make a plan moving forward. We then started to do that. This is a quick look at the build. So this is the technical side, so I'll be really quick with this. The source systems are, as Lisa mentioned, our internal systems, but we were also able to incorporate all the external data sources so that we can put these things together. So looking at data from Australian Bureau of Statistics, so for the socio-economic stats or the regional stats, the postcodes and any other AIH, Australian Institute of Health and Welfare, data sets that were relevant. So these datas would all flow in from to our data domain on a methodology which is called Data Vault 2.0, which is what is shown in this picture here. We see that the data is brought in, it's brought in raw, nothing's changed. It's staged where it's time-stamped and hash keys are applied. It's transformed, which means just adding information to the data, so that means changing a code into words that are understandable, and then having a presentation layer at the end. That is overshadowed by a system called Denodo, which manages the user access, the governance, and the auditing. And at the end of that, we then come out with a whole suite of data tables ready for reporting in Power BI. This was how long it took us. It's just a quick look at the timeline. So if we just looked straight to May 22, that was when our mental health data zone came alive. So this is what the OCMEO provided us, the Chief Medical Information Office. So the idea here was all of our divisions across SA Health doing all different bits of work, we all need to come together. So it's again, bringing us all together. So this was bringing us data people together. So everybody has a zone, and we're at the beginning of our journeys, all of us, and we're just building our domains, and we are starting to share across our divisions. So talking about things like LHNs, focusing on their data and being able to share things across LHNs and vice versa. So by March, this entire build only took 18 months, and I might say it was a team size of 1. So it can be done. It can be done. So by March 2023, we have an app auto-refreshed every morning, and it is a work in progress. It is never going to end. It's like a lot of us. That word's gone straight out of my head. All of our focuses are trying to come together. We're trying to collaborate. So that's true of us technical data people as well as you clinical guys. So by February 2024, we have a published app. This is the front page. As Lisa mentioned, we have to just show you a whole bunch of screenshots. So this is just what our front page looks at. It's bringing our data from all our sources that I mentioned before, joining the guests, and no matter where they are. So whether they have come in from inpatient, which is a Sunrise thing, ED, another Sunrise thing, or community data from our other systems. We're just going to have a quick look here. I'm just going to take you a quick look of how it sort of works together. Looking here at, I just have to look down there so I can see. Yes, this red box is showing you where the actual menu for the reports are. So you can see a whole range there. We've got emergency, starting at the top, emergency, inpatient, the actual activity in the community, referrals, a whole lot of reports around legal orders. And then we are now going to take a look at the physical health assessment report. Don't be overwhelmed. There's a lot of information on one page here. But this is what it looks like. This first page of the physical health report is just a summary. You can see at the top, we have a number of selections and filters so that we can see what we want to see. We are here looking at 2025, and we are looking at 3 selected LHNs, which have just been blanked out for the moment. We are also looking at currently open episodes only, because we've selected yes. These 3 boxes here allow us to hone in on our community teams. So if we were a team leader, we could do that. We've selected some closeting teams, I believe, in there, Lisa. And this first visual is showing you all of the percentage of episodes that have had a physical health assessment. And these are community episodes here we're talking about. So that's the result for the 3 LHNs. Oops, I nearly hit the wrong button there. And we have 1,072 in total done in this selected period for those teams, for the patients of open episodes in those teams. We can do further filtering by comorbidities up here. And we also have other filters on the demographic type filters that are available at the bottom left of the page. The top chart, as I said, is showing the percentage of all the episodes that have a recorded physical health assessment across all those teams we selected from those LHNs. The bottom one here is showing you the number of physical health assessments by team. And if this was live, I could show you that. You can just sort of hover over those and see a total for all of the teams, one by one, so you can see who's the busiest team, and teams can help each other out. Where did I say? Okay, so this chart on the table on the side is just showing numbers of a breakdown by LHN. The bottom one is down to individual clients or guests. I can easily change that name to guests if we need to. And if we could see there that a whole range of clients have had 11 assessments in this period of 2025. That's all different people. When we select cancer from the comorbidities filter at the top, you can see that everything's changed on the page. The whole page is filtered for those 3 episodes that have a comorbidity of cancer for those 3 teams in 2025. This is the next view is showing an individual person. So we could have selected one person from that list and moved over to see this individual person. So this is showing us 24 and 25 for this person. Their identified comorbidities at the top being cardiovascular and cancer. The first chart on the left is showing their blood pressure that has been recorded over this 24 and 25 period. The chart to the right, oops, I forgot to press my buttons here, sorry. The chart to the right is showing the blood pressure and, the weight and waist measurements that were recorded in that time. The next table is showing substance use that has been recorded. And then at the bottom we have a boring old data dump that looks a bit like that. So, and all these data dumps can actually be exported quite easily to Excel. So that was, where am I? Back here. To return to the summary table.
I will just say that it's a bit hard to see the PowerPoint, so...
Is it? Yeah. Oh, I'm so sorry.
Yeah. So maybe talk to the themes is going to be helpful. Yeah.
Yes, we're going to be doing, yes. I will be,
We've got 2 minutes.
So, okay, sure. Yes, heading back to the summary table. So if you prefer to see all those visuals that I was showing before, we also have the ability to just see it in a table like so. If that's, some people don't like the visuals, so we're trying to cater to anybody. Okay. We can extract all data that is feeding this summary page in one go by hitting that data table button at the top right. And again, it just gives you a boring data dump, but some people take advantage of that and use those things. So I'll hand back to Lisa to focus in.
She's taken my script.
Oh, no.
So this one here, this is the bit I really like, because we can actually see individual data showing a person's journey with the service over time from their inpatient to community. So we can actually see here where we've actually got where the high peak size generally reflects inpatient or intensive service, and then if there's some low ones, the troughs, this is around 18 months, and it's around a community stay. So we can actually see a picture over time for the intensity of a person and what services they require. And you can get pretty fancy with it, with that list on the side. You can actually, if you want to see just exactly how many case conferences that we've done, you can just click on that and it will show you that data. So there's lots more clickable things on there. Now this is where we actually got using the Australian Institute Health Welfare Code, as April said before, that's already been built in, but we were able to pull this data of the vaccine potentially preventable hospitalisations and use this in our ATAGI presentation there. So we can see here that view shows total vaccine preventable admissions across general and mental health, and we can actually have a look to see if the person is in mental health services, and then right down to how many specifically for all preventable hospitalisations, and then into vaccination alone. What happened there? There we go. And this was pneumonia and influenza here. From the previous slide, from there, we can also, this is unique, we've not been able to do this before, so we can actually see when a person's GP status has been updated. So this is where we can actually identify an individual person and their last confirmed acknowledgement that the GP is their current practice, because often we have a list of GPs and the person might not have seen them for years. So this gives us that as well. So, impossible to the possible. We've actually come a really long way with it, with all our disparate systems being collated into one, which is really useful. But we've still got a long way to go on that. And of course, it takes dedicated time, and like April's a team of one there at the moment, but there's so many people to thank. Information Performance Monitoring and Measurement Unit, colloquially we call them the CBIS team, April of course, Liz Prowse, our Director for Mental Health Strategy Planning, John, our Chief Psychiatrist, and of course OCMEO for the tools.
Thank you so much. This is just such a powerful project, and I can't believe you were the staff member of one pulling all this together. That is phenomenal. How are you still upright? But what a powerful piece of work that you're doing together and as a team, but also individually in your case. I will just ask, because I know it's always a concern with data, questions of data sovereignty and questions of data privacy. When government agencies have big data sets like this, and you can see yourself, in that data set as an individual being mapped and tracked, and, it's both very powerful from a service provider's point of view, but what are you doing to ensure, data sovereignty and data privacy?
Yes, well,
the mic, yeah.
Sorry. Yes, for the privacy and both really, where we on the technical side have a system called Denodo that sits over all of our data. So every time that's touched, this is all cloud-based stuff. So anybody touching any piece of data is recorded within our auditable system. So everything is backwardly auditable,
Yeah.
and everything is traceable and trackable. Because I've used the methodology that I mentioned, Data Vault 2.0, you are able to backtrack and right to source.
And if I was a guest of a service, I love that I just love that. Tell me what impact this sort of data set and this collation of data, this representation of data, how it could serve me, just in my journey.
Actually, when we use the whole data set, it stops you having to tell your story so many times. We can actually see where people have been. It helps us to actually in-reach and support the person better, because, you know, if we know they've got an OPD appointment for a physical health issue, we can actually in-reach for them to that. Do you need some support to actually get there? It's not that we're blindsided, that we had no idea. More often, and South Australian clinicians, correct me if I'm wrong here, but we have people within our service and we've got no idea that they're working with the renal team or something until, you know, it's just a happenstance conversation or something.
Yeah.
This actually brings it together so we can collaborate a lot better.
A question from Josie: integrating many systems into one is a monumental effort to achieve in 18 months. I'm curious to know more about strategies you use to build buy-in across your organisation levels. In particular, we often hear that time and resourcing is a barrier. How did you mitigate this? Go on.
That's for you.
And we'll just keep it brief, thanks. Because the conversation can continue at morning tea as well.
I think just being very open and accessible, and just giving people the ability, the easy way to provide their feedback, ask their questions, and also being really available to in early stages of people using this data, because a lot of people have come from just a straight spreadsheet. So that sort of, our team has been very open to people coming at any time.
Yeah, great.
In and just having that hand-holding. And I can say...
Hand-holding.
Yeah, that I could say from experience, it's just a one-time thing. And my biggest, one of my proudest things that I did in New South Wales was bring, in my previous experience, was bring the Aboriginal health team of New South Wales, in southern New South Wales, had no reporting ability, and they ended up being the first champions of the data
there you
domain
go.
built there.
Yeah, fantastic.
So,
Congratulations, and I hope that, I mean, we're a federation, but can we work together across states in models
lovely.
like this? Can we?
I'd love it.
Yeah, well, hopefully in this room this conversation might be initiated, because one state can be a leader and the other states can be learners and become leaders in their own right, in their own context, and their own data sets and their own systems and their own silos. Thank you very much. Congratulations to Lisa and April. Great. Wow, that's fantastic. And look, and from the Office of the Chief Psychiatrist, I might add, and South Australia Health. And what we heard there was the power of communication. So, you know, keeping the communications going throughout the development of a platform like this and an integration process like this, and to consider the power of communication. She's already there. There you go. And collective communication for change is Victoria Erskine, lecturer in communication at Charles Sturt University, communication lead with Equally Well. She's been wonderful to work with today and yesterday. With a background in strategic communication and journalism, she survived. She's doing a PhD with Equally Well. She's determined to survive that as well. And her work explores how communication can shape social change. Yes, that's what I'm into too. And be a catalyst for collaboration and connection. Yes. And most importantly, what's at stake when communities fail to prioritise effective communication, because a whole lot can collapse. Please welcome Victoria.
Thanks so much for that great introduction, and thank you so much for allowing me to be here and part of your community. I'm not someone with a mental health professional background or experience in that area, so I'm a little bit of a fish out of water, but I wanted to say how grateful I am to feel part of this community and acknowledge the insights that I share represent you, every one of you, and all the different diverse perspectives you come from, and the generosity and openness of people in sharing their experiences about communication that's helping shape the foundation of the work that we're doing. So in this presentation, I'm going to ask you to consider the role communication plays in social change, to ask the question, how are we doing so far? So this is a reflective presentation. Essentially, you're going to pose some questions, share some insights, and hopefully leave you with some thought starters to take back to your own sphere of equally well influence, wherever that is. Communication, in my world and from where I come from with my background, is a less understood element of what I'm discovering about the collective impact model, the model on which Equally Well is based. So from the view of a communication professional and a researcher, this presentation outlines some of the invisible factors that influence, change, and make things happen to build genuine collaborative relationships based on trust. So from that starting point, I'd like to quickly ask a question. Show of hands, who in this room has communication in their job title? And I know there's at least a handful of you here. So that would be about, I'm going to guess, about 5 people. Who would consider communication a critical function of their job or their role? Hello. Exactly. So I'm aware that this is a really diverse and multidisciplinary audience. But I truly believe and think there is something for everyone in what we're going to be sharing today. I would like to acknowledge that I'm standing here in front of you doing something completely out of my comfort zone in the mental health space, thanks to the guidance and support of Russell Roberts, and a serendipitous conversation in the cafe of the Bathurst campus of Charles Sturt University about 4.5 years ago. So I was on a path to research communication and resilience in professional communication practice, because I, as a practitioner, had faced monumental change and shifts in technology that was impacting my world and inevitably the world of the students that I'd be teaching to go out and be communication professionals. So that rocked me enough to go into that sphere. And then Russell tapped me on the shoulder and suggested that my skills might make a valuable contribution to the Equally Well project, just at the right time when I happened to be looking for a supervisor to start my PhD journey. So thank you, Russell, for that confidence building, and it has been a world shifting, not to quote Shannon, a monumental shift in me to be able to be part of this project. So this is a presentation that doesn't really discuss outputs. It's not about marketing, social media posts, websites, newsletters, or even podcasts, all some of my favourite things in life. But that's where a lot of the effort is put in communication, and yet where the least impact is found. I'll unpack that as we go along. So communication is subjective and open to interpretation, but we all know when it works. We all know when it looks good and feels good. And we all know when it misses the mark, or even worse, causes harm. So I consider the role that communication plays in social change to ask us all to consider, how are we doing? With the best of intentions, the formal signing of consensus statements and the opening up of new spaces to connect, not all connections are created equally. So in terms of communication, we're operating in a social context that can't be ignored. Lack of trust in organisations, media, government, traditional institutions, what's been described by social researchers as polycrisis. That's the multiplicity impact on society of crises like climate change, the implementation of AI, housing affordability, financial disparity, world conflict, need I go on. So, and AI in itself and the tech disruption is blowing up everything we know about how communication functions. So with that context, I'd like you to consider where you sit in the sphere of the Equally Well network, My background and strength is in organisational communication, but what's really special about this community is the collective impact model is founded on dismantling traditional hierarchical structures of what organisations are. So from a communicator's perspective, it's a fascinating place to play because we get to challenge the notions of what are power and equity and how communication influences those fundamentals. So a few questions posed here for you. Have you ever considered, and I have to fix my glasses, thank you too, had an experience where you didn't feel heard in a conversation? Have you ever worked for someone in a professional or in a volunteer capacity where people are great at telling people, well, your leader might be great at telling people what they need, but not actually very good at demonstrating what that looks like? Or worked in a team where things seem to go round and round in circles and you hit a hurdle and never really get where you wanted to go or where you thought you were starting with in the first place? Or you've had to collaborate with people outside of your sphere of influence or your comfort zone or your organisation and felt there was a communication breakdown, but you didn't know where to begin to help alleviate that. This is something that is all too common in any situation, but amplified when you've got a complex environment with multidisciplinary stakeholders all working towards the same challenge. So just a little reflection on what is collective impact. Russell touched on this yesterday and explained it beautifully. So this model has come out of the community development sector. Some of you in the room will be very familiar with that. But it essentially is really taking off, particularly in North America, but very popular in Australian contexts as well, thinking about environmental challenges. I know a lot of First Nations community projects are based on the collective impact model because it's very much in synergy with that way of knowledge development. So in collective impact, it's highly popular. The original article by social researchers Kania and Kramer has been downloaded from the Stanford Innovation Review over 1 million times. But when I started to look at this model, which I had never heard of until about 4.5 years ago, I was zeroing in on what is this element called continuous communication. To me, as a communicator, that is anxiety-inducing in the least and frightening at the other end of the spectrum because that sounds like bombardment. It sounds like over-information and we're all suffering from that. So I looked at the research, I did a deep dive and tried to unpack how to define continuous communication and what does that mean in terms of collective impact. So what I found and discovered in that search was that there wasn't a really known and adopted definition of continuous communication and collective impact. In fact, there was a lack of evidence of how communication functions, although the intention of what it should look like was there in the research. So for me, that was a gap that I could enter into and explore. So the literature quickly looked at broad themes like being effective, building trust, adaptability to change, and being collaborative. And the other key element is that it really focused on what backbone teams could deliver. And the backbone teams, I'm not sure, just to quickly recap, essentially Equally Well project team is the backbone team. So it's a very small, part-time, half-resourced kind of work team of collaborative people that enables all the work that everyone else is doing to create a space for the work that you're doing to be amplified. But essentially, I felt that as a backbone team, that's a lot of responsibility to have in terms of being, having that power to, that influence to communicate on behalf of the whole collective. So in short, communication is everybody's business, and so it's the opportunity there is to explore how do we build capacity and confidence in others to do the work collectively. Okay, so what I found is that continuous communication is often referred to as the condition for mobilising stakeholders, but when you're working in a complex environment with multidisciplinary roles and positions, how do individuals and organisations within those networks, whilst they agree on change, how do they agree? How do they know how they're going to get there effectively? Especially when communication is often one of the least resourced elements of projects. And I found with my research so far that that happens across the board in health services, mental health services, in researchers, in clinical practice, in education. You often find that as a common denominator amongst the challenges of amplifying impact without the resources to deliver it. So when we talk about the term continuous, how much is too much? And that is the entry point for this work. So what I'm really looking to explore are these concepts about how does communication support trust and engagement and genuine community engagement. And I'm looking at this intersection between interpersonal communication, how we relate to one another as individuals, organisational communication, how you come into your professional sphere of influence from whichever lens that might be as in your roles within the network, and then broadly how we operate on that bigger strategic lens as the movement for, in this case, equally well. And I'm testing new communication nerding out. I'm following on the lead of communication scholars before me that have already been exploring how we create meaning and shared meaning through communication, and looking at building a new theoretical framework about effective communication in cross-sector collaboration. So to the fun part, the data collection. So as I'm adopting a methodology for those qualitative research nerds in the room called constructivist grounded theory, which allows me a whole lot of flexibility in collecting data. So one of the fun parts of my project so far has been that it allows me to go in and out of data collection and really open up not only conversations, but use materials that we might produce in Equally Well, like the call to action experience. It allows me the opportunity to have conversations with people in a room like this and take your feedback and collaborate it into my data collection. And it allows me to be an observer, a participant and a practitioner in the research process. So podcast conversations, the call to action, all of those examples have allowed me to go in and out of this work and do my analysis to try and help synthesise what are those crucial elements of continuous communication that are really going to help drive and change, improve social change moving forward. So next, this is some of the findings that are emerging from my data, and I just might say I'm in deep diving. I've taken a small break to attend and help support this conference to get out of my in vivo all my transcripts, but I'm really doing a deep dive into the participants. So I've done 32 interviews with practitioners from Equally Well Network in Australia, New Zealand, the UK, and a couple from Canada, actually. And the opportunity, some of the people who participated in that research are in this room. And I'm so grateful for the insights that they shared, because they're really rich experiences about what they think are successful ingredients in terms of communication, and what are the barriers to effective communication. And these are just some of the quotes that came out of that work. So early findings are demonstrating, after going out of my, and sorry, I just want to clarify, going out of my echo chamber means that just like you, most of my participants do not identify as communication professionals. In fact, I think there was 1 or 2 out of 32. So I wasn't preaching to the converted, I wasn't speaking to my peeps, echoing my own thoughts and ideas about communication. I was really interested in what those who don't call themselves communication or don't identify, even if they operate in that space, really felt were effective ingredients in communication in collective impact. So broadly, and these are, I apologise for the size of that font, essentially communication needs to be shared and is a shared role and responsibility of everyone. It's often ad hoc and misunderstood. Excuse me, and that's my glasses again. There's not enough attention paid to divergent ways in which communication operates in organisation and social change contexts. It needs to be shared and have that common language, and I have heard that so many times in the last 24 hours, it's reiterating that for me. We need to invest in, there's an overinvestment in personality over processes. So you don't have to be the largest voice in the room to have your voice heard, especially not in collective impact. And intention and purpose needs to be clear at every stage of every project. So when I synthesise the work to date so far, what I'm looking at is potentially considering what the impact is in terms of social change when people are technically or metaphorically bringing their communication unchecked baggage into spheres of influence that they're trying to collaborate with, particularly in terms of complex social change contexts. So when I popped some of my data thoughts, and not the raw data just for ethical transparency, some of the analysis I'm doing into Napkin AI, because I'm a words person, not a graphics specialist, as you've probably just already noticed. This is what it spat out at me, which is an iceberg model, and many of you will be familiar with that. This work is trying to shine a light on invisible factors of communication that are often overlooked. So when Napkin put in my data and Napkin spat out this iceberg, it spoke everything to me about the purpose of this work. So what organisations and I will say social change movements and the organisations that they represent often spend a lot of time at the top with outputs. So it's all about messaging and content and spraying people with information, and less about what's actually happening with the relationships and the elements of trust that continue that important work. So I'm suggesting so far 3 core concepts are coming out of this work. The first, to unpack it, is that for individuals and organisations and the collective, we need to commit to communication competence. So that's communication strategy and planning, maybe the skill set of a small team of professionals, but it's a lot of weight to carry on solving the big issues. But the responsibility for good communication is everyone's business, and communication competence is being assumed as participants join into these experiences, and that is potentially creating some challenges in terms of where everybody is intending to go together. In terms of clarity, there's confusion over language about what is being said, why are people being called to a meeting, or even what is the shared purpose. And it can really turn people off. So maybe asking the question, have I checked? Have I been clear in my communication today? Am I able to adapt to a diverse audience and make a real connection? Am I communicating for understanding or to be understood? And in terms of confidence, I really wanted to hone on this one in particular, because in collective impact work, not all voices are equal. And this work aims to address some of the inequalities that have landed us in this issue in the first place. Not to oversimplify it, and there's my timer, I've got one more slide, that communication breakdown is often where what lands us in the challenges that we're seeing in terms of some of the issues we've been discussing over the last few days. So communication confidence isn't just being the loudest person in the room or the sage on the stage, but it's how you listen and create safe spaces for everyone. Okay, so where to from here? Discussion, what can we do? Number 1, and I'm going to be sacked if I don't say this, fact sheets are on the registration table at the front office. We have a lot of resources we want to share with you in terms of the Equally Well movement, and we would love to have your resources as well and keep collaborating and sharing. But please take some fact sheets on the data that Russell shared with you yesterday with you today. Distribute them in your communities, in your staff rooms, in your schools, at your dinner table with your family, if you wish. Anywhere that you can spread the message of what we're sharing today would be really valuable. So hard evidence and good intentions and willing participation are not enough. As the collective operates against this social backdrop of distrust in organisations and the media, while people are being overwhelmed for information, we really need to understand how to make better connections and build trusted relationships. So as individuals, be self-aware and reflexive about communication. Be proactive and help others to build skills and capacity. As an organisation, be aware of the communication culture that you're nurturing in your organisation, and when you go to collaborate with other organisations, how you bring that culture with you of supportive, inclusive conversations. As a collective, role model what great communication and connection looks like, and make the time to invest in relationships. And on that note, huge congratulations to all of you for being here in person for 2 whole days, if you're able to contribute that time, because you're living the collective action, the communication, collective communication, continuous communication collective in action here today. So thank you for showing up, thank you for listening, and thank you for sharing your stories.
Fantastic. Thank you so much, Victoria. Any questions or comments?
And before I leave, the other big important message I had to get out there, you're almost lost. We would love to have you formally and informally be part of the Equally Well movement. So if you wish to join, if you haven't already, please pledge your support. You can follow the QR code. There's a link also on our website, and we would love to have you join in any capacity that you wish.
So what's
if you
the link
haven't
on the
already.
website point people to?
That points people to become a supporter.
Okay, become a supporter.
Become a supporter. Physically support the cause.
Great.
Thank you.
Any questions or comments? Yes. John.
Thank you very much, Victoria. It's fantastic to see that work. I just want to ask you 2 questions. What do you reckon for this organisation? What's the one thing we should do more of, and what's the one thing we should do less of, based on your observations of what we're about?
No pressure.
Yeah, gosh, thanks, John.
Excellent question.
Yeah, no, great.
Be frank, be fearless.
We should do more of this. We should do more investment in the opportunities to build genuine collaborative relationships. We should do more work in having real, meaningful conversations. We should do, which is already happening, but amplify the connections and turn down the content. I think we're all overwhelmed by information on every level, and I think there's been an opportunity for us to, we don't have a lot of dollars, so this is not a big budget marketing operation, so we don't have the luxury of running national ad campaigns about this yet, but maybe a conversation we have somewhere along the lines might end up investing at that. So I think that would be my focus, I would suggest.
And less of?
And less of worrying about, less of creating, not paying attention to the communication in the sphere of influence we have. So I'm not saying less of, okay, that's a bit of a, I've flipped that, haven't I? Less just walking through communication landmines. Less bringing your baggage, not in a personal sense.
Give me an example.
Yeah.
What's a communication landmine?
Yeah, so when we enter a Zoom webinar and everybody's coming from all different spaces, make some time and space to connect before we get started.
Yeah.
Slow down is probably, slow down and make those connections really genuine. Safety and inclusion was a huge part of the research, the voices coming through. There was over half of the 32 participants had a lived experience in my work, so having safe spaces. So less of assuming that people have all the skills they need to be confident and competent communicators, and a little bit more listening is probably what I'd say.
But also, don't you think that it's, people are pretty zoomed out, so, and meetinged out and all of it. So isn't it also about, okay, what do we really need to meet over here, and how can we make this a genuine engagement?
Clear on purpose, clear on who's in the room, and also invest in the communication skill development of your whole team. Not just defaulting to the comms experts, but where do people need that? Meeting people where they need in terms of communication skill development is probably something I would say.
We just don't really learn how to, we kind of stumble into learning how to communicate with each other through our family relationships, and we know what they're like sometimes. Yeah, exactly. Pretty crap. And a lot of trauma and baggage and legacy issues, and so we kind of emerge out of those into our 20s. We kind of stumble into share houses if we're lucky. Well, my generation did, and then we land in a workplace and we sort of, like it's kind of, as someone said on your slide, I don't think we ever acknowledge communication as a thing. It just is kind of there. And I would say it's pretty much the only thing that matters.
Well, stole the words right out of my mouth.
Yeah. Thank you so much. And we've got a little prezi for you. From your team. Did you put the things in the bag? No. I think there's some excellent food in there, which is great. Well, look, absolutely fantastic. We've got morning tea, which I reckon you're probably, really ready for a cuppa. If you're online, thank you so much for joining in on the live stream. Please just go and have a loo break and a cuppa and come back and join us after morning tea, which will be at 11:15. Let me just check. So about what time? Just time-wise, 11:10. Why don't we make it 11:15? We come back in for after morning tea. I just want to also say, if I say these words, a bag about this size with seashells on it. Does a hand go up in the room? Yes, we have it. Rego, just check in with the Rego, just registration desk so they know. Also, this is your chance now to book in to share a story. Remember what I was saying earlier about sharing a story? I won't go on, but we really do want a diverse representation of stories. And even if you're thinking, I don't really have anything to share, just have a think of what you could share from where you sit in this community and go to the Rego desk and book up to do that at lunchtime. Book a time in so that they can get you. If you're up for doing that. Enjoy your morning tea. Catch you later. They're yours. Yes. Did I not get them to you? No, too much. I need really probably someone else to be doing that. I can't really do it. Yeah, sorry. Right.
One, two. 1, 2. 1, 2.
party pies and are feeling refreshed for our first panel of the day. We're ready to rock. Thank you for the comments and conversations coming in on the WhatsApp. Really do keep that coming, because I'll keep an eye on that for your questions as well, especially if we are running a bit over. Then it allows me to kind of have some questions up my sleeve. I'd love you to ask questions there, so yeah, really actively engage there. Dave Peters is just such a gift. Yeah, I just love the way that you give of yourself in this community as a leader. And if you're not on the WhatsApp, Dave's feedback to Natalia, who was our exercise physiologist, who has just left for the afternoon but has been here for the last 2 days. Thank you so much for helping guide us through some stretching and connecting to our bodies. We had a great chat yesterday, but your body connection exercise that you just ran through was amazing. I'm living with chronic pain since I was a teen, which eventually got so bad after a workplace injury in 2005 I couldn't work and ultimately lost the will to live. Your exercise that we just ran through is a fantastic reminder to me to connect, to continue to connect to my body, feel my feelings, notice the sensations. I spent over 20 years desperately trying to distance myself from bodily sensations. Who's done that? And since I started working with an exercise physiologist, I found it really hard to be aware of my body, change my habit of disassociating from body sensations. And I guess the Equally Well story and this conference and network is all about anchoring back into body in many ways, isn't it? So thanks, Dave. I thought that was just a great comment and I really relate to it. So, and I'm sure we all do. Just even sitting on the stage in front of you all after 3 weeks of not exercising properly because I've been a bit too busy, after a year of really trying to do, quite a bit of exercise, everything's stiff again. It's amazing how quick, isn't it, that you kind of start curling back up into your pretzel form, especially at this life stage. Women, non-binary people, who relates to this particular life stage that we're in? And in fact, I was thinking the NEMI tool, what I'd love to see there is some questions around the perimenopausal, menopausal phase. I thought that would be really powerful because, whoa, that's a huge phase for many of us, and especially if you've had an experience of trauma or mental ill health at different times of your life. The loss of estrogen from your body is wild. Anyway, on that note, I just thought that was important. Engaging with communities, and it's not that funny, but we all have to laugh, don't we? Engaging with communities. John Allen is joining us now to introduce his configuration of speakers, which has evolved slightly from the program. And John is Associate Professor, former Executive Director of Mental Health, Alcohol and Other Drugs Branch with Queensland Health, was Chief Psychiatrist in Queensland and New South Wales. And what I love about John is that he could continue to exist in a particular type of silo, and he has actively chosen throughout his career to not do that and to be part of a wide and evolving intersectional community. So thanks to John for his leadership.
Thank you very much, and I'm now officially retired from all those jobs, so I can do even worse things. That's great. So thank you. We're going to just move track a bit now. We're going to talk about some of those governance things and what we can get out of governance. And we've got some people representing the various commissions to talk to us about that. And we have 4 people to do that. One of the things is that all commissions throughout Australia are about different, so they all do different things. So I'm going to ask them all to do 3 questions. The first question is going to be, what does your commission do? That's 1 minute. What is your commission doing now to advance the physical health of people with mental illness, all the Equally Well agenda? That's 2 minutes. And then what would you like to do in the future, all right? So that all adds up to quite a number of minutes, and that's another 2 minutes. We're going to go through them. We're not going to do each of those questions at once. We're going to do the first couple. But I want them to be quick. That's why I'm just saying this now, because otherwise... Because we want to get to your discussions and the audience's view about what you think they might do as well, and to comment on what they say they're going to do as to what you think about its effectiveness. And, be a constructive critic, because when you're in these jobs, and I know I've worked with many of these people very well over like 20 and 30 years, it is really important that we get the feedback, and that's what Equally Well is about. So that's what we're going to do. So here's our panel, all right? So first up, we've got a ring in, so we'll leave her. The next, no, we won't. So Catherine Lowry is a former New South Wales Mental Health Commissioner. She was there for 7 years and just recently retired from that job, and now actually does some part-time work for Equally Well. She and I were used to work in New South Wales Health together, looking out, building guidelines. And we used to go around and convince services to take seclusion rooms out of their plans. So we've got a great lifetime in human rights, right? Maureen Lewis is the Western Australian Mental Health Commissioner, and she's been there since 2023. But she told me in confession that she's one of the people whose names are in that document about Equally Well, and she was there at the start with us and Russell and others, and worked in the Mental Health Commission there, and I worked with her in New South Wales Health as well, and various things. So she's got a great track record of that mental health reform. Deb Pratt, who I've also worked with in the Queensland Mental Health Commission, almost 30 years experience in influencing social change. She's a social worker. She's been involved in all those policy things around promotion, prevention, reform, addressing social determinants, service change, everything that, and she'll talk about that. And then at the end, we have Philip Chabrel, who's from the South Australian Mental Health Commission, and he's the lived experience and governance leader in the mental health and community and wellbeing. And he works on engagement, participation, social change, but he's also got a great background in various senior roles around the place, around psychosocial services, psychosocial support, crisis support, suicide prevention and so on, before joining the Commission about 6 months or a few months ago. Is that right?
Yes, that's right.
Yeah, a few months ago. So he asked us to take him easy because he might not know everything, but we expect actually if you come from outside you'll know a lot because you're not inculcated in the nonsense that we're all in. So I'm going to go to this first question, which is, can you please explain what your commission does? You've got 1 minute to that, and then just follow on from that with 2 minutes about what is your commission doing to get us started. I'm going to start with Maureen.
Thanks.
Yeah.
Thank you, John. So what does my commission do? So the West Australian Commission is different to all other commissions in across Australia. We hold the funds for mental health, drug and alcohol across the entire state of Western Australia. We design the policy strategy in terms of drug and alcohol and mental health across the whole commission. And we're also host our big lived experience team, and we are the voice of the sector, voice of lived experience as well for Western Australia, with our amazing lived experience leaders across Western Australia. It's a huge job. We have $1.6 billion in terms of how we commit our funds, and there'll be no surprise to many of you here that at least $1 billion of that goes directly to public mental health services, so inpatient beds as well as community. We've got a brand new strategy about to be launched where you'll see the public mental health bit, which is super important, isn't what the strategy is all about. It's not about always more beds, more doctors, more nurses. We're really looking to have a shift into community-based services. We've got 600 million worth already, but we're looking to really shift that dial, early intervention, prevention, rather than building more and more of the same. So that's our new strategy, and we're hoping to get traction from government. It launches in December, hopefully this year. So very much looking forward to that and our new direction as well. We've got also suicide prevention framework we're about to launch. We just launched our eating disorders framework last year, and we're framework. But the frameworks are all great, aren't they? It's really about actually delivering on them, not having this beautiful document that you often see sits on the shelf. For us, with our new strategy, there'll be an annual implementation plan which we'll report and measure against and make sure we have delivered on what we said we would in that year. So really about holding the system to account. It's tricky because we're purchasing the services, but we actually don't deliver them. So it's trying to get that traction from a governance perspective, but we're not operational. We can't tell people what to do. Only through our contracting and procurement measures can we add those things in.
Thank you. Deb, we might move to you about the Queensland Commission.
Thank you, John. So yes, the Queensland Mental Health Commission is a bit different from the Western Australian Commission.
We haven't got any noise.
I think you have to press it. Oh, do I have to press the button? Oh, look at that. How's that?
That's good.
All
That's
right,
great.
excellent. First fail. The Queensland Mental Health Commission is different from the Western Australian Commission. We don't fund services. We don't hold money for mental health service delivery. We have a system reform focus across mental ill health, alcohol and other drugs concerns and suicide prevention. We also have a role in building the mental health and wellbeing of all Queenslanders, so it's a really broad remit, as is other commissions as well. So we do that by, one of our roles is to lead the development of a whole of Queensland Government strategic plan, mental health strategic plan. That's called Shifting Minds. We also have sub-plans under that, so we've got an alcohol and other drugs sub-plan, suicide prevention sub-plan, and a trauma strategy as well. So our role is to lead the development of that and then support the implementation of it and look at the accountability for that. So supporting implementation, but also monitoring progress and reporting on outcomes. We've also recently got some money through a recent inquiry in Queensland and some funding to do some extra things, so focused around lived living experience workforce development. We've also got some funding around leading the development of a public awareness anti-stigma campaign, some work around mental health and wellbeing investment. So lots of various things. The other thing that we do is we've recently, over the last couple of years, kind of taken holding the charge of the Queensland Suicide Register. So now that that's sitting with the Commission, we're really looking at how can we really maximise the impact of having that data and making it more useful in real time for people as well. Shall I stop it there? I think that's what the Commission does. Really.
Yeah, that's your 1 minute so far.
So many things.
And in the physical health space?
And in the physical health space, well, I guess we're not doing anything specifically. However, we make sure that consideration of physical health is really infused across all things. So it's in Shifting Minds, so we've made sure that it's connected there so that there's an action around improving the physical health of people with mental health conditions. In the mental health and wellbeing space, we're really focusing on including physical health as a component of that. And I guess we work with other government agencies and across non-government agencies as well to try to elevate that in every different way that we can.
Great, thank you. And we might move on to South Australian Philip.
Is this working? It is. So yes, as per the introduction, I've not been with the Commission for a long time, so my perspectives perhaps maybe in the next section might be a little bit broader in terms of what I think we could do. Our Commission, gee, it'd be great to be WA, wouldn't it? We have, we're very, very small. We're nested within preventative health. Currently Tammy Allen is our Mental Health Commissioner, and I'm sitting in for her. She's overseas at the E-Mental Health Conference at the moment, and myself. So there's the couple of us. And we have just a shade less than 1% of WA's budget. So yeah, we're the little commission that could.
I'll send you a donation.
We'll take it. Look, a lot of our role is around communicating, around listening and connecting. So a lot of Tammy's work is getting out, meeting people, coming up with ideas, but also drawing out that lived and living experience from a consumer perspective around their engagement with services, bringing that back into the Commission and advising the Minister. It's also around providing connections within the sector and cross services and finding links where they wouldn't perhaps naturally occur. And one of those areas that we're doing that is with an initiative we're standing up called Tall Trees. And that's a whole of community approach to the dismantling of stigma and discrimination. And that allows us to bring in emergency services, NGOs, local government, people from all walks of life. It's a whole of community approach. So we're looking at reaching out to hairdressers and bartenders and whomever wants to be involved in the program from that lived experience perspective, to work on projects to dismantle.
Getting people everywhere to be part of it.
Yeah.
Thank you. Thank you, Philip. Just to let you know that we did originally have Jacqueline Gibson from the Mental Health and Wellbeing Commission in Victoria, who unfortunately had to pull out. And the reason I'm going to Kath last is she only just got volunteered 10 minutes ago to do this, so I want to let her collect her thoughts first. But I might head to Kath and talk about New South Wales.
Thanks, John. And, Victoria, this is, communication 101, how to answer and look professional when you've had 5 seconds to prepare. So thanks. Look, the New South Wales Mental Health Commission is established under legislation, and the role of the New South Wales Commission is to improve the mental health and wellbeing of everyone in New South Wales. So it takes that whole wellbeing, that whole community approach. It does that by doing 3 key things. One is reporting, and then monitoring, and then advocating for reform. So very much about doing collaborative, collective work on reviews of particular services. We've developed, the Commission has developed a suicide prevention framework. And in New South Wales, for those of you who may know, New South Wales now has new suicide prevention legislation, such as South Australia. And the Commission has now been tasked to oversight the rollout of the suicide prevention framework. That's a new role that they've been given, which is fantastic, because part of that framework has been a whole of health approach as the kind of bi-directional relationship with suicide risk and that whole of health, mental health relationship. The other thing that is in the Commission's legislation in that whole of person approach is physical health. The things that the Commission has done in regards, we've worked and supported equally well on a number of projects. We've also supported the work of Jackie Curtis and her team in keeping body in mind, and one of the things that I always love to plug, and I will continue to do so, which is the Commission received about 4 years ago a Commonwealth grant to do a health literacy project. And the reason that I always want to talk about that is because obviously we've spoken about health literacy here, we've spoken about the health literacy of people and of the workplace, and that's exactly what this project was all about. It was a Commonwealth grant for New South Wales, New South Wales won, and it was now with the Commonwealth, and I always like to pester them about what have they done with it. But the key thing is about really understanding, and it was a very hugely consultative process. It included every single PHN in New South Wales, every local health network bar one, and the community managed sector and the lived experience sector. So it was a totally collaborative process, which meant that the health literacy could be understood by people who were not mental health clinicians, but having people come into their service who did have mental health issues, and vice versa. Mental health clinicians are better understanding physical health. And I think, there are a lot of these little things that we do that we collaboratively bring together. And I don't know whether Equally Well has a link to that on their website, but I just think health literacy is something that's been echoed here quite a lot, and I think absolutely it's quite a fundamental thing in how we need to lift that gaze off the prescription pad, right into those person's eyes, and to really understand and listen to what is important to them in their physical health and their mental health.
I remember we presented that really well at the conference in Sydney a couple of conferences ago, but we'll check the website that it's still there. So I'm going to move on now to my next question. It is short and sharp. Just keeping in, what I've asked them to do is keeping in mind the issue of physical health, people with mental illness, and the Equally Well agenda. What are the things that are in the system that are ripe for service enhancement? So what are the things that you would like to do that are hot on the press from the Commission's point of view to enhance that area in physical health? So I'll start with Maureen.
Thank you. So I did mention, obviously, the launch of our new strategy shortly. So it will be a key feature in our new strategy about physical health. Often gets ignored in strategies. So we'll make sure that that's a key feature in there. We've also just developed a brand new outcomes measurement framework to monitor the implementation of our new strategy. And again, physical health is a key domain in that area. So we'll actually start to tangibly be able to measure those things. We've also launched a vision early this year around, it's called CETA. It's not a bad document actually, but in terms it's about community treatment and emergency response and community support services, and it's how we're going to link all up together. So the person who's travelling in and out of different services, we've got a linkage with general health, physical health, and also for NGOs and all the services. So hopefully there'll be better communications between all of those services in terms of integration. These are strategies at the moment, so it's all gunner at the moment, but it's our vision to connect all those things up. We advocate very strongly to our ministers. I've got 2 ministers, so Minister for Health and Mental Health, and then we've also got a brand new preventative health minister, which gives us a great opportunity in Western Australia to be able to get in terms of a physical health perspective, in terms of how we can work very closely there as well. So there's a fair bit going on. The other thing I'll say for our Aboriginal communities in Western Australia, we work very closely. Our model is the social emotional wellbeing model, which of course physical health is at the heart as well as everything else of that as well. It's about everything, the whole being. So that's our preferred model. We've got 6 or 7 pilot sites across Western Australia, and we'll choose to grow them as well. So really that's where we're at the moment. There's always a lot more we can do as well. But we're hoping, we've just had a reset. We're all new and we're starting again, and it's really about trying to head in the direction to make sure all of these things are important. But as others have said, I was one of the founders along with Russell and others of Equally Well, stole it from our friends across the ditch in New Zealand. They were very happily let us use the name. And so it's very much front of mind. The other last little bit, which is critical actually, is the commissioning piece. We're lucky because we commission services. So it's put my mind to how we commission into the future. We've got a new commissioning framework, and to make sure that in contracts, in procurement, in commissioning, that physical health is a key component of actually what people have to deliver and what we measure people against, and make sure that we are able to do that, because that it's key in the commissioning as well. So that's a few things.
Yeah. Thank you. And all you Western Australians, remember, she commissions the money, all right? So you be good to her. Deb.
Thanks. I also think that the commissioning side of things is a fundamental, system fix that we need to do. That it's very, very challenging, but the way that we fund things in silos it just makes it so difficult. And I think if we could put our heads together, the role of the commissions I think could assist that. And I guess from a Queensland perspective and the Queensland Commission's perspective, we're not holding the money for service delivery, but we really are trying to influence the way that things are done. So bringing, and not just focusing on health, but looking at those broader social determinants of health and how we can get a better focus, and really focusing on that prevention and early intervention. So, generally for mental health and wellbeing across the community, but specifically for people with mental health conditions who may be at the start of their journey, and where if we could, intervene earlier would make such a difference. And I guess from that government perspective, trying to pitch that to government as an investor save type strategy, which is really difficult. I guess when governments are really looking at avoidable hospital admissions, for example, but that's a real that's something that I think in this space we could really make the argument for. I think there's also potential to upscale and build on the things that we know that work. There's just so many pockets of excellence, but I think the system really struggles with how to build on that and scale it up. And I think again, part of the Commission's role is to, seed innovative practice and evaluate and, amplify the outcomes of things. So I think that's something that the Commission is doing in various ways, but could focus on more. Additionally, I'll just make one more comment. We're in Queensland, we're calling it refreshing Shifting Minds, which is the whole of government strategic plan. We've had a change of government in the last year, and we're really looking at how we can reset and refresh, shifting minds so that it really speaks to the new government and its priorities. So it's continuing on the good work that's already been started, but really trying to nuance to what the new government is particularly interested in. And in this space, obviously we'll continue to have a focus on improving physical health outcomes, but linking back to what I said before, I think it's really about pitching it at what's in it for government that government's really interested in, which is reducing costly services, and we really just need to boost up and show them how important investing in prevention and early intervention is.
Yeah, prevention and early intervention is very important. Now, Phil, we had a wonderful talk from your minister who said that you're doing great things. So tell us about some of those things you'd really like to do.
Thanks. The minister. Well, firstly, I would say that a couple of the things that Tammy's been involved in have been social prescribing. That's just been some work being done through Flinders, and also some focus on overshadowing. So that's been something there. Now, the minister did outline some significant funding, and we've talked about a lot of different programs, the Mount Barker Head to Health work there that they're bringing, supporting physical health in, and other things through this. But a lot of the investment in the mental health budget has been around beds, and that's important. And we're sort of almost there in terms of the meeting that need in SA. But I think, just coming back to Russell's comment in the beginning of the conference around bridges, and we've got to get politicians of all stripes to like bridges. They love bridges, and you only have to drive around Adelaide and to see all the bridges that are going up. We have to get them to like different bridges. We have what, and this is more from my perspective than the Commission's. What I've been hearing through here is amazing, and it's been, even though there's a lot of lived experience around, it's been largely focused. I've heard a lot of stuff about GPs and making sure in those settings we're getting that connection or breaking down the silo between physical and mental health. I come to my work from a lived experience, and so my go-to is the person that's engaging in the support. And where I've seen the most traction has been in psychosocial supports. We've got up over 400,000 people that are missing out on those nationally. In SA, we've got 19,000. It's great to see some of my old NEMI crew and Tom here today launching this health prompt. I remember using that in the Wellness Connect psychosocial group-based program. In that program and in other psychosocial programs around, there's great work being done by peer workers to support people around their context, around their physical and mental health. It's a holistic approach. I think there are amazing stories of recovery that come out of that. The impact, the change that can be made around somebody's mental health from their physical health being attended to, sometimes for the first time. So I won't drag on too much, but I think the investment into peer support and psychosocial supports would have a dramatic impact on those statistics.
And the opportunity to use that peer support to support both the physical and mental health and the emotional well-being of a person.
In psychosocial services, it is physical and mental health. It's not just mental health.
So they've overcome the Descartesian divide.
Yeah,
that's good to hear.
Indeed. They've broken down that silo.
Good to hear. Maybe we will one day. Catherine, chains are off for you, so you can suggest what you think.
I can suggest anything.
Yeah.
Oh, that's excellent. So in New South Wales, they are writing a new strategy. Seems to be the season for writing a new strategy. So New South Wales Mental Health Commission is writing a new strategy. What I think I would like to see in that is a bit shaped by what the New South Wales Upper House has been doing recently. They've been quite interested in mental health. They did an inquiry into community mental health, and out of that there was very strong recommendations around improving integrated care. Very interested in what does holistic care look like, and wanted really practical examples, which actually also echoes a bit of our conversation that we had with the Productivity Commission, so that would be interesting as well. But I think trying to really do that reshaping of the system to actually fundamentally understand what an integrated care model looks like on the ground, to actually understand that it's more than just bringing individuals together. It's actually a culture. It's actually a culture change and a transformation. And I think that my hope for the Commission, given that it's almost 15 years old, is that it can be brave. And I think that's one of the things that would echo perhaps many of your work or your practice, and listening over these last day or two, is that you can be brave from wherever you are in your role. And I think as an organisation such as a Commission, they have that extra responsibility to step up and be brave. And I think for physical health of people with mental health issues, it is something that I actually ponder why, with so many stats, and we've seen all of those, why isn't that agenda driven forward? So that's what I would like to see the New South Wales Commission do. They've got an election coming up, in 18 months. I'm always thinking, nail it now, guys. And I think that's really important in all of this story about reform. We each are different, but we have that common agenda about what's important to our community. And I think that's the responsibility that a commission has.
Yeah, great. Thank you. Thank you to all the panellists. A lot of ideas there. We're going to open up for questions.
Yeah, there's some great questions coming in, so thank you so much. And I'll come to the room. I'll get to a couple on here and then I'll wander around the room, so please pop your hand up. Every question is, you've got the commissioners here, ask the questions. Okay, but just as a little point of celebration, Julian has said, speaking of peer workers, as of this morning, I'm now a qualified peer worker. Where are you? Congratulations. Rock on. Right, that's fabulous. Now, Dave Peters, quite a few people have ticked your question. I'm curious about whether the difference between this is for WA. I'm curious about whether the difference between holding the funding and commissioning in WA creates opportunities to offer longer-term funding for services, as opposed to most of the rest of Australia where funding is usually time-limited and insecure. We frequently see pilot programs, yes we do, that don't seem to be further funded after the pilot, 18 to 24-month funding cycles for more mainstream NGO services, and the roll-on effect on staff turnover, lack of job security, followed by consumers and carers getting access to support for an urgent need only to see the program finish or change, bringing a loss of trust, confidence and engagement. Speaking the truth, because I'll reinforce that, JD, I was wondering the same thing. The service I work in is a pilot. We just celebrated its third year of being open, which is nothing short of a miracle. Countless other pilots have not been so lucky. WA, have you been able to kind of take the reins of the piloting, endemic piloting in this sector?
So I'm an anti-piloter. So just letting you know. So
staking a claim.
Since I came in to the Commission, I've had fights with Treasury around why are you piloting, unless it's some new idea about painting the room blue and we're all going to get well or whatever it is. I'm sorry, that these are evidence-based, proven programs and part of a system that we require. So I have inherited some pilots, but I am shifting away from pilots full stop. The other thing I'll say is my background is a health professional, worked in the mental health system for many years. There's a huge inequity in our NGOs getting funding on short-term cycles when funding has been going on for some in the WA Commission, people have been funded 10, 15 years and still having to go through these ridiculous cycles, not recurrent funding. So I'm seeking to fix that in our new commissioning cycle that we're working through. And also, I honestly believe that, you can educate Treasury and government and others to stop the pilot, unless it's something brand new that no one's heard of, and we do need to test it and get the evidence. but I'm not a fan of pilots at all.
So what are you replacing them with?
So as in, if it's an evidence program, I put up a budget bid, and basically this is about, we need funding for this program, we're going to roll it out gradually. And here's the evidence, and here it is.
Because 18 to 24 months is never enough to build proper evaluation.
No. But like, for example, I'll give you a good example.
So you can't build a case to continue the pilots?
I mean, a good example is in WA, we're just in the process of rolling out ambulance co-response, and there will be peer workers in that co-response team. It's across Australia, it's been working forever, and they want to do a pilot. Well, no, it's not a pilot, it's part of a system that we require. So it's really that education piece. The other thing is, I will say, as again, inherited so many hundreds of millions of grants, people on short-term grants, yet the programs have been running forever. That's going as well.
How to create trauma in a sector that's already traumatised?
So we're just in the process, this budget, whether we'll be successful or not, of shifting those grants, there's a lot of them, into permanent funding. So
this is great for people to hear. Yeah. So, I mean, part of advocacy is also advocating against the piloting culture in this country. Terrible and very politicised as well, because different politicians get behind different pilots, don't they? Okay, so we're going to let's keep answers really tight, because we've got a lot of questions, and I really want to move around the room. So over the other side of the room.
Does this one work?
Yep.
We had two over here, if that's okay.
Yeah, great. And maybe we could take them both in a row while you're over there. We'll take the questions.
Getman. I'm a Palawa man that comes to you from Naarm in Victoria. I know you can't speak to the Victorian government. However, as a lived and living experienced consumer, an educator and an advocate, can you tell me how a consumer can have confidence in a commission that gets 16,000 complaints over a period of 12 years and doesn't make a single determination against the system? And also we have a mental health tribunal that can see a psychiatrist at 5 tribunal hearings in a day in a row where he's found to have been coercive and can continue to practice.
Okay.
How can consumers have confidence in commissions?
We don't have...
Thank you very much. I'll just take that question, actually.
But I want to... because we don't have the Victorian Commissioner with us.
We don't?
No.
So, I mean, does anyone want to respond to that or pick up on that point that was made? It's an important point.
Yeah, and I think there are some internal...
But trust is an important part of the Commission.
In Victoria around that, but I don't know the details, so I can't give an answer to that.
Right, okay. I also just want to acknowledge that Victoria has just signed its first treaty with First Nations communities, and let's hope that that has an impact. Okay. All right, interesting. Okay.
Take the next question.
If anyone wants to pick up on the question of trust and commissions, perhaps we can across the course of the conversation. Another question. Thank you.
Just thank you for sharing, first of all. The space that we work in, I just want to pick on the latter thread of braveness, and thank you for introducing that. Through the work we do, we know that braveness exists in conditions, and often, I guess what I wanted to ask the panel was, from your experiences, and this is maybe messages for commissioners in the room, for people that run, directors of services, etc. What are the conditions that you would love to see in those kinds of environments that enable people to step into their braveness more?
Who would like to pick that up? I won't grab all of them, but who? Tell me about courage and braveness. And
look, I mean, for me, I guess as a commissioner, as I said, I've been in the kind of mental health system for, I'm not going to tell you how many years, because you'll know exactly how old I am. The hair dye does a great job. But I guess I've gone through just doing what I need to do, doing what I'm told to do, kind of, you go through the system from a young nurse all the way through, and you're just going with things. Now I'm very more outspoken, not by the way, not in a way to annoy government, because you'll get nothing. I've worked out how to influence in a different way by being the voice of many, and really I'm a very the way I'm talking now, I would speak the same to ministers or anybody, because it's important to be honest and truthful, and you get that trust from them, that they trust in you in how you're speaking, rather than I've got many colleagues across other DGs and the agencies, and they can be very bureaucratic, and hold themselves and not able to show a bit of themselves and things, and that's not my leadership style. It may not ever get me to be the DG of DPC or Treasury or something.
Who cares?
But this is me, and what I've found is with ministers, politicians, other government, then I have a lot of trust in them just by being myself and being honest.
That's an interesting point, isn't it? To be yourself and be strategic in how you deploy that.
And I'll just say, look, I spent 15 years in government too, and I think that there are two things that really work. One is if you're actually genuine about what you're representing, which means that if you've consulted with people and you have the voice of lived experience and the voice of your service people as well, and you're putting their ideas forward, that's one. And the second one, as we talked about a lot, is about evidence. If you can actually show the government that they will get a return by filling that gap with an evidence-based program, as Maureen says, then that's when you get so jumping up and down, being rude, will never get anywhere. And that's how we've worked as bureaucrats, isn't it? Yeah.
Some questions. Michael, peer lived experience workers are always spoken about in glowing terms. Are they ever going to get well-paid union representation and career pathways? And alongside that, what tangible differences have each of the commissions made to the experience of people with lived experience in their states? Slightly different questions. And Brooks adding not just peer workers, all people with lived experience. So, how do you... The first one, about, lived experience workers are not a charity.
I might just start that. Thank you for the question. It's a really great question. I think at the Queensland Commission, we're doing a few things. I think all of the things that we fund, we...
Just bring the mic up a bit, yeah. Just closer to your mouth, yeah.
They say I'm the quietest one in my family.
That's not the mic.
A couple of things. So first of all, the Queensland Commission recently released our commitment to partnering with people with lived and living experience. This is a public statement that we're making about the way that we want to work with people with lived and living experience, in the way that we fund anything that we're funding, the way that we work, the way that we bring in the perspectives of people with lived and living experience to co-design, co-produce, co-lead together as much as possible. And we encourage, so this is how we're doing the work ourselves, but we're also encouraging others to use it also in a way that works for them. Anything that we fund, and unfortunately we don't have recurrent funding, and we do fund, we seed good ideas, we seed, evaluations and so on. We require anything that we're funding to partner with people with lived and living experience as part of that work, and we support them to do that so that it's in a genuine way. We've also received some funding through the mental health inquiry over the last few years to build the lived experience workforce, so we're doing a lot of initiatives there, and we're talking about lived experience workforces across mental health, AOD and suicide prevention as well.
Is part of building it also looking at payment?
Oh, absolutely, yes, yep, definitely. And we've also built the capacity of the lived experience team in the Commission itself. So we've got some designated positions in the Commission, including our Director of Lived and Living Experience, who sits on the executive leadership team, and a number of identified positions as well.
Okay.
Can I tap into
yes, please do.
That peer space as well? So within psychosocial services, from a South Australian perspective at least, peer workers, I'm going to go out on a limb and say, are generally paid the same as community mental health workers that work side by side with them in those psychosocial settings. So there's a parity there against with people that are using their lived experience in their practice and those that are not. A lot of organisations are tapping into the resources created through LELN, our Lived Experience Leadership and Advocacy Network, our peak in SA, and also the Mental Health Coalition for frameworks, and from nationally as well for frameworks, which provide some career pathways for people with lived experience. And I'd really suggest to any of the peers that are in the room today that to look around for where you want to work, do your research into the organisations that are really doing some great work in this in terms of creating those pathways, and go to them. That will put pressure on other NGOs to lift, to create a value proposition.
Value proposition, yeah. It's a marketplace, isn't it? It's a workplace. Dave, you've just got some things that you've posted around this, and I'd love you to enunciate, to talk about it.
Thank you. Look, in relation to the idea of national representation, or even just having a union, having access to education, professional development, career pathways, we have, the Commonwealth has committed to funding for at least a 3-year association, which will then be required to be self-sufficient, or show that they can be self-sufficient, to continue to offer national representation, a consistent national practice guideline, scope of practice that allows people to sort of push back against job scope creep, and that sort of pushes that idea of equal work for equal pay. But that's just my hope. I don't know whether that's it's part of the grand sort of commission is calling for ideas on how that could happen, but it hasn't even closed. I think that's closed last week, so it's still very early days, and whoever gets the job will have a lot of hard work to do to try and professionalise lived experience work as a discipline.
Yeah, it was part of a national workforce initiative about 3 years ago, sponsored by the Commonwealth Government, led by the National Commission, and that prioritised peer workers and Aboriginal and Torres Strait Islander health workers in mental health as the two leading gaps in what we didn't have.
And this was reinforced by Liz. Not simply payment, needs to be meaningful career opportunities for lived experience people working in systemic advocacy, not just relying on volunteers and token honorariums. But that other question, which was, what tangible differences have each of the commissions made to the experience of people with lived experience in their states? Now, I know you want to answer that in about 15 minutes each, but you can't. But someone has said, for Liz also, because she's in Tassie, has said, I'd love to know this as a Tasmanian without a mental health commission. So this is good chance for you to say, give us a palpable sense in 30 seconds each. Is that okay, John? Yeah. Because it's a question that's come up.
Sure.
Thank you. I'll start and have a go. What I will say is we've always got a long way to go since I've been working in this area, specifically in commissions. I get it right, I get it wrong, but each time I'm learning and trying to work with it. In the WA Commission, we have lived experience assistant commissioners, so as soon as I arrived, the first thing we wanted to do was elevate the voice of lived experience. They're remunerated very well, and should be. There are experts and they work within the entire sector. We've also got lived experience teams like Queensland, who are on various levels from directors downwards.
And for the wider lived experience community, what impact do you feel when you go to bed at night you're having?
So all those strategies, all those things I've mentioned to you, there is not one thing we do without consulting with lived experience. They are all... Now, we may not always be able to deliver on everything that's been requested and required, but every single strategy, document, policy, everything we do, we work with lived experience expertise and lived experience across the whole of Western Australia. Are we perfect? Absolutely not, and we've always got a long way to go.
Perfect's the enemy of the good, often anyway. Other comments from each? Phil, Kath?
I'd say very similarly. I think everything that we do is infused with lived experience. So, we're a strategic reform focused commission. So
bring the mic right up to your face.
God,
Thanks.
So sorry.
Amplify. Claim your voice.
With my hands. So all of our strategies as well, they have very strong lived experience focus in how they're developed. We have some really strong peaks in Queensland, so we support them in many different ways. The governance of all of our plans have a very strong lived experience element. We have our team who embed every lived experience into the way that we work as well, so they support the internal team as well. We're not perfect either. We've got a long way to go. We always will, but I believe we've got a very true commitment to working with people with living experience.
South Australia. It's tough.
So
one of you,
I come
two
to
of you.
Two of us.
What are you feeling
Look, as I
terms of
mentioned, I
impact?
come to my work with a lived experience. Tammy as well does everything she does from her lived experience perspective. So I can confidently say we're 100% lived experience. It's not that easy to say with two. I don't know how it's hard to say with two.
And having
but
two commissioners,
yeah,
two
or
people there,
people,
front and
yeah,
centre,
yeah.
public facing, that is impact.
Everything we do is through a lived experience lens. If we're looking to advise government, it's either something that we know it's on the shelf that we can draw from previous research, or we go straight out. The drought mental health funding in the SA, for example, when that came up, we went straight out to regional SA and drew that lived experience in, exactly what people wanted, and then that formed. We take that and we help shape that response. So that's an example of how we would do that.
New South Wales, you're not really able to comment in your role, but very briefly.
Well, just briefly, in New South Wales in our legislation, the commissioner has to have lived experience as a carer or a commissioner, and I had experience as a carer. As deputy commissioners, there were 7, and 2 of those had lived experience. But that's the structural thing. I think that the thing for me that the commission very much backed peer work, because that really is a culture change, and the culture change is about the experience of care, but also about engaging across all different government departments about why isn't there a person with lived experience of homelessness on this committee? I think asking those questions wherever you go and lifting that engagement, because then that will change that experience of care and outcome.
Being in every conversation. John, back to
I
you
think
to
just
control.
back to me, some of us are old enough to remember a time when there weren't any commissions, and we recall the call for commissions. I think if you look at the success of the commissions, and they've been variable and up and down and had their flotation, the respect for lived experience that's come from that has been an enormous step that we wouldn't have got as far if we hadn't done that work. So I do think overall commissions have been helpful in that, but some of the times commissions don't have much money apart from Maureen, and it's an uphill battle against fights and bureaucrats like me to get the money to do what they want to do. So
where are the gaps?
Well, we're at the position where I think everybody actually recognises what we need to do, right? We're all committed to the lived experience stuff. Some places are better than that, and I'm really proud of the fact that I'm from Queensland and we're way ahead in the representation and payments and so on and organisation. But everybody could be there too, right? That's not me. That's individuals who've done that. And it's been if you look at the services, they've got high levels of lived experience people working in their services. They're the ones who have the best change and they have the best satisfactions, and it's pretty clear. It's very clear. So it's just a funding issue now. It's not a debate issue anymore.
Okay.
As Maureen says.
Well, we'll wrap. Is that okay? Thank you, John.
Thank you. Thank you to the panel.
And thanks to the panel. Thank you so much for being here and sharing your approach to your work and your leadership. Appreciate it very much. And just thinking about this national story from a Mental Health Commission point of view at least, but the Equally Well movement is a national network, an alliance, but Russell's keen to remind you that it's an international alliance as well. Obviously it jumped the drink, what do you call it? The ditch, that's right, the ocean, from New Zealand to Australia, went gangbusters in Australia. You're proof of that here in the room, but it's actually international, and next year you have a chance to participate in the Global Leadership Exchange in Canada for the Equally Well movement. So if that's something that piques an interest for you and you're thinking, oh, well, I couldn't afford that, maybe start thinking about that and having a conversation with Russell and the team at Equally Well about how maybe an Australian contingent could collaborate to get there in some way. So thank you. Excellent. Now, we hear a lot about the Productivity Commission in the news, and for my sins, I was at the National Housing Conference and just read an entire report on the from the Productivity Commission on the housing construction industry, which was riveting reading, I have to say. But what does it do? Well, it provides independent research and advice to government on economic, social and environmental issues affecting the welfare of all Australians. If ever there was a name that was kind of masking the actual work of the Productivity Commission, Commission, I would say that was it. But the Commission was asked to conduct the final review of the National Mental Health and Suicide Prevention Agreement. Its inquiry report is fresh. It was tabled in Parliament 10 days ago, I think. So, hot off the press, what did it find out about one of the most important policy frameworks connecting the states and also for the Equally Well movement? Let's find out, and we can, because we now have the Assistant Commissioner at the Productivity Commission with us today. Now, we put a call out to check Miriam's surname pronunciation, and so sorry, I'm going to stuff this one up, but I'm going to say Miriam Weissman Apter. Where are you, Miriam? Have I got it right? Or is it Wiesman? No, we really wanted to know. We sent you a little secret squirrel text. Yeah. I love getting names right because, you know, names are part of our story. Miriam led the review team, the staff, and is currently leading the Commission's work on Aboriginal and Torres Strait Islander policy. She's passionate about telling the human stories of public policy and designing reforms that respond to the needs of diverse communities. And so say all of us, what a great mission you have. Come on down. Welcome, Miriam.
Thank you. Thanks for having me. And we've worked on the review with two of... Yeah? Better? Okay. Own it. Okay. We worked on the review with two of our commissioners who unfortunately can't be here today, Selwyn Button and Angela Jackson. But I worked with the staff team to deliver this report, which, as you said, was released literally 10 days ago. I'll start by acknowledging the traditional owners of the country on which we're meeting today, the Kaurna people, and pay my respects to elders past and present, and recognise the contribution of social and emotional wellbeing frameworks to everything that we do and did. So the National Mental Health and Suicide Prevention Agreement, which we are probably all familiar with to some extent, signed in 2022, but followed on from a long, long line of national mental health plans that have been around since the 1990s. It's an agreement between the Australian Government and all jurisdictions that aims to get them working better together to deliver an integrated, person-centred mental health and suicide prevention system that responds and elevates the voices of lived experience. It doesn't include much funding. The vast majority of the funding comes from Medicare and from hospital funding, but what it aims to fund is that what the South Australian, actually, Royal Commission into Early Childhood Development called the glue, the bit that sits, in between governments, in between LHNs and PHNs, in between lived experience organisations and the health organisations they're working with, bringing them all together and making sure that they are able to work together and collaborate in order to deliver that person-centred system. It also had commitments to report on progress and to have a final review ahead of the expiry of the agreement in June of 2026. It's only one part of the broader mental health policy and suicide prevention policy space, and of course that also includes the Equally Well consensus statement. The agreement recognises that statement and makes a commitment to continue to promote the physical health of people with mental illness. However, like many other commitments that are included in the agreement, what we found is that there are no tangible actions. There's no funding, there's no plan that we could identify to actually make that commitment real and make a difference to the lived experience of people within that system. It set itself a very large set of tasks. It has 5 objectives, 5 outcomes, identify 15 priority populations, 14 policy principles, and includes a very long list of actions. It doesn't, though, show us in a clear way what the links are between each of those things. How are the actions going to achieve the objectives? How are the objectives going to support the priority populations? And importantly, it doesn't show us, to be blunt, the money. It has funding for certain things and important things like the Aboriginal Social and Emotional Wellbeing Centre that we heard about today is funded under the South Australian Bilateral Agreement. Medicare mental health care centres, suicide prevention initiatives, all important things, but with a very limited reach. So what it does is cover a very, very wide terrain, but the actual actions are much smaller, and we'll talk about that in a second. So these are the significant outcomes that it aims to achieve. One of them, as you well know, is improving the physical health of people with, living with mental illness. And as the agreement is about to come to a close in June of 2026, the Proactivity Commission was asked to conduct the final review of this agreement. There's been periodic reports from the National Mental Health Commission. Only one of them has made it into the public domain so far due to delays with jurisdictional reporting. So we were asked to assess the agreement as a whole, assess the effectiveness of its governance as well as the services delivered under it, and look at the way lived experience and the voices of Aboriginal and Torres Strait Islander people were featured both within the agreement and within the services that it funds. We did this over a period of 9 months, so it was a bit of a whirlwind kind of approach. We had an intensive period of consultation. We released a draft report in the middle of the year. We then went to consultation again, and as I said, the final report was released 10 days ago, and you can find it on our website. In the process of those 9 months, we undertook as much consultation as we could, really, and I should acknowledge and thank Equally Well for really supporting us in that process. We've heard from you in submissions, in a roundtable, at our public hearings, and it's been very important for us to hear from you. We've had a survey out in the field. We went and visited as many services as we could, and we put a real emphasis on hearing the voices of lived experience. Both consumers, carers, Aboriginal and Torres Strait Islander people from various walks of life with various experiences, and try to play those back to people themselves to make sure we understood them correctly, but also to government to make sure they get the messages that they need to hear. And what we heard is that there are many opportunities to improve the next agreement. The centering of voices of people lived in living experience being a key one, but also governance and accountability. I think accountability and transparency were probably the most common words that we heard in all of the conversations that we had. And a clear link between what we want to do and what we want to achieve and what we are actually doing in practice and how we're going to know that we're on the way to get there. And there were some clear priorities that people spoke of. The psychosocial support gap that was mentioned before, 500,000 people across Australia that can't access the psychosocial supports they need. They're not on the NDIS and there's no funding to deliver them the services that they require. Data was another major one, again was mentioned earlier today. The way services are commissioned and the way PHNs and LHNs work together to ensure that commissioning is efficient. And the lack of an overarching strategy. There used to be, under the National Mental Health Plans, a plan for a way forward, a national way forward for mental health. We now have a national suicide prevention strategy, which was very well received when it was released early in the year, but we don't have a similar thing for mental health. So, the first question in our homework for government was, what has this agreement actually achieved? On face value, it actually achieved a lot of what it set out to do in the sense that there are national outputs that are listed in this agreement, and the vast majority of them have indeed been delivered. The problem with those outputs is that they don't necessarily go far enough in actually resolving the issues that they set out to resolve. There are also some very urgent priorities that have not been advanced, even though they're included in the agreement. Psychosocial supports we've spoken about. Clear guidelines for PHNs on regional commissioning and planning are not available as of yet. The National Stigma and Discrimination Reduction Strategy was developed but had not been released, and that goes back to the conversations before about the effects of stigma and discrimination. And finally, yes, there is a national workforce strategy, but we have been unable to find ways in which it's actually being implemented. There's no funding attached to it, there's no government, there's no governance, there's no accountability. And so unsurprisingly, even though the outputs have been completed, the overarching objective of creating a person-centred, coordinated mental health and suicide prevention system has not been achieved as far as the Commission was able to find. There's been minimal involvement of people who lived and living experience in the development of the agreement, in the governance of the agreement and its implementation. And even though some positive policy developments and some very important services have been delivered, by and large, we are not now in a different position than we were prior to this agreement being signed. And this plays out in the daily lives of everyone, really, with services being unaffordable, with the suicide rate remaining unchanged, and in the case of Aboriginal and Torres Strait Islander people, getting worse. And there are a few reasons for this. As we said, the agreement was not set up for success because it doesn't have those clear linkages between action and outcome. There was an inadequate inclusion of people with lived and living experience across the board, which means the agreement isn't able to relate to the real needs of people on the ground. Its governance arrangements are comprehensive but don't seem to be terribly effective. So the key example being there's a schedule dedicated to cross-government interaction and cross-government sort of coordinated action to address the social determinants of mental health, but that all it was able to achieve was the exchange of some papers between government departments, which is an important, as a thought leadership piece, it doesn't necessarily address the social determinants of mental ill health. And finally, the agreement did not support reform enablers, things like better data sharing, greater investment in the workforce, greater transparency and monitoring and accountability, have not really advanced under this agreement. So what did we recommend, or what do we recommend? There are some urgent things that governments should do before the agreement expires. So there's only 7 months left, but these are things that can happen ideally tomorrow. The psychosocial support thing, again, is a critical missing piece in this puzzle. It was mentioned in the existing agreement. There's been years of discussions. We're still not there yet. 500,000 people are being affected by this gap. The stigma and discrimination reduction strategy should be released in the Commission's view. Similarly, the guidelines on regional commission and planning should be broadened and offer more detail on how to do these things effectively, and again be released. And finally, the National Mental Health Commission, which has been operating within the Department of Health, Disability and Ageing for some months now, close to a year and 2 years, should be re-established as an independent commission, and its powers should be strengthened in order to enable it to become a monitoring and accountability body that monitors the next agreement more effectively. Now, in terms of the next agreement, we believe that the negotiation of the next agreement should actually start with the development of a mental health declaration. A declaration and not a strategy. We've learned from what's happening in the education space, where the Mbatwa Alice Springs Education Declaration has been around for many decades and has served as a foundational document of the Better Fairer Schools Agreement and other key documents in that space of collaboration between Commonwealth and state governments when it comes to education. So we believe mental health should take a similar approach and develop a declaration. There are so many documents available. There's been so many conversations with people who lived and living experience. There's a clear understanding of what a declaration should and could entail, and the National Mental Health Commission could lead that conversation to develop a document that all governments should be able to sign up to. The benefit of a declaration is that it's not time limited and it can stay with us for as long as we need it to, because this reform will take a very long time. In a practical sense, as I said, this agreement is due to expire in 7 months. 7 months in the Productivity Commission's view is not a long enough time to enable the development of a comprehensive agreement that truly enables the listening to the voices of lived experience and reflecting them in what governments commit to. So we are proposing extending the agreement by a year, and that includes extending funding to the services that are being delivered under it to ensure continuity of care, and using that period both to develop a mental health declaration and to truly build a new agreement that responds to the needs of people. We believe this new agreement should come under National Cabinet. At the moment, the National Mental Health and Suicide Prevention Agreement reports to the Health Ministers' meeting. Mental health is a national priority, and we believe that National Cabinet should be responsible for the next agreement and set up a special purpose council to oversee this particular agreement. The benefit of that, and of obviously health will continue to have a huge effect, but there are other important parts of government that should play an active role through their effects on the social determinants of mental health. So, as I said, a National Mental Health Declaration, an enduring document based on the significant conversations that have already been in place. It should work hand in hand with the National Suicide Prevention Strategy and give that long-term vision and long-term clarity on what we are all trying to achieve. And that declaration should flow through into the objectives and the outcomes and the particular indicators that are chosen. There should be a clear logic and a clear flow from the big picture into the activities and services that are funded under the next agreement, and it will take time. So we see each consecutive agreement as achieving a number of steps towards that vision that will be articulated in the declaration. Of course, a greater role for lived and living experience in a meaningful way. Yes, if you look at the agreement, it's got lots of mentions of listening to the voice of lived and living experience. We have heard from many people that there are varying ways in which that has played out. And in some cases, we also heard that the word tokenistic to describe the way that role was played in governance and in the implementation of the agreement. So we're making a number of recommendations on how to formalise and elevate those roles, so to make sure that those voices are heard and they're consistently at the table. And also making sure that there's a balanced representation from the mental health side of things and the suicide prevention side of things, as well as carers, as well as service providers, which at the moment are not part of the governance of the agreement. As I mentioned before, a stronger authorising environment means coming under the National Cabinet's authority. We believe that the governance arrangements need to be expanded to reflect and enable cross-government activity and that representation of agencies that look after the social determinants of mental health. And we believe that the National Mental Health Commission needs to have a much stronger, clearer, independent role that enables it to get the information it needs to truly monitor progress against the next agreement. Flexible funding is one thing that we also believe should come into the next agreement. At the moment, a very small amount of funding sits under this agreement, but there are many, many other government programs, both within the Australian government and state and territory governments, that go towards this idea of better coordinated care. They're duplicative. It's not always efficient to have duplicative programs. They impose part of that difficulty of multiple grant applications, of services needing to apply again and again and again. What we're saying is all of this funding needs to come in to one flexible pool that will be available to PHNs and LHNs once they're able to actually coordinate and commission services together across the continuum of care for each of their respective responsibilities within that continuum. We think that services that have a strong evidence base and are currently funded should continue to be funded and on an ongoing basis, and we think there should be dedicated funding for evaluation, as well as for dissemination of those evaluation funding and making sure that excellent work that is being done in many, many places across the system is embedded across and is made known and is able to affect as many people as possible. The issue of peer workers that was just mentioned, we make a recommendation for a scope of practice to be developed for peer workers by the association that Dave mentioned before, and to learn from the experience of the Aboriginal and Torres Strait Islander health workforce that developed a similar scope of practice and that has underpinned growth and within that sector. We think that the National Workforce Strategy is a really great place to start, but it needs funding, it needs accountability, it needs monitoring, and it needs clear governance. Finally, we make recommendations for 3 schedules to be added to the next agreement. 3 schedules dedicated to areas that are at the centre of the mental health system but require specific consideration. One of them being services for Aboriginal and Torres Strait Islander people, where there is a social and emotional wellbeing policy partnership set up under the Closing the Gap agreement that is operating in parallel almost to this agreement. We believe they should come together and be able to direct greater investment in culturally appropriate services for Aboriginal and Torres Strait Islander people, including mainstream services. Suicide prevention is another area where we believe a separate schedule is necessary, and that's guided by the National Suicide Prevention Strategy. There are many things where mental health and suicidality intersect. There are also quite a few things where they do not. And bringing the two together under the one umbrella agreement doesn't always enable the recognition of those things that are distinctly separate. So what we are suggesting is a separate schedule for those things that sit squarely within suicide prevention. We have a National Suicide Prevention Office, which is very well equipped to monitor and guide the development of this schedule. And finally, we are also thinking about people affected by dual diagnoses who are living with mental health as well as problematic use of drugs or alcohol or other drugs. This particular area of policy has been neglected for some years. We have very good guidance for practitioners, but it's not necessarily being implemented. And we don't have any monitoring or accountability of policies that are being rolled out in this space. And just finally to say, these are the schedules we're recommending at this point, but we believe that using similar approaches, other priority populations, including people living with mental health and physical chronic conditions, could be the subject of the future schedule.
Well done. Thanks, Miriam, very much. Ambitious, as it should be. And I'll ask a question and then I'll open it out to the room. Who's listening?
So we delivered our report, as the Productivity Commission always does, we delivered our report to governments. We've had back from the Minister for Health publicly through a press release that this will underpin the beginning of the discussions that need to happen with the new agreement coming up. We've had conversations along the way with all departments as well as peak bodies, etc. So we would hope that they are. And we know that they need to start thinking about the next agreement pretty soon.
Is there a process, though, that ensures that they keep listening? You know, do you table the report and then park it and you have to move on to your other responsibilities? Or do you go, by the way, squeaky wheel, what about this? Sorry.
Yeah, well, the Productivity Commission's role is defined by its terms of reference. However, we also have a role in monitoring and reporting through the review of government services that comes out every year on the outcomes across many, many areas of government services, including mental health. That will continue. It's not necessarily linked directly to the agreement, but it certainly reflects the extent of government investment, the experiences of people across many aspects of the system.
Yep.
So through that, we maintain our sort of monitoring and accountability.
Because I asked that because, you know, all that incredible analysis and work and input and consultation to really strip bare the, cleave open the failures, let's face it, of a national agreement, you do start to wonder whether a national agreement serves any purpose at all.
So we asked that question. We actually asked in our
we're a
consultation,
federation, sometimes it doesn't work.
Should there be a next agreement? And the consensus, with one exception, was yes, there should be one.
Why?
And the reason for that is we need governments to work together. The beauty, the failure of the Federation is that different parts of government are responsible for different things, which all come together when it comes to mental health and suicide prevention. We absolutely need state governments and the Australian government to work together, and a national agreement is the most efficient way to do that when it's well designed and well implemented. So that's why we still are recommending a new agreement.
That's interesting. Michelle Buckley's written, as a lived experience researcher from Victoria, researcher and worker from Victoria, I truly believe that the ongoing effects of COVID on our mental health, in Victoria's case, 2.5 years of, etc., I lived it, need to be included in the new agreement. So that's an interesting variable, isn't it? We are living in different times. And how about adding an equally well schedule in addition to the ones already recommended? Liz got that in, cheeky.
Look, we had to consider where the needs are most urgent. Equally well, and the physical health of people, mental health are clearly a priority, and as they should be. They're not a priority population, by the way. But what we saw is a clear need and a lack of policy engagement where it comes to that dual diagnosis of people with mental health and problematic use of alcohol and other drugs. But we've made very clear in our report to government that this can be taken as a blueprint to future approaches of populations where we really think that systems need to come together to deliver better outcomes. So not having it in the first tranche doesn't mean they don't need it in the next tranche.
Hazel asks, Hazel Dalton, thank you. Given the lack of money, what sort of financial investment would allow the system to mature and collaborate to be more person-centred and effective? How could we be more equitable for rural and remote communities? Big questions. But
So we estimate that if all the flexible funding that's intended to support better coordinated care is brought together, we're talking about $1 billion a year.
$1 billion?
That's a lot of money. It needs to be invested better. It needs to take into account the evidence that we have. It needs to take out of the system bureaucratic costs that affect the way service providers work and affect the way governments work as well. All the ideas are in place. It's just a matter of making sure that we've got a clear linkage from the idea to the actual output on the ground, and that we're listening to lived experience to make sure that what we've got on the ground answers the need.
Well, more that lived experience is driving the change as well. It's not just a case of listening to, it's a case of, centering. And I just think of all the flights that get, all the costs on flights and flying people to the meetings and, servicing a national agreement is an expensive beast. So if it's not actually deploying resources effectively and efficiently, then it's truly a failure. Sorry, that's a bit blunt, isn't it? It'd be great to see someone like you, given that your knowledge now, this sort of cross-sectional knowledge, for you to be involved in an implementation role. It must drive you kind of, very, very frustrated sometimes, yeah.
So the Commission does support government as much as we're able to, as much as we're invited to in implementing change. It really depends on how things go in their deliberations.
Yeah. Any questions in person that you're itching to ask before we head to lunch? Look, I really appreciated that sum up, and your slides I think will be uploaded to the portal of the Equally Well website. We've got a little prezi for you. Russell's going to make his way to the stage and take the podium. Please give it up for Miriam from the Productivity Commission. Thank you.
Vic mentioned in her presentation about communication. One of the things that underpins all communication is trust and reputation as an organisation of integrity. And I've got to say the Productivity Commission is that. If you haven't visited their inquiry report, go and have a look at that, which identifies Equally Well as a start now and a priority reform, but also in the whole process they've done that. And compliments to Alan Fells, who launched this Equally Well at the National Press Club in 2017, who really put mental health on the agenda of the Productivity Commission, understanding the link. It's just not something separate, it's an integral part of our community. Talking about integral parts of our community, we're going to really invite you, when you go back, take some of these, and put them in your coffee rooms.
And what are they?
The Equally Well National Consensus Statement. If you want some more, email us and we'll send you a box of more, so let us know how many you want. Same with the fact sheets. Take them with you, put them up in your community notice boards, in your tea rooms, wherever. We really need to raise the awareness and the culture. Also, as part of the collective, the research and data. So we really invite you. So one of the things we're doing in one of our projects, and Justin and Rita are lived experience researchers on this project.
This is at Charles Sturt University?
Charles Sturt University research project on peer navigators. We've developed a model of care. We need your advice, and we still need more information on your perspective as a person with a lived experience, as a carer, or as a service provider. If it's not working for everybody, it's not going to work. So we really need all the perspectives. I also have a shout out for Professor Amanda Wheeler, Griffith University, while Natasha's looking at her phone. She's also got a research project as well. Let her phone watch. And also, I do understand if Alyssa Minton's here, her Simplicity project as well. So please jump onto those QR codes, and make an impact, make a difference, because we need to hear your advice. We need to have the voice to design proper, effective, feasible, acceptable approaches to improving this. last but not least, it's a QR code fest, isn't it? We really strive hard to make this, to meet your needs, to make it connecting, to make this conference better every year. One of the ways we can do that is from hearing from you and filling in the QR code. Be honest, be brutal and be honest. We'll take it and we'll respond to it as best we can. So thank you so much. But over lunch and in the other sessions, please have a QR code fest.
So how can they find those?
They're on your tables.
Right.
There's varieties.
Okay.
That's why I'm doing a show and tell. If you don't have that, contact us, anyone on the team, and they'll give you another copy.
Yeah, conference feedback is important. Thanks, Russell, very much. Let's have lunch. I'll see you back here at 1:30 for the afternoon sessions. Energised, invigorated, so we're going to come back at 1:30 if that's okay for you. See you soon. Thank you so much for your participation and great questions. Bye. o'clock. 1:35. So we've pushed things on just a little bit, but we'll keep things moving. It's Friday, but I'm loving the energy in the room. Let's try and keep that energy right until the last session, where I'm going to chair that one. And you can see I love a bit of engagement. So I'll be encouraging you throughout the next just couple of hours that we've got left together. Let's really use this to channel questions into the WhatsApp. When I come and do the panel at the end, I would love to have your participation. I've got some people who are right at the coalface, lived experience coalface, community NGO, mental health sector coalface. We're really going to kind of try and wrap on the question of what good looks like and how can we get there, and I really would like you to participate. So I hope you're feeling refreshed, filled up. If you booked, I hope so. Who got to share their story today over lunch? Did anyone do that? Yeah, great. Thank you. Yep. At least 4 or 5 of you. That's fantastic. Thank you so much for doing that, and maybe you might continue to do that on the website, the Equally Well website as well. And to do that, I think you have to click through to the call to action in the top menu bar. So go to the Equally Well website, equallywell.org.au, is it? Yep. And then up the top you'll see call to action, and then through there there's a share your story link, is what I've discovered. GPs, we've heard from a few of you throughout the last 2 days. You are at an important front line of the health system. It's either really, isn't it, if you're really in a health crisis, you go to your GP, if you're lucky to have one, or your local bulk bill clinic, what's left of them, or you go to an emergency department. Important front line if you're struggling with your physical or mental health and you really don't know where to go. So, crucial to the Equally Well conversation, how do we connect the dots between mental health services and general practice? We've got 2 people who are doing that for you. Simone McCallum is a GP passionate about advocating for equitable, holistic care for people living with mental illness. All hail the GPs that recognise that and make the time to achieve that. She's established the embedded GP service within Eastern Health's mental health services. Now, where's that? Melbourne, my city, to improve the health and wellbeing of mental health consumers, in part by helping to reduce barriers to accessing holistic care, but she'll tell you more about that. Regina Kai is leading a research project in this embedded GP service. She's a clinical nurse consultant at Hamilton Centre, Eastern Health Victoria, a nurse leader and a researcher who brings experience from China, Denmark, and Australia to really focus on bridging this gap. So I love that. What a duo you will be. Welcome.
Hi everyone. I'm so nervous. I always am, and I know I shouldn't be, but I just feel like if I announce that, then maybe it'll make it better. Okay. So I'd like to start by acknowledging and paying respect to the traditional custodians of this land, and also to express my gratitude for the care of the land over eons, and for now sharing it with so many of us, because we really have the most magnificent country to live in. I'm also thankful for the people with lived experience of mental illness and their families and carers, because your extraordinary courage and resilience in the face of massive adversity inspires me every day to strive to provide the most excellent care possible. We have a disclosure that we received funding from the Trophy Grant, which is translating research outcomes into the primary health interface. And also I just wanted to say it's such a privilege to be presenting at this conference. I've been reflecting that all the people who are here and who are involved in this collaborative or organisation are people that are here because they care really deeply about people living with mental illness. So it's a special circle to be a part of, and we all want to do all that we can to make things better. And we all also have really deeply personal reasons for being involved in this and doing the things that we do. So there's stories that sit behind what everyone's doing. And I have also been thinking about what Russell said when I came to my first Equally Well conference was that we do what we can, where we can, when we can, or maybe that's slightly the wrong way around. But it makes me think about if a good few years ago when I was, I've been a mental health GP for a long time, and at some stage I still do really get overwhelmed at times with all of what I see with my patients. They really struggle with a whole lot of things, and it does put a burden on the practitioner as well. You feel overwhelmed, you want to do so much to help everyone and fix everything, or at least I do, I think we all do. And so I remember expressing this to my then psychiatrist, who said to me, "Simone, you can't fix everybody, you can't do everything for everyone all the time. You can only help some of the people some of the time." So I guess this is an acknowledgement that this program that I'm setting up now, so for the last 3.5 years, we've been establishing this embedded GP service. While I'm aware of sort of the broad problems that people face, the work that I'm doing is helping a small collection of people who have real vulnerability and are really struggling. So that's what I'd like to talk about today. And the easiest way for me to explain this is really to start by telling a bit of a story about how this all started. So I'd been working in outer East Melbourne for many years as a mental health GP, and in 2020 where am I at? Partly sort of out of frustration with the mental health system, and also out of increasing curiosity about psychiatry, I thought that I might retrain in psychiatry. So I made this bold move and left general practice and went to work as a psychiatry HMO, so a junior doctor in the local mental health service, and thought, yep, let's give this a go. So what I discovered was that learning about psychiatry is truly fascinating, and I would have loved to have become a psychiatrist, but the main thing that I saw were a tremendous number of people, patients in mental health services, in desperate need of holistic primary health care. So that's where, where was I going to... See, I've reworked this in my mind, and I haven't put things in the right place. Can I go backwards if I go forward now? So this is forward. Just leave it here for the moment. So at this point, I just wanted to talk about what I see in terms of this drive to get equity in healthcare. And I think I've seen before the equality and equity poster quite a few times, but in my mind I had this vision that actually what my patients are going through is they're in that third reality thing, or I had this vision that they were sort of like being dragged down off the pedestal and people were pushing them off, and I was there kind of trying to prop them up and lift them up. So, and I think that a lot of the patients that are really struggling are the ones where they're like this little guy in the ditch. You know, the adversity has been stacked against them from before they were born, with intergenerational trauma, multiple adverse childhood experiences, and by the time they get to be seeing me, there's so much going on, and I think to myself, how can I fix all of this? As a single GP in the community, I found that very overwhelming, but in mental health services, working as part of a team, it's a bit of a different story. So now, can I go back a slide, please? Or do I just press the red arrow? Thank you. Oh, this is magic. So going back to the story, as I worked through the various aspects of the service as an experienced GP in a different environment with a GP lens, all I could see were all of the things that needed fixing and all of the ways that having a GP may be able to help make things better for the patients within our service. There were lots of moments where I felt like being a GP in the service was really helpful for my patients, but there was one moment that I kind of remember quite clearly. I was doing weekend on-calls on the inpatient units, and I did morning ward rounds for the patients in the intensive care area, and there was a woman who was really distressed, and she was telling me unhappily about all of the things that you psychiatrists do. And after a while, I just said to her, I'm so sorry, I'm not a psychiatrist, I'm a GP. She said, oh, thank God for that. And she came out and she lifted up her nightie and showed me this really terrible rash all over her groin. And it was pretty clear that she'd been living with this burden of this painful rash in her genital area and hadn't even been able to sort of say, this is what's going on for me. So we went through a treatment plan, sorted out some creams, worked through everything. And she seemed to settle a lot just from having that one single issue addressed. So at that point, I really thought, this is a big thing. So at the end of 12 months, I had to, as a junior psychiatry doctor, I had to make a decision whether to pursue psychiatry or to return to general practice. And if I could have done both, I would have, but I'm not Superwoman, as much as I'd like to be. Ultimately, I felt that I could not let go of my capacity to treat the whole person. I wanted to always be able to be the person that if somebody came and told me about their vaginal discharge or their problems with their bumhole or their constipation, that I would be the one who would be able to say, let's talk about this and I can examine you. You can't do that as a psychiatrist. I didn't want to let go of that. And I realised that in my heart, I'm really a GP, and it was such a lovely thing because I thought, I'm so very sure now that I've followed the right career path. So I felt very strongly that the best way that I can help patients with severe mental illness was to remain as a GP and to provide physical health care in the context of their psychiatric illness within our mental health service, and to make it as easy as possible for our patients to access a GP. So trying to remove those barriers to care. And I was also quite mystified that mental health services have massive multidisciplinary teams, but they don't have any GPs on the team generally. So I spoke with our then really visionary leadership team about my ideas to have a GP on the team, and they were able to make this happen because there was some uplift funding from the Mental Health Royal Commission. So that's how this role was created, and since then I've been working to develop this service. So that was 3.5 years ago, and 6 months later we got 2 more amazing GPs on the team. And I should say that, not all GPs love doing mental health. That's okay. The ones that do it really beautifully. And so that's what we've got, and there are lots of other GPs who also love doing mental health. But we're a very specific group of people who really are very passionate about caring for patients with mental illness. So why is our service unique? I know there's a few services in Australia with GPs attached, but I think this service is different. We are embedded, fixed firmly and deeply in our surrounding teams like little tumours. We're a truly valued part of the team, and we participate in all of the team activities that help determine patient care. We are co-located within the community mental health clinics, and we work alongside the case managers and psychiatrists and the multidisciplinary team. So we're right there, and we provide... So a key point is that we're salaried staff. So we're not limited by MBS item number billings, so we provide our patients with free care. What does our role look like? Between the three GPs, we cover all case-managed clients in community and rehabilitation streams, and we specifically target the most vulnerable patients who have no GP or poor engagement with their GP, and those patients who are at highest risk of physical health problems. We see people in the clinics, we do outreach visits, we see them alone or with their case managers or support workers or family. We sometimes do just a one-off consult, sometimes we do longer-term management, we do secondary consults with other staff or community members, so we're supporting other staff to provide holistic care. We provide support and education to all staff about physical health and holistic care. We liaise with specialists, emergency departments, community organisations, and try and develop lots of connections, all with the intent of improving patient care. We join in the clinical reviews and discuss cases in that context and share ideas with the teams about ways that they might be able to help from a general practice perspective. We attend handovers. We have planned appointments, but if we're available and something comes up, then we'll do urgent reviews, and sometimes we'll just pop in during a case manager appointment to try and build a rapport with somebody who's really struggling to engage. We provide patient-centred holistic care and help our patients understand that this service is about helping them to address their own concerns and not feel like this is one more thing that we're doing to them. This is about asking people what their concerns are and trying to support them to access the things that they want and need that will help them to feel better. So generally I'll go in and introduce myself, explain the role in the clinic and just ask, how can I help? What do you want to do? How can I help you? And over time, there's also a shift in focus within our service to capacity building amongst staff so that everyone can take steps to support patients to improve their physical health. So we're having kind of like a culture shift where the whole organisation is bringing wellbeing into everyone's sphere, and it's becoming everybody's business to make sure that physical health is improved for all of our patients. And when I tell people about the work that I do, everyone says that's such a no-brainer. But as we keep on discussing throughout the conference, we need evidence to continue to strive for the best possible practice all the time. So part of my role has also been to do research, and I'd really love to be able to say that we have all this wonderful data, like we saw this morning from South Australia. You know, if I could have pulled data about saying things like, well, we've reduced emergency presentations and we have reduced morbidity and mortality, but the truth is we have, within mental health services, we have a very old clunky data system, not even like an electronic medical record. We don't have GP software. And so everything needs to be kind of manually extracted. So I'm sorry, I have no such data. But one of the projects that we are doing is this beautiful qualitative research, which is exploring the clinician's experience of caring for patients with mental illness. The trophy grant that we got has enabled us to have a professional external interviewer as part of our project, and that hopefully makes the research less biased and more robust. And research has been such a huge learning curve for me because it's just like learning a whole nother language, I think. So that's been a big thing. But fortunately, I have the wonderful Regina on my team, along with a bunch of other people. But Regina's has such a good handle on qualitative research and how to go about it. So she's going to talk a little bit about where we're at with all of that. Thank you.
Thank you, Dr. Simone, and that was really beautiful. Good day, everyone. My name is Regina Tsai. I am a clinical nurse consultant working at Hamilton Centre Eastern Health, which is a statewide centre that we provide specialist service for people with dual diagnosis of mental illness and substance use disorders.
Sorry, I didn't advance there.
That's okay. All good. So a little bit about me. So I was born and raised in a small town in China, and as some of you might know, mental health is still hugely stigmatized there, unfortunately, because people don't want to talk about it, and some of them, they choose not to talk about it. So that motivates me to talk about it more and having my voice in different conferences. So my passion towards this integrated care and particularly embedding the general practice within the community mental health services comes from witnessing so many firsthand the significant physical health side effects and issues experienced by my clients. So when I was working alongside with Dr. Simone as a mental health case manager in community, so many those issues, they go unrecognized and untreated and even picked up far too late. And from this 2 days conference, we know there are so many shocking statistics and morbidity and mortality gap that is still very heartbreaking as a lived experience carer. So I want to share a personal moment that kind of pushed me towards this research work. So I still remember that powerless and helpless feeling when a client told me about their serious physical health concern. And because we have very limited physical health resources within the organization, all I could say is go to see your GP, even when I knew, how hard that was in the reality. So that moment stayed with me for 3 years and pushed me towards this research. And from there, I began to take a more serious look at the physical health needs of my mental consumers and became deeply interested in the integrated care models. So even when I changed positions and changed teams, throughout the last 2-3 years, this project still holds a very special place in my heart. And I want to acknowledge a great thanks to the Equally Well framework and our local committee led by senior nurse Harry Singh. And with all this support, we were able to carry out this project with Dr. Simone's great passion and compassion, as you can hear in her speech. So I want to talk a little bit about the dry stuff. So this research model is known as the reverse integration model, where instead of we are trying to make the GP clinics more mental health capable, we are bringing the GP directly into the mental health services. And the benefits of that is that mental health services cannot ignore any physical health problems that picked up and make it more one-stop shop instead of the wrong door, we are sorry. So although it is relatively new in research in Australia, there are some really great international evidence, particularly the ones from USA and UK, are showing a lot of strong evidence. So some of the benefits that it shows are improvements in access to primary care, of course, and reductions to avoidable ED presentations, and a better continuity. So they've achieved a higher screening rates and more consistent monitoring of chronic conditions, and in some cases, improvements of overall quality of life. However, integration isn't always that straightforward. Literature consistently highlighting some long-standing systematic level barriers, such as the separate funding mechanisms, the incompatible IT platforms, like Simone was saying, we wish we have, all the same information stored in one system so we can, share them much more easily, and also that long silo and divide between mental health and physical health care. So being one of the first reverse integration programs in Australia, we are seeing similar challenges here. One very practical limitations was the clinical rooms. So sometimes, we are competing with the interview rooms that's completed by the mental health teams, and we need to borrow them, and there's no proper beds or curtains set up as such. But despite all these challenges, I want to still highlight that the benefits still outweigh the difficulties. And that's why growing this model requires very strong local evidence and, importantly, more multidisciplinary voices like nursing, allied health, medicine, psychiatry, peer workers, policymakers, because this is not something that one profession can solve alone. So a quick timeline of our research project so far. So we spent probably about 2 years just talking about it, and then really get it going is probably just this year. So the ethic approval was approved around May this year, and then we have our recruitment shortly occurred afterwards. And it is occurred in 3 phases, so we can, have some target promotion around disciplines, and then have organization-wide promotion, so we can ensure that everyone who wants to attend and fits the criteria won't be missed out. And then the interviews that commenced in June, and then we have already finished it in early September. And at the moment, we are working on the thematic analysis with a team, with monthly discussions to categorize those themes and findings as we agree on. So here, I just want to show you our flyers. So it's printed both digitally and as a paper form. And we have a wonderful research team, including 7 clinicians Myself as a nurse, we have 3 GPs. So all the GPs that's involved in the program, they are helping us to promote the study. 1 lead psychiatrist and 2 mental health researchers of social worker and chiropractor background. So this multidisciplinary approach also been crucial in shaping our project so far. In total, as you can see, we have 36 participants signed up for the study, and we have a range of representations here. So we have registered nurses, enrolled nurses, occupational therapists, psychiatrists, psychiatry registrars, social workers, and team leaders. So this just want to show, it does provide a rich and comprehensive set of perspectives in our study. And in total, we have 19 professionals that was selected and included to complete the one-on-one interviews. And just want to quickly point out, although this qualitative research, we want to in-depth analyzing, how mental health clinicians are thinking about or viewing about this program, we also want to acknowledge that co-design has been an essential part, although the criteria didn't, include, but we have some initial co-design consultations with lived experience workers and the carer peer support. And together we identified the research priorities and safety considerations and ethical issues. And after we conduct some informal surveys with clients to test early ideas, that we decided to begin with the low-risk clinician perspectives. So this will help us, to create a safe and stable foundation for the first evaluation cycle. And in future phases, so we can include clients directly to have the research projects. I want to share some early findings. First of all, our clinicians have consistently described that embedded and co-located GP surveys have been highly beneficial for them for holistic client care. And I'm very also glad to hear that many of them report also increased their own clinical confidence. Like their knowledge has been increased about physical health, and they actually have a greater job satisfaction, which I didn't expect as much before the study. There are some practical suggestions also emerge, including expanding GP coverage across additional mental health sites, because at the moment it's only community, but if we can think about maybe acute, subacute, rehab in different settings. And also maybe expand the GP scope to do more training and education and potential vaccination clinics. That was one of the emerging themes. So looking ahead, our aim is to develop a structured annual evaluation tool, and we plan to embed ongoing consumer co-design so the model continue to reflect, the service users' needs. Thank you so much for listening.
Oh, there's a revolution in the making. Well, it's already being made. It's made. A question from Helen Piper. Is there a national register of mental health GPs?
No, thanks for that question. No, that's not that I'm aware of, but you might know, Michael. No, but no, I don't think there is, and but it's a great idea, isn't it? I think that sort of thing happens more from word of mouth. People sort of get the idea that somebody is more of a mental health GP. I think that with community GPs, though, the risk is that if you see only mental health, then it can lead to burnout because it is a lot to carry when that's the only thing you do. You sort of also need to see, you don't want to de-skill in the other areas as well.
That's a conversation that needs to be had within the community who want to do this as well, isn't it? How do you prevent burnout? How do you support each other? Yeah. From Josie, hi Simone and Regina, fantastic initiative. In regards to embedding the GP roles into the pre-existing multidisciplinary team, curious to know more about what strategies were used to embed this position into the team to foster interdisciplinary practice, inclusive of the consumers, e.g. particularly communications processes, care planning, etc. Josie from Nimai.
Sorry, I don't think I'm...
Yeah, sure. So that's a really good question. So this program has been around for 3 years. So initially, I think like we are raising the awareness among the team just by word of mouth. And our 3 GPs, they possess very valuable personal qualities of like being very approachable. So I think like being there, being co-located in morning meetings so everyone can see that you are there, and being in the office where mental health clinician sits, they can just bring a physical health question over without being silly, and then just ask about it and then discuss about the client in a very safe and confidential way. So I think that helps the program to raise the awareness and increase the communication very effectively. And then this research also helped raise the communication among the teams, because when I was promoting the study, surprisingly, some mental health clinicians never actually utilize it. But because of the research study, they become aware of it, and then they start becoming very interested in it. And we have allied health like dietitians, and we have we have OOTs probably like in the same organization. They just become aware of each other and start utilizing each one. Yeah.
Becoming aware of each other. Are there many men who specialise in mental health GP and nurse practitioner work?
Yeah, the 2 other GPs that are in the clinic are male, so
yeah. I was just interested to know.
It is interesting, and they tend to get more of the men's health kind of stuff, whereas I get the women's health. Not that we can't all do both, but it just sort of, and people feel more comfortable sometimes with one or the other.
Yeah,
so.
Yeah, absolutely. Dave Peters giving the best questions. I don't mean to rave, but just sharing a lot in the course of giving a question. Sorry, Simone. I love that colleagues respond to your description of your work saying it's a no-brainer, but have any of these responders commented about why they haven't or can't also focus on physical health despite their no-brainer attitude?
I think that comment is not necessarily coming from colleagues. That's a general comment. But if you're asking about, are you asking about why GPs in the community don't focus on mental health? Oh, inpatient services. Well, because they're training in psychiatry. The doctors who are looking after the patients are training in psychiatry. And I think that the further you go from medical school, the more you forget about the general medical stuff and the more you learn about the specialist stuff. So you kind of unless you're doing something all the time, you're not as confident. So they lose confidence, but the thing about having us as GPs there is that they can come to us and ask questions, and then we can reassure them that they do know what they're doing. So it is upskilling and maintaining skills in not only the registrars but the psychiatrists as well, because they sometimes feel loss of confidence, and we can say yes, you can actually do that. Or you've got the right idea. So it is good.
And just never forget the pain of a rash. Question. Yeah, the pain of a rash, an ignored rash, so much suffering. So much mental health burden when you're carrying a serious skin experience. It's just, we've got to get it right. Hi.
I'm sorry, Mike. I just had a question. I hope there's the GPs are getting supervision and support in their role in the clinic as well. That just wasn't mentioned. I mean, you'd be able to do peer supervision, but then something else as well. So.
Yeah. GPs aren't sort of formally required to get supervision like psychiatrists are, but certainly within our organisation we have supervision available, and also GPs do. I think actually this has changed just in the last couple of years with the new continuing medical education, that it is kind of fitted into our ongoing stuff that we need to do. So yes, we do it, and I do it on multiple fronts.
We can't hear you without the mic, so I might get you to follow up afterwards if that's all right. Quick question here.
I haven't heard anything about intersectionality and who's responsible for uncovering the different impacts from people's intersections in this process, if you're talking about a holistic healthcare system.
Thank you. Do you want clarification?
Maybe, yes,
Yeah,
sorry.
well, you know, the impacts of being LGBTQI, impacts of being Indigenous. Hello, hello, hello.
Yeah, no,
Thank you.
I think that's, that's something that has come up within, I think it's come up as a small theme within the research so far, is that it would be nice to have a GP who specialises in that. But I guess I feel as though we are very broadly mental health aware, and I've certainly had patients from the LGBT community that I'm caring for within that role. So it's, it's not like...
Can't hear you if you're not on mic. Sorry, I'm going to have to keep it moving. I'm going to have to keep it moving, sorry. Yeah.
Let's talk about this after.
Yeah,
then. Thank
absolutely, because
you.
it is a vital thing, and it's also as much about anything as about reading as much as you can to climb inside the shoes of your patients.
Yeah,
and
and
who are
involving
living
specialists whenever
across
there's
the
anything
intersections.
we're not sure of as well.
I'll take one more question very quickly.
Amazing work that you guys are doing in there. I think it's fantastic, and I know that you mentioned there's some other work happening with GPs being integrated. I think our silent rehab services had a GP come in, which is fantastic. I guess my question is, obviously you're engaging with people that maybe aren't within your service and providing that GP care. When people are, I guess, discharged or leave the care of your service, how does that GP follow up? Because obviously they've established a really fantastic therapeutic rapport with you. How does that then continue once they've left your service and are receiving that care ongoing in the community?
Yeah.
Quick response.
Yeah, so with any of our patients, then we're always thinking about discharge planning and finding a GP in the community that somebody is handed over to. So yeah, that's always a part of it. But I could talk for hours about all of this.
So two statements from both of you about advice for setting up such a service. For people who are interested in setting up such a service in their area or having the conversation.
I think you've got to approach the local health service about whether this is a feasible thing, and we're really hopeful that having this research published will actually be something that other services can say, all right, here's something that we can go to government and ask for funding for having GPs embedded in the service.
Great. And would you like to add one? About setting up such a service, what would you recommend?
Yeah, so I think... local resources and organisational support is definitely the biggest thing.
Okay.
So we are very lucky to have the local Equally Well committee, and I think that is the very primary step that we got support. And our senior nurse Harry Singh is sitting here today. If you're also interested in such model, he can be approached to give you more information.
Great. Thank you so much. Simone and Regina. And obviously you're all here, so it'd be great to... And there's a little prezi for you both too. Thank you for your questions. I'm aware that I was rushing some and didn't come back to a question about intersectionality over there, and you had a follow-up too over there. I respect that I couldn't come back to you, but let's keep that conversation going, perhaps via email or via the WhatsApp. So thank you to both of you. Now, smoking is many things, isn't it? It's big tobacco. It's a massive industry, it's a corporation, it's a blight on the world's health, it's a killer, it creates cancer, it creates heart disease, chronic lung disease, immune compromise, type 2 diabetes, fertility issues, eye health disasters, emphysema, all of it. But if we are to be frank, and you would all know this from your lived experience or the work that you do, the act of smoking, I would say, I'm not a smoker, but I know many people who have found it a form of self-medication, very important, of comfort, that one form of agency that you have in your day, wherever you happen to be, whether you're in a hospital situation, the internal courtyard of a hospital, what's that moment where you can take control? It's to have a moment with a cigarette. So, it's a very powerful drug. And it's very, very relevant to our conversation today because it is the portal to so many health problems. To present on a customised, I'm very excited by this presentation, on a customised smoking cessation support program for consumers at Adelaide's Trevor Parry Centre in Noongar. It's a 20-bed residential mental health rehab unit with the Southern Adelaide's local health network. Michelle Quirk is joining us. And she's a community rehabilitation worker at the centre. She supports mental health consumers or guests to exist as equally well as the rest of society. She did a master's thesis in philosophy and legal studies, which became a book called Informed Consent for Schizophrenic Patients. That's the title. And she wrote that as a scholar, but she is also has lived for over 30 years with lived experience and with a diagnosis of paranoid schizophrenia. So please welcome to the stage Michelle. Her other half, who was going to be bringing occupational therapy experience to the stage, was unwell, so or couldn't attend today for various reasons. So Michelle's being very stoic and taking the stage on her own with the support of Sarah Skinner from South Australia Health, from SALN, which is the Southern Adelaide Local Health Network. So thank you so much. You're going to do the clicker, you're going to do the talking, and you're going to be the listeners and the questioners.
Hello everyone, I'm Michelle, as I've been kindly introduced. So I'm talking about the Beyond the Smoke Rehab Support Program down at Trevor Parry, and it's for our residents wanting to reduce or give up nicotine or vaping or cigarettes. An outline of this presentation is around 11.2% of Australians over 15 years smoke. This increases to 32% for people who live with mental illness and up to 70% for those living with more complex mental health challenges. A survey of smoking habits at Trevor Parry Centre in 2024 found that 60% of the residents were interested in reducing or quitting tobacco use. The TPC is an SA Health facility, and all SA Health facilities have a policy of no smoking on the premises. The TPC has developed its first program to support residents who are interested in quitting or cutting down to explore and create their own plan to address their tobacco use goals. There are common misconceptions about mental health consumers and smoking. They don't want to quit. Mental health consumers want to quit just as much as everybody else, and most have tried to do so at some point. Quitting will make mental health conditions worse. Anybody who quits smoking is likely to feel better, both physically and emotionally. Symptoms of withdrawal, irritability, restlessness, anxiety, difficulty sleeping, etc., are often mistaken for indicators of deteriorating mental state. There is no evidence to suggest quitting smoking makes symptoms of schizophrenia, as one example, any worse. It's impossible to change. Consumers may be facing multiple other factors that add to the challenge of quitting: lack of access to meaningful occupation, social isolation, fewer resources available to them, but quitting is possible with the right support and treatment. The reality: most of these myths are stigmatising and capitalise on vulnerabilities that we are duty-bound to address as mental health professionals. Rates of smoking in the general population have reduced over time, but not for the mental health population, broadening the disparities. Mental health consumers are already facing significant health disparities as compared to the non-mental health population. The health impacts from smoking cannot be ignored, just like any other health concern. By not addressing smoking as a health issue for our consumers, we perpetuate some of these unhelpful myths. Smoking cessation support needs to become part of our core business. So, what does the evidence tell us? What is an effective approach in services similar to ours? Taking repeated opportunities to check in with people about their smoking in a non-judgmental way. A structured approach to assessment and treatment. Assessing nicotine dependence, willingness to quit, motivational factors. Offering education, behavioural support, plus pharmacological intervention. Arranging follow-up to support motivation and assess progress. The Trevor Parry survey results. Why would you want to, as a consumer, reduce or quit? For health reasons, for family, for money, or because you stop doing other illegal things. As you can see, health and money are hugely popular as one of the reasons that people want to stop. So what strategies have been used in the past? This is from the survey. A lot of people have tried cold turkey. Just as many have tried nicotine replacement therapy, Champix, which is how I actually quit, exercise, vaping. Some people can quit cigarettes and take up vaping, but it's debatable whether this is a better choice. Chewing gum, avoiding smokers, not buying as much, and avoiding and showers and steam and eucalyptus oil. So various strategies that have been utilised. The Trevor Parry survey results. So how many times have you attempted to quit? Way above 10 times, less than 10 times, more than 50 times, and millions upon millions of times, tried repeatedly. What benefits do you get from smoking? It relieves anxiety, stress relief, it provides relaxation, it decreases your appetite, gives you a relaxing break from whatever you're going through. There's many different reasons that people do smoke. So what have the TPC residents told us? The barriers to ceasing tobacco at the Trevor Parry Centre is because it's routine. You might get up in the morning and the first thing you do is have a cigarette. Stress, if you feel stressed about an appointment or something else you've got to do. Boredom, you've got nothing else to do with your time because you're addicted or because everyone else around you smokes. It affects your mood, improves your mood. It gives you some social time with the other smokers out the front of Trevor Parry Centre. It gives you something to do, an occupation, and it gives you a bit of free time to yourself. And maybe due to a lack of comfort in a situation. So, best practice smoking.
Hang on, the clicker's not working. There we go.
Thanks, Sarah. So, best practice smoking cessation and change. So, a recovery-orientated approach. The principles of a recovery-orientated approach include understanding that each person is different and should be supported to make their own choices, listened to and treated with dignity and respect. Residents can attempt to go cold turkey versus developing their own plan and supports, such as information and brochures on managing. We've got quite a few varied ones of those. They can try different ways to cut down or contact the Quit Your Way service or alternative support groups, apps. Quitline is very popular, or involving themselves in the Trevor Parry Centre Beyond the Smoke peer support group. We also provide education and information, provided in a range of different formats and is relevant and accurate to the consumers. So, Beyond the Smoke program process. Connection, so connect the consumers to the right material and supports. Hope, affirming their goals and aspirations. Identity, actioning new habits and behaviours. Meaning, to design and co-author a tailored plan. And empowerment, choice and control over your direction, goals and engagement. So, the Trevor Parry Centre program process. So, session 1 is an intake assessment. So, an appointment's made with one of the Trevor Parry Centre nurses to determine the level of dependency and considerations around their medications. Exploration of the reason why you might smoke and where you want to change your relationship with smoking. Excuse me. Getting information about smoking and quitting. And in the end, making your own decision. The next steps is an involvement of and conversation with your preferred team. This will include your psychiatrist, your GP, and other staff on developing a tailored program. Session 2 is titled Getting Ready. So identifying triggers, short and long-term strategies, including nicotine replacement therapy, Quit Buddy, Quit Line, free programs and apps, and having support from your nominated buddies. There are ideas developed and plans for change, including what to do when there's slip-ups and setting a date and starting out. So, barriers and enablers to supporting smoking cessation in mental health settings. Some of the barriers are no smoking support, family and friends who smoke, no access to NRT, smoking culture and norms, staff attitudes and implicit bias, consumer stress and boredom, task-rich, time-poor staff, enablers to seek helping individuals cease smoking, well-trained staff, working with fluctuations in motivation, having an integrated approach, preference-based support, bespoke smoking cessation programs, interventions targeting specific alternative coping strategies, protected time and space for smoking cessation to be discussed. So, what's our current state at the Trevor Parry? An audit of 12 discharges was conducted on CBIS. This looked at the first physical health assessment compared to the final physical health assessment. 2 residents had reduced tobacco consumption since being at TPC. 4 residents had increased tobacco consumption since being at TPC. And 1 resident had remained the same in tobacco consumption since being at TPC. Things to be noted from the audit. 5 patients had information gathered at 1 physical health assessment, but not the other. And there was a lot of variation in the way smoking information was collected. For example, was it collected by grams per week, per fortnight, dollars spent per week, per fortnight, or the cigarette smoke per day, per week? So the way the information was collated changed between clinician to clinician, so we had to work on trying to make that more consistent. Also, if a patient has a short admission, smoking information was not collected. So, okay. So now we're moving on to the lived experience perspective, which is me. Okay, so the topic of vaping and smoking is a significant issue within the mental health community, whether that be for consumers, family, friends, or supporting staff. People living with mental illness are far more likely to smoke cigarettes or vape. As you've heard, people living with mental illness are up to 3 times more likely to smoke than the general population. That's not just a statistic, it's a reality that impacts lives every single day. Smoking doesn't just harm physical health. It can interfere with medications, making treatment less effective, and it increases risks for heart disease, diabetes, and respiratory conditions. These are serious consequences that shorten lives and reduce quality of life. I want to share something personal. Quitting smoking had an immense impact on my health, not just physically, but mentally too. When I finally managed to quit, it felt like a huge achievement. I had more self-belief and more confidence in my abilities. The benefits were many. More money in my pocket, no lingering smell, no cough, more energy. For anyone living with mental illness, self-esteem often takes a hit. So when you accomplish something that makes you proud, it can have a powerful ripple effect across the rest of your life. It's not just about quitting a harmful habit. It's about reclaiming control and proving to yourself that change is possible. Working on my physical health, starting with quitting smoking, changed my path completely. Today I work full-time and even have a mortgage. Over the years, I've completed a master's degree and found a job that connects deeply with my own life experience. My journey wasn't fast. It was slow and full of small steps. But those steps added up to real change. Every milestone mattered, and every setback taught me something valuable. My passion for helping others quit or reduce smoking and vaping comes from my own lived experience. I want to support people to reach a level of wellness that gives them the best chance at a full and satisfying life. For many in the community, quitting might seem simple, just apply yourself and stop. But for those living with a mental health diagnosis, it's not that easy. Addiction is complex. Nicotine isn't just a habit, it becomes a coping mechanism, a source of comfort during distress. Recovery is a journey of self-discovery, and every attempt teaches you something new about yourself. For me, quitting cigarettes was incredibly hard. I relied on them during the worst times, when the voices in my head were screaming about uncomfortable, unwanted things. In those moments, there's little you can do to feel normal or participate in life like others do. A cigarette gave me relief. It helped me appear calm in public, soothed my nerves, and offered a small sense of pleasure when everything else felt unbearable. When I couldn't sleep night after night, cigarettes were my comfort, my joy. Giving them up was the hardest thing I've ever done, and that's saying something. It took many attempts, but each time I tried, I learned something new about myself and why I had initially formed the habit. That's what I share with clients in the Beyond the Smoke program at the Trevor Parry Centre. Every attempt matters. Every time you try to quit or cut back, you learn something new. For me, oddly enough, keeping a packet of cigarettes with me worked. Knowing they were there if I really needed them gave me a sense of control. It sounds counterintuitive, but it helped me break the cycle gradually instead of feeling trapped by an all or nothing approach. Programs like Beyond the Smoke aren't just about quitting. They're about understanding triggers, building coping mechanism strategies, and creating a supportive environment. It's about progress, not perfection. If you're a clinician, ask about smoking habits. If you're a family member, offer encouragement without judgment. Every conversation matters. These small interactions can plant seeds of hope and change. I'm grateful for the chance to speak to you today and the benefits of prioritising physical health, even when it feels secondary to mental health. Quitting smoking can feel impossible, but the benefits are profound. It strengthens your mental health, boosts your confidence, and proves you can achieve your goals. For those living with mental illness, quitting smoking offers more benefits than most people realise. Everyone deserves the chance to live longer and healthier, and that's what Equally Well is all about. I embrace that fully. Thank you for listening and for supporting the journey towards wellness for all.
Wow. What can I say? I just think you've embodied the entire 2 days with that last half of your presentation.
Oh, thank you.
Unbelievable. Michelle. Stay on stage. Woo! That was just brilliant. And I really loved the way that, in a number of different ways, you said that every milestone mattered and every setback taught you something valuable. Many attempts, each time I tried, I learnt something new about myself. And also just that sense of power that came when, and I wonder if this also applies to, you know, going and getting a mammogram or overcoming the fear of, you know, getting a pap smear or, you know, when it's almost like that thing about doing your tax. It's like once you've done it, you feel like you can take on the world. But, you know, that this is sort of a portal into so many other conversations.
Yeah, it is. It is. It's like getting physically healthy. I mean, that's empowering too. You know, these little things about improving your physical health are just so important in relation to your mental stability. It really is.
Unbelievable. Any questions, comments, shared experiences, stories? Yes, thank you. And I'll hold the mic. Yeah, yeah. I'm being a boss on the mic.
Hi, I'm Catherine. That was really great, and that, as you said, that the second half was I could really relate to. So just wanted to say I kept a carton of cigarettes in a top cupboard for 12 months.
Wonderful.
Just knowing they were there was good.
Yeah.
But yeah, it took me 3 attempts, and I actually walked the same path as you. So
Oh,
amazing. Yeah. So
thank
it
you.
isn't really counterintuitive. It just worked.
Yeah.
Interesting. Did I see another hand go up before? No, not yet. Oh yes, thanks, Ta.
Okay. The nicotine replacement therapies, are they funded by you, or do the participants have to be? Because that's the biggest barrier.
I know.
The medicinal vape is fantastic. That's how I quit after 30 years of smoking.
Yeah.
I was on that for about 2 or 3 years, but it wasn't costly, but cheaper than cigarettes, but
Yeah.
still costly.
We're working towards doing that because, no, at the moment they're not. And there was the old NIFSA used to run a smoking cessation program, and they did. If you attended for a couple of weeks continuously, they would give you NRT.
Just stay on the mic.
Yes, sorry. But our biggest barrier has been Chop Chop, which is the illegal tobacco, because people can afford it more easily. And we've had more success with people that don't like the taste of Chop Chop.
Yeah, that's interesting. Look, that was a fantastic presentation. Thank you. Yeah, and I think I don't want you to halt your applause. So, but I would love to see, if you were willing, that piece put somewhere and distributed through your website, the Equally Well website or something. Like that should be published. What you just said. Yeah, that story, that first person story would just people would. Yeah, I think that will have impact. Thank you, Michelle. And we have a little prezi for you as well from Lee. Lee's doing the honours. Thank you so much. Final panel of the day. Do you want to just stand up and have a bit of a sort of stretch and just 2 minutes, nothing fancy, or sit down and have a stretch, twist in your chair, whatever works for you. And I'll get Dave Peters, Jeff Harris, Julia Kim, and Tom Johnson. I haven't met Julia yet, so I'm looking forward to clapping eyes on you. Oh, there you are, yay. Hi. Could I have the next panel just to come and have a quick 2-minute brainstorm with me on a few things I want to check in on? Where are we? Yeah, come on over. This is good. It's a good opportunity to have those conversations. This is what it's about, I think. Because I'd prefer to sit down. This can't be moved, can it? Not at all. Can't move it down to there. Thanks for doing that. That's great. Yeah. Thank you for that. That's good.
That's all right.
We're okay. Yeah. We'll just do a quick sound check. Just talk into your mic. Do a quick sound check. Yep.
Is that actually on?
Can we do a quick sound check? Yep, great. So just keep talking into the mic.
Hello.
Yep, great. Quick sound check. Hello.
1 2 1 2.
Testing 1 2 3.
Love it.
1 2
Ooh.
1 2.
Yes. That's right. Channel your inner roadie.
It's been a few years, can you tell?
All right, let's go. Am I being a bit bolshy? Sorry.
Did you say bolshy?
Yeah.
Or bossy?
We thought we'd take this opportunity to wrap in a way that both involves our panel but involves you. Two things that I'd like you to think about in this conversation. Let me just get to my notes. And I would really love your participation. Why are you here? You don't have to get too existential about that. But why did you come today? Like, what was there a curiosity? Was there a hope? Is it core business for you? Is it new to you? I'm interested to know why you've come. So I'll come to you at some point. And then what would you like to do on Monday that connects back to these 2 days? Now, look, that's a bit much, isn't it? Monday, maybe you're having a long weekend to have a little break, but it could be Tuesday or Wednesday, but Monday is the sort of, concept. So just have a little think about what kernel you've taken away, and I'd love to rove the room with you. And you might sort of reinforce each other, talk to each other, ask questions of each other. But we also wanted to have a bit of a wrap conversation that leaves you with a sense of possibility. So we can restate the problems to an extent, but we're going to try not to focus on kind of some visions here. And I'm really pleased to say that I'm joined again by Dave Peters. Hello.
Hello again.
Champion of the WhatsApp channel for the conference. I just want to reiterate that some of you are joining on the live stream as well. If you've stayed with us this long, love your work, and we'd love your input on the WhatsApp group as well. If you'd like to, why did you tune in, and what are you taking away with you for Monday? We've got Dave Peters, who is co-chair of Equally Well Australia. Did you know that he's got a performing arts and musical theatre background? I think that says a lot.
I don't really talk about that very much.
And passionately challenging his own lived experience of recovery into helping improve services and systems and outcomes for all of those of us who use services. Jeff Harris, hello. There you are, Executive Director of the Mental Health Coalition of South Australia, which means that's the peak body for community-managed mental health sector organisations or centres here in South Australia, really focused on enabling better approaches to physical health needs, human rights, lived experience workforce, likes to call a spade, I think, which is, I'm really looking forward to your contribution, so thank you. Julia Kim is representing Lived Experience Australia, and she conducts lived experience research with Equally Well Australia as well. The thing is, she's also a final year medical student. And not only is she a final year medical student at Flinders Uni, she's also the Senior Vice President of the Flinders Medical Student Society, and she's President of the Health and Human Rights Group. So she is going to make some changes. Neuropsychiatry research background. Great to have you here. Tom Johnson is Director of Advocacy and Engagement at the mighty Consumers Health Forum of Australia, with more than 20 years experience across government and higher ed and community sectors, really amplifying the voices of people experiencing health disadvantage. He was also, and I love this intersection, Deputy CEO of the Council to Homeless Persons, amongst other roles. So yeah, let's just say welcome. All right, I'm going to just do a little power session with you all. Why do you care about the conversation that we've been having here from your perspective, this intersection between mental illness, mental ill health and physical health? Tom?
Always difficult to be the first one off the ranks of the
Sorry.
panel, so that's okay.
Speak from your heart.
That's okay. I've been humbled since I've been, sitting around here. It's been great to come on the first day and sit at a conference and actually sit and absorb and hear. Thank you to all of those people that identify as lived experience advocates for sharing your voice and your story and your journeys and your insights. That's the beauty of coming together at forums like this, where there's an equal voice and a conversation. I think that the key thing that we can take away from this conference here today is that there's a momentum, there is a conversation, there's so many different ideas, but I guess what we heard from the Productivity Commission findings is that the approach at a macro level from the enabling isn't working as it currently stands, but they've mapped out a pretty good framework and they talk to people along the way. So, yeah.
Yeah, interesting. Dave?
I started my journey into Equally Well, I guess, finding out about my own medication side effects and the physical impact of those. And just remembering being absolutely outraged that these unknown side effects, unwanted, but, can be manageable if you talk about it and plan in advance. But that discussion never happened. With one particular doctor, I put on 40 kilos in 5 months. And, complaining afterwards, like, oh, well, that's a known effect. It's like, I didn't know it. So I thought it was absolutely outrageous, the injustice. So that's kind of what started me off with Equally Well. But then it's like, well, hang on, this is a groundswell, a grassroots movement. And I can make a difference. I can help make a difference. And that's ultimately what I want from my life, is to help make a difference. So that's why I'm here, and that's why I love it.
Yeah. Julia, your perspective, your interest in being here.
Yeah, the main reason why I'm here is initially I was interested in psychiatry and neuroscience research, and that's how I started it all. But the more you actually look into it and do research I've been doing research with Russell and Sharon for the last 4 years, and you get surprised by the statistics, the gap and the inequity between the general public and also the patients who experience mental health issues. So it alerts me that as a medical student who's interested in psychiatry, there is this gap that needs to be addressed. So I wanted to learn more about it from this conference and also learn from these amazing people who have so much to share.
Do you feel, as a medical student, and you're final year now, aren't you? So you're
about to graduate,
about to launch. Yeah, congratulations.
Thank you.
Do you feel? How do you feel this conversation about the intersection between mental health and physical health has been addressed? Like, is there a literacy about this gap amongst your fellow medical students?
Yeah, so interesting you're saying that. So I feel like in the last 4 years, there was actually much more recognition within the medical school. In my first year, I think medical school didn't cover too much about the health and the biosocial models and everything, but we get more within that medical school curriculum. There was much more incorporation in the last few years. But one thing is that the nature of being a medical student means you have so much to learn, and if it's not assessed, you might not actually study for those things, right? So I think if it was put into more focus as part of your curriculum, I think that could be better with the medical students. Yeah.
Can I just come back to you though? Why are you president of the Health and Human Rights Group?
I'm interested.
Yeah. What's driving that interest? Because that's very unusual for a medical student. And I love the fact that you're at that coalface of activism, human rights activism.
I'm quite interested in the culturally diverse and linguistic group. So I think supporting those overlooked population who might have mental health issues, who might come from a refugee background, people who are not well seen in this public, but actually have so much to be taken. They need more support, and I think that needs to be seen widely, especially in the medical field, because they're more vulnerable and they need more attention and care.
And people need more understanding.
And more understanding, yeah.
Wow, I'm excited for where you head next. Jeff Harris, Executive Director of the Mental Health Coalition of South Australia. Why does this conversation interest you? Clearly, you are at a very interesting coalface representing the community mental health sector.
Well, I think Dave stole my words. So,
all part of my cutting plan.
Yeah, beautiful work. So, at one point, I had my office in the CBD in the southern area, and this guy called Robert came in. He looked kind of homeless, and he talked to me about all sorts of things, and then emailed me about a few things. And one of them was a report by a bunch of US directors of mental health, which talked about how people with severe mental illness died 15 to 25 years younger than the rest of the population. And like, when I looked at that, I was kind of outraged, really, that that happened, and that nobody was really talking about it. And it took a homeless guy to tell me about it. So, and then...
Well, he's an expert.
Well, he was. He was amazing, like a really, really smart guy, and much better researched on some areas of mental health than I was, for sure. And then he said, "Oh, you got to do something about it." And it's like, really? So we ended up finding some money and brought one of the lead authors across from the US and did a bit of a national tour with him, and like including going to the local Royal College of Psychiatry in a couple of different states, where he talked about that and a few other things. Like another outrageous thing is the polypharmacy stuff. And so he said, like in my role in the States...
Spell that out.
Sorry?
Spell that out for us.
Oh, the polypharmacy thing?
Yeah.
Oh, so it was talked about a bit earlier.
Multiple medications.
Yeah, multiple medications with...
No tracking.
No known clinical benefit. So several antipsychotics, for example. And so he said...
Stacked up on one after the other.
Yeah. And he said in his role in the States, he can write to psychiatrists, to prescribers, and say, hey, on your list you've got 10 people who are getting multiple antipsychotics. The only known benefits of this is this and this. Suggest you review it. And so this, and like when I went to talk to people in Australia, it's like, oh no, we couldn't possibly do that because that's a Commonwealth thing, and so I'm kind of really passionate about it because it's so unfair, and in terms of human rights, these are the kind of outcomes we need to be looking for, not just mental health outcomes.
So looping back to you briefly, you actually asked around for, and you might need to explain what you mean by psychosocial providers. I know many of you in the room know, but it's always good to spell things out, I think, to be inclusive. You asked them what they're doing to address the equally well. Sorry. Whoops.
Freudian slip.
The equally well consensus statement responding to the hellish situation out there. No. Yeah. So what was your motivation? And just give us the headline of what the outcome was.
Like I sit on a committee that young Lisa Wilton is on, and she gave me a bit of a stare and talked about what are NGOs doing about this, about equally well. So we kind of hatched up a plan just to consult with the non-government sector. So there's a bunch of services that are funded by the SA Health, so South Australian Government, to deliver psychosocial supports to people.
For example?
It's a general kind of service around... so if I move to the findings, like essentially what they do is they use a tool like the Campbell Assessment of Need to have a discussion with people about how things are going in different areas of their life, and then work on what people want to do and work up a support plan and then go from there. And it could be anything. So physical health's part of it, but it could also be relationships, work, like just all sorts of things.
Okay.
And so we specifically wanted to know with the equally well statement, what are they doing in response to the 6 elements of that? And basically every person in that service gets asked about their physical health, and where there's things that people want to work on, then it's in their plan in terms of actions. So I was really happy with that kind of response.
So that's a positive.
Yeah. So I think like we were talking earlier about good. I think it's good. It's not perfect. There's a lot more we could do, but I thought that was a good.
It's a development. So let's think then about what does good look like, just as you've been discussing over the last 2 days, and I'm interested in the panel's perspective, and then I'm interested in your perspective too. What does good look like, and how do we get there? From the room's perspective. So from your perspective, in each of your individual roles, what does good look like when we're having a conversation about the Equally Well mission? Tom, from your perspective at the Consumers Health, just remind me of how I say it, Consumers Health Forum, that's it. What's your perspective on what good looks like?
I guess lots of other speakers before us have said nothing about us without us. So I guess where we as the Consumers Health Forum of Australia, we're the peak body for everybody that's a consumer-led organisation across Australia. We've got individual members as well. And what we work at the Commonwealth level, at that level. And for us, government makes decisions, be they huge decisions, like the National Mental Health, maybe declaration or whatever the Productivity Mission talked around. They make policies, they make decisions, they do evaluations, and what we see from the outside looking in is that often those decisions and that policy work and that evaluation and that, ideation, if you like, in the overall policy cycle, as I get quite nerdy here, happen in the absence of talking and engaging with the people who are directly impacted, be they those people experiencing it, be they carer, be they kin, and that happens on a very regular basis. Now, what is good is that in pockets that is happening.
Seen a really good example that you'd like to share? I'm putting you on the spot a bit, but have you?
I have. I guess the thing is, though, that often we hear the word co-design. And co-design is a beautiful thing, but it's not a vibe. It actually has to be done in reality. And when I see a survey going out and see that described as co-design, that diminishes the power of genuine co-design. And it's really important, and I hear this from consumers who I work with and lived experience advocates. Please do not use that
as a vehicle,
that idea, unless you genuinely mean, and it is hard to do.
So what does genuine co-design look like? Let's really nail it down.
Does anyone else on the panel want to answer that?
I guess it's a multi-stage kind of layered approach that involves people from multiple sides of the situation to have an equal input, and basically supporting and empowering the people that are most disadvantaged to actually have an equal voice. Hopefully they're the ones that are going to be affected most by the situation, so they should have the ones who have the most say around how this service, this tool, this whatever product is going to serve them best.
Does a survey cut it?
That's consultation. Barely consultation.
I'll come back to Tom briefly, then I'll come to you, Dave. Tom, did you want to...
I just think it's important that, someone that is a lived experience advocate talking around what co-design means for you, that's really powerful. And, there's frameworks, there's ideas around what it... Oh, I'm on again. What it means in reality is that you don't come up with a survey or an idea. You work with somebody to actually identify what is the problem we're trying to address.
Yeah.
That you don't just go to one group of people that you always go to, you reach out. So Consumers Health Forum, we help government do this work. We bring people.
I was just going to say, because sometimes
Australia.
people go, well, where do I start?
Yep.
What consumers? Some are overworked.
Yep.
Where do I start to find a cohort?
Yep. So,
and there's an anxiety around that.
Yep. So if you want to do that, then you can reach out to us, and we can support through our networks of health consumers, and we can connect you with that expertise to do that work. So but don't forget, this is at a policy level, this is a program level. If you are evaluating your program, then you don't just do that on a desktop. You don't do widgets on a board. You actually do it. But don't call it co-design. It's okay, it's not really okay not to do co-design. But if you are going to do it, be really clear about what you're doing and why you're doing it. Be upfront so that you don't create an expectation around the change that someone who's contributing their value and their expertise, expecting an outcome of change, or that their voice will be considered in an appropriate way.
Fantastic. Dave Peters, what does good look like for you?
Co-design, Beyond Sticky Notes.
Yes.
Great book. Good general example. Right, what does good look like? I could say better health literacy for the country. I could say better public awareness. I could say better social connection. I could say a better functioning health system that actually talks to one another and shares care amongst the specialties in a way that supports and empowers the person that it most affects. But it's all of those things. I could say Medicare reform to fund that shared care arrangement, to offer maybe incentives, maybe just money for the time spent to have a joint conversation and plan how we're going to divide the care of that person well. I'm seeing my psychiatrist for 2 years. He hasn't communicated with my GP once. I'm relied upon to go and inform my GP about what's happening.
Have
you? And that's kind of a legal requirement. Like he has to within 12 months. So.
Yeah, right.
Yeah.
That's awkward, isn't it? So you turn around and go, have you had that conversation yet?
No. Well, here's the medication I'm taking. Here's why I'm taking it. And, yeah.
So it's all on you.
Yes.
It's all on you. Yeah, yeah.
But I'm a layperson, very much a layperson.
Yeah,
so.
but just coming back to the Medicare question,
right.
Medicare reform, just give us the headline there. What would make a difference? What key change in Medicare would you like to see?
I think, strengthening those accountability measures for are there eligibility requirements on like if referral's made to a specialist, that specialist must inform the referrer of the outcome and the recommendations. But really, it's so much of the service now is pared down to the bare minimum, and people are squeezing out as much as they can into that item code as they possibly can. And it's not enough. So you've got a 7-minute bulk billing appointment where you can talk about one issue really quickly and walk out the script. That's not enough. So for people with the multiple needs, we need the ability to be able to serve them and do it in a way that the doctor can then live and pay their bills and pay for their mortgage. So it might be dedicated item numbers for shared care scenarios. It might be greater rebates for incentives for actually complex cases that require better and more attention. But the bulk billing clinics that are kind of just relying on turnover to pay the bills doesn't provide comprehensive care, but often those bulk billing clinics are some of the only places people can afford to go to. Yeah.
And just a show of hands, who's ever managed to actually have a medical appointment and get what they need in 7 minutes? Yeah, I certainly haven't. And I don't go to the doctor a heap, but when I do, it's certainly going to need more than 7 minutes because, 7 minutes is nothing.
Hi, how are you? Okay.
Yeah, how are you and bye. Yeah. Julia, Kim, from your perspective, and I know you're very early in your medical career, but you're certainly more advanced in your neuropsychiatry research career, your research career. What is good looking like for you at this stage?
I think what's good is when the person with mental health issues is at the center of their care. So it sounds very general, but what I mean by that is like when a patient has, we don't think of a patient with their diagnosis and just by the symptoms, but when you actually hear their story and when you're able to get to know more about what's their actual experience, what's their actual what's actually concerning them. And when you actually hear their story, that's when you actually get to help them in their journey living with mental health issues. And I think that's good when you actually consider the person in front of you rather than a diagnosis that you want to treat.
Yeah, there's nothing simple about that, is there? And the Cancer Council were here earlier, and often the experience of people living with cancer is that they go from being Natasha to being cancer diagnosis. That's it. Natasha, the cancer diagnosis. And you walk into this, and suddenly you're sucked into this system as a patient. And that diagnosis, that frame around you is very, very limited. And it's a big deal, isn't it? You are much more than a diagnosis. Exactly. When you most need to be more, more than a diagnosis. Yeah.
And by recognizing that there's actually a person behind it, that's when the patient can actually take charge and be the one leading that journey themselves when they're actually involved in that care, and make that shared decision with the doctor. I think that's really good for them.
Confronting for some doctors.
It is confronting, but I think it's important regardless.
Yeah. Thank you. Jeff Harris, what does good look like for you as the Executive Director of Mental Health Coalition of Australia, South Australia. Australia, you wish. Yeah, taking over the world.
I would suggest South Australia's big enough.
Yeah.
I think it's difficult to answer that. Like, I think in the context of what people have said, I think, like, particularly that thing of, hey, there's a person attached. So in the medical system, there's kind of, or the way it's designed and constructed, like, it's really easy to just kind of say, oh, you've got this illness, as opposed to, hello, there's this person.
Walking diagnosis.
And I think what you said about cancer, I think just applies, it's a risk across health.
Yeah.
And I think listening to the Productivity Commission and talking about the declaration, I think one of the things that would help define good or create the parameters for expecting good is including a human rights approach, but actually understanding what that means in the mental health space. And physical health is part of it, but it's that thing of actually delivering a service that is right for the human and the condition, not prioritising one over the other kind of thing. And I think in mental health, like, what I often see in the human rights conversation is it turns towards doing less bad things, which is obviously important. Like, we've got to do that.
It's not a great healthcare model, though, is it? Let's do less bad things.
No, but what the human rights thing is saying is we need to help people to lead a good life. So it's not just about the mental health condition or the symptoms or the medication. It's actually
the thriving,
the whole thing. And I think, like, when I talk to policymakers, often their eyes kind of glaze over a bit, and they kind of say that's not health's job, But it is. Like, we talked about bridges, I think, somewhere in these 2 days, and that's where I think it's not our job to build a house for someone, but it is our job, if someone hasn't got a house, to do something about it, like to help with those kind of things. So I think good in mental health will be getting the balance right around how we help people across their life rather than just the illness bit.
And someone said, I think it was one of the commenters over there said, if we gave houses to people who needed houses, so many other aspects of health and mental health would be solved. And I so agree with that. As we come to you in the audience, I'm interested in what you think good looks like and what we need to get there, why you came, and what Monday looks like for you as a result of being here. But I'm just going to whip through. If you were stuck in it, and Russell was very keen on this question, he offered it to me, I'm taking it, and I'm handing it to you. If you were stuck in a lift, and I know you probably are, Tom, quite a lot, stuck in a lift intentionally, but if you were stuck in a lift with a key minister, for, let's just say, like 2 hours, and neither of you have claustrophobia, so you're doing okay emotionally in this situation, and you know that minister has a bucket of $20 million. Ministers do have access to this sort of money. This is the bizarre thing. What would you want them to prioritise around the equally well conversation? Tom?
So I might ground us in some reality and tell me, call time on me if I go too far. So we did a survey, 5,000 Australians from across all of Australia, different experiences.
So good sample size.
Good sample size. 1 in 10 of that survey, 1 in 10 couldn't afford the healthcare that they needed at the time.
Yep.
And so the conversations we're having here around being physically well, 1 in 10. Now, of the sample size, 8% said that they had experienced discrimination when seeking care. 8%. That, if you equate it to and being a cheeky advocate, that's 1.5 million Australians. That's significant. And so we're having this conversation now. We're talking about barriers. We're talking about access. We're talking about affordability. And I guess that's the key thing. Physical health, when you're talking about mental illness, actually being able to seek support, and if you extrapolate that experience from what we were talking about, those 1.5 million people have said that based on discrimination, they've
Mm.
made decisions not to seek that support.
Mm.
On top of that, 1 in 10 can't afford it. That's highly problematic. On top of that, when we've heard in the media most recently the conversation around specialist fees. Now, it's been reported, and this is in the public record, that an appointment with a psychiatrist can cost anything upwards to $1,000 for the initial consultation. Now, that's the stark reality, and that
If
is...
you can get an initial conversation, that's a
Yes.
small miracle
Yeah,
right
yeah,
now.
yeah. And the last piece, if you'll indulge me, is the postcode lottery, I like to call it, that not everything is equal. I live in Melbourne, in the western suburbs of Melbourne. I can go and see a bulk bill GP. There's specialists around. That is not the experience that I hear when I travel around Australia. I was in Tasmania, and what people down there told me is that even if they can afford to see a GP or to see a nurse practitioner, because there are nurse practitioner-led clinics down there, that can take upwards of 3 weeks. And they have to travel 40 or 50 kilometres, and there's no continuity of care because that's a lottery as to who's available. And so what that leads to is rocking up at emergency departments.
Yeah,
when it could be
which
dealt
are
with.
under incredible
Yeah.
pressure
Anyway,
right now.
so-
And so to the minister, you would say,
We've told the minister this. We
Yeah.
launched the National Consumer Sentiment Survey, and he came along and we outlined this, and he listened. So this is a positive that this is happening. So,
yeah. So at the foundation though is that access to fundamental healthcare, it needs to be more affordable.
Yeah.
In a cost of living crisis.
Absolutely, yeah. And if you talk around, what we're here to talk about today, you've got to remove that discrimination, stigma, if you like. I know that the two concepts are, we can talk about those, but stigma and, coming from where I'm coming from, working previously with the Council to Homeless Persons, I am acutely aware of that lived experience and that voice that's been shared with me, and that's why I sort of moved into this health space, because hearing that experience of the discrimination, the stigma, the challenges, on top of that with the, lovely that productivity insurance talk about dual diagnosis, people that have co-occurring
Yep.
mental illness alongside AOD and experiencing homelessness, they fall into this black box, black hole of who do you look after, and then...
And do you go to the GP or do you pay your rent? Or even, it's not even your rent, it's like maybe a third of your rent or a tenth of your rent at the moment. Thank you for that.
Yeah.
Dave, stuck in a lift.
20 million?
Yeah.
Bring back a public awareness campaign like Life Be In It. Raise public awareness to the point where they raise their expectations of the health system and of their government. Demand better. Create a groundswell of people that are outraged at how things are, but also provide simple strategies and awareness of the things that we need to do to keep ourselves well. Bring back Norm.
Yeah, Norm. Well...
sorry, I'm showing my age here, but maybe not Norm, but,
Yeah.
create a groundswell. Get everyone
Norm was
aware
good.
of
Norm's
the problem.
great-grandchild.
Yeah.
Yeah.
Get everyone awareness enough to know that there is a problem, but also that our health system is struggling to react appropriately and respond appropriately. So the only way we can do that is through government. We've got to get the people to demand better from our government.
Julia, in case you don't know Norm, I will show you later.
Sorry, I really am showing my age, but...
Life in It. What's the tune? No, what was the tune?
Oh.
Life... Da-da. Yeah.
To join our call to action, because that's we're going to demand better.
Fantastic. 20 million in the lift. Julia, from a medical student's perspective and a researcher's perspective.
So I'm ambitious. I have two things I want to propose. To paint a picture, first of all, though, so I had 2 terms in psychiatry, one in metro area and one in regional area. So that regional area was Mount Gambier. And the main problem that I saw in Mount Gambier was that the psychiatrists were doing a fantastic job, right? The patients who are admitted to the inpatient unit, they recover and they're about to be discharged because they are at the stage where they can be managed in the community setting. But then what happens then is the GPs, rural GPs there, are fully booked out. So they're actually not accepting new patients just because they just don't have any books. So if you have a patient that just recently came from interstate and are under our care, we want their physical health to be looked after upon discharge. And now that longitudinal physical health care won't be done just purely because there won't be a GP that's open to take a patient in.
Yeah.
And that's not just only for mental health patients. It's, for example, for me as well. I'm going to be an intern next year in Mount Gambier. I won't have a GP next year because there won't be a person to book me in for. So I think that's an issue that is actually really that's felt tangible, both from a psychiatrist's point of view or like from the patient point of view. That's a really big area that's a really big gap that needs to be addressed, but has not been fully addressed for, I feel, quite a long time. And that's something I'll propose for the first one. The second one would be, I think there is a focus on attracting rural doctors to rural areas, but not much on retention of the rural doctors. So an example of that would be, recently doctors had their enterprise bargain agreement passed, and part of that was regional bonus, which didn't exist before, but it now exists as part of this year. What happens though is that it's only for doctors who are starting out rurally for the first time, like getting their first contract. So what that means is me starting internship next year in Mount Gambier, I'll be getting that regional bonus. But the doctors who are already working in that regional areas, unless they get a new contract in a new position, they won't be eligible for that regional bonus. And now this, I think it really shows that the focus is getting more doctors into rural area. Their intention is there, but I think the appreciation and that longer term, investment, into having them there for a long term and actually building that patient rapport for a longer term is missing.
Yeah.
So that's my second suggestion.
What a great thing that you're going to be placed in Mount Gambier next year.
That's right. Yeah.
Fantastic. Wow. I love the fact that you're so actively engaged in the region. Jeff, stuck in a lift with a politician, briefly.
Okay. Look, you knucklehead.
Yeah.
No, sorry. Sorry, that's the halftime speech. So I guess to follow on from what Phil was saying from the SA Mental Health Commission, like we've got the unmet needs study for South Australia for unmet need for psychosocial support. We've got the national study. We've got the Productivity Commission saying now that your agreement is not fit for purpose and it'll take you 12 months to sort that out. But in the meantime, you've got to invest in psychosocial support. We've done some work in the Barossa and in Salisbury, $14 million, sort out all the demand in those areas, pick another area that costs $6 million, and we can address that unmet need, and that will include a strong focus on physical health, and depending on how big the building is, I could give some examples of that, but that's what I'd go for.
Thank you. Now to the room. Thank you for your contribution. Now to the room, you can answer one of four things. You can say, we've got another mic there too, and I'll cover this side of the room and in the middle. You can answer, why did you come? What drew you here? You can answer, what happens on Monday? What are you taking away? What kernel do you want to integrate into your practice, your work, your advocacy, your life? You can, what looks good? What would good look like? You can respond to that. How do we get there? So hands up, thank you. And can I just also say, Michelle, I don't know whether you're on the WhatsApp group. Have you seen the flood of feedback for your presentation? Kristen, well done, Michelle. Amazing presentation, Michelle. Jojo, this was a wonderful presentation, Andrew says. Congratulations. Thank you, Michelle. I felt so empowered, says Yvette, after quitting. Well done, Michelle. Sarah, thank you, Michelle, for sharing your story. So wonderful to have your experience to inform equally well work. Jojo asked, what's a medicinal vape? We might come back to that. True recovery story from Michael. Great share, etc. Congrats. Yes.
So mine was what would look good, and I really echo what Julie is saying here, but I would have MBS item numbers for GPs to give much better mental health people with mental health issues better access to them and have decent length conversations and consultations. I would have support sustainability of evidence-based programs, because too often we do some really great work and then the funding runs out and it's gone. I would co-locate some primary health with community mental health service, and particularly GPs. I would definitely replicate Melbourne and the South West Michael's GP in mental health services. And support for regional mental health services, which is basically what Julia actually said, and embedding physical health into mental health services and incentives for regional, for mental health and general practice. And Monday, I'll go back into John's office and play the same old broken record again and again. Only this time I will say that we need to make Michelle our equally well lived experience ambassador for South Australia.
No pressure. You did your homework. Oh, that's excellent. Love a SWOT. Does that resonate with anyone else? I'd love to any reinforcement. So, because we might be able to gather a list. Thanks.
So, just for context, I come from a youth.
Just bring that mic right up.
For context, I come from a youth and a multi-morbidity lens. The first thing I would ask for is prevention, because we see so many young people who have mental health issues and struggle with their mental health, and then they're on the wait list for so long, and it comes to the point where they're in crisis, and it could have been addressed, and they would not have to go through the trauma that comes with crisis. Second, I would ask for a multidisciplinary model that adequately pays for the fees that are asked for by medical practitioners, but also that would allow care teams to adequately care for people with complex comorbidities and mental health and physical health issues. And I forgot the third one. So
yeah, well, it might. We can come back to you if you remember it.
It's gone.
Great list. Thank you. Does anyone want to... Thank you. Yes, love the cheering. That's what we want. Does anyone want to amplify what's been said or add your own? Great.
You. Basically, I just want to respond to what good looks like only. And I feel good would look like continuous efforts to, irrespective of limited resources, continuous efforts to the progress of everyone's health individually that comes into the healthcare facility, not just getting them out and just leaving them alone, but just continuous effort.
So in other words, not just that single appointment, but a kind of ongoing relationship? Is that what you're getting at?
Yeah, more like, and even if we know they may have progressed so far, we don't just leave them to go just like that. We see how we connect them to resources within, despite limited resources, just so they could still thrive in life.
Yeah, that's a really great point. That kind of, it's a relationship that needs to kind of bloom into other kinds of supports, doesn't it? Rather than just one appointment with a GP. Hello. Oh, there's a silence in the room.
So
yes.
often,
Dave.
Just so often we seem to focus on managing the deficit. You know, if we take away the bad, then everything will be fine. But does the removal of the bad automatically mean good? Good is quite different and separate in my mind.
Yeah.
Good, you want to feel like you're connected to people around you. You're part of things. You're included. You are able to do the things that you want and the things that you find important to you.
Yes, I think of the parallel movement and look, I mean, there were some problems, but, in the psychology community, they realised that it was all about pathology, and so then came the positive psychology movement. It went a little bit far, potentially, but interesting. It was a sort of, okay, hang on, we've got to stop thinking about everyone as a walking diagnosis. We have to look at flourishing and thriving and flow and all those other things. So then there became interesting research around that, and Seligman and all those sorts of people. Hi, John. I need to come to you. Yeah, sorry.
What, you actually want to talk?
Don't you just have an inbuilt mic? I've got it.
It's getting a bit late in the day, isn't it? I've had a long time to think about this because Russell emailed me the $20 million question a while ago. My first response was, I'm not Naomi Campbell, I won't get out of bed for that. We need a lot more money, right? Because 20 million from the South Australian minister scaled up on a population basis is actually 200 million for the country. Then we can start to do stuff, because one of the things that strikes me is everybody's got great ideas. I support everything that everyone said, but we need to scale. I'm really concerned about equity, because when you argue for your little patch, but we haven't got enough to go around, we get inequalities, we get this, it just builds up. And the worst thing, I think, is the postcode lottery, which you said, is that when you've got a little bit of money, it always goes to the people who are always rich. It doesn't actually go to the people who need it. So we actually need to get our movement to show what equity could be. I think that's the main thing.
Jack, I don't have my glasses on. South Australian Community Mental Health Services need a team that covers the homeless population specifically. At present, there is nobody, and there is also needs to be an escalation points for practitioners who hold concerns for this population. Where do we go? Who do we call? Mental Health Triage do a great job of recording the information provided, but there doesn't seem to be any traction from there. Is Jack in the room? Do you want to add anything verbally to that? It's okay if you don't, that's fine. But there's been a follow-up from Susie Gates, who says a combi van that can cruise around, do physical and mental health assessments and prescribe and administer any medications then and there and chase them up again. We know they struggle to make it to appointments because they have more pressing concerns such as food and shelter. So on any of our, they're great suggestions. Yeah. You're going to take on the Polly in the lift.
I'm going to take the Polly in the lift. I think there is a problem with the question to start with. Let me give you the two factors that, we had 1, 2, 3, 4 different ideas for that $20 million. So we have contestability, we have fighting against each other, which is something that we have a problem with right now. That's the first problem. The second problem is the bureaucracy is going to take 35%. The agency after that is going to take 15%. That's 50% of the money gone. I would like the politician to turn around and say, he said, I've got $20 million. What do you think I should do? Is for me to say, utilize that $20 million to get all the people from the different departments that are dealing with the areas of mental health and all these other areas that impact health, like housing, like supports and so forth, NDIS and everything, and put them together for a year to work out a common plan that utilizes money in an effective way in government.
Hear, hear. Yeah. So, that's one for next week, because the Equally Well team and others in the network are going to be fronting up at Federal Parliament next week to have this sort of conversation. Are you going to be there? Ooh. We have a question or comment over there, thanks.
I just have a comment, and it follows on to what's just been said. Every person, no matter their background, income, mental health, disability or life circumstances, has the basic human right to safe, secure and affordable housing. This is not an option. It is recognised international law, Universal Declaration of Human Rights, Article 25. I think it's a huge overriding factor that covers everything that we talk about all day for the last 2 days.
I would agree. Are you Michael? You get my other prize for participation on the WhatsApp. It's been fantastic. Thank you so much. Lots of really great comments. Housing. Anything else? Do we have anything else? Any other comments? Yes, we do. We've got 2 hands over there. Thank you.
This is my first time being introduced to Equally Well, and it's been an amazing conference. What brought me here on a personal level, not so much professional, was my son has complexities that involved intellectual disability as well as mental health issues. And I noticed the disconnect in care and how it's impacted. In fact, it's actually led to some permanent sight damage because of the lack of connected care, which has been the theme of this conference, and the lack of adaptability in treating both the mental health aspect and allowing, adaptability in standard tests like eye tests, where communication may be challenged, and there's very little adaptability in language, and whether that be easy read and other tools that are out there that can make things easier. So that's what led me here today.
Fantastic, thank you. I'm so glad you've come here. And we've got a hand there. Hi. I mean, you're a hand with a human attached, sorry.
Hi.
Hi.
I actually was going to raise something really similar. Obviously the work that Equally Well's done around the excess deaths and the reduction in life years and all of that is really, really important. But I guess my experience is, permanent damage to my health and my physical well-being because of the inability to access services or services that aren't trauma-informed or able to deal with PTSD for medical screenings, that sort of thing. And so I was just wondering, I think it'd be great if there was more research done into what is the impact of that, not on just, I suppose, mortality, but the people who, get all of those conditions that we talked about, with like heart disease, diabetes and all of the other things that other people have talked about, the impact on people who are, I guess, hurt or suffering or all of those sorts of things, but are still around. Because I feel like it'd be really interesting to have that data so that we can advocate for government, because while, yes, absolutely, that people dying prematurely is 100%, like obviously that's important, it goes without saying, but the impact is even greater because of, even greater numbers of people who suffer because of the same causes.
And I think you raised an important point about the harm that's done. There's your life experience because of mental illness, one's life experience, and then there's associated health impacts, physical health impacts, but then there's this sort of almost third bucket, I think, sometimes, which is kind of harms done, health consequences of harms done by the actual system that translate into physical health problems. I think that's really important too. Thank you very much. Yes, agreed. I think we'll wrap now, and I'll say thank you. Any final comments from the panel, just briefly, or we're ready to... Yep, Tom, go for it.
Love that people want to be involved. If you do want to bring your lived experience to it, people like Health Consumers Australia, government does come to us, so follow us on, sign up for Consumer Voices, follow us on social media. When government does want to engage with people, we put those opportunities out. Also in your different states, follow the local health consumers, follow your health services, because they do reach out. So if you do want to make an impact and you do want to be involved, that does happen. It's not universal, but it does happen. So if you want to be involved, do that. And yeah.
So what was the name of the newsletter to sign up to?
Just go to our website, Consumers Health Forum Australia, and click sign up to Consumer Voices.
Yeah.
And we have a whole list, and sometimes we've got 8 opportunities at any one time. And but that's not just us, that's across the health sector that, so in your local area.
But you're a good one to start with,
yeah,
I think, because just also sometimes it feels very lonely and you don't really know what you can do to be an advocate, but certainly just hearing sometimes what other people are doing shifts the conversations in your immediate sphere, because you've been reading a newsletter that says, did you hear about, I've heard about this. So this is the thing. I think it can feel a bit overwhelming. You all have exceptional skills at advocacy. Some people are just trying to get by, aren't they? Well, you're probably all trying to get by as well. Look, thank you so much to our panel, Dave Peters, Jeff Harris, Julia Kim, Tom Johnson. Thank you. Yeah. So as we wrap, we've just got a nice little celebration, some awards, and some of you are nominated for these awards. So we're just going to do a bit of a stage reset. Feel free to talk amongst yourselves, have a wriggle, have a stretch. We're going to round off with a beautiful sense of celebration. And Lisa Wilton has dressed for the occasion, because not only does she work in this sector, she does a bit of theatre. Musical theatre, is it? No, not musical theatre. Okay.
No, it's I would have wrapped it earlier. Yeah. No, it's fine. We're yeah. So you went like Thank you. Guidance. How do you want us to stand? When you just want to stand up the side of the banner. Okay. Sorting out the technical bits. Clearly, we didn't have enough rehearsal. You guys worked out what you're doing? Right, we're good? We're good. All right, so thank you, Natasha. As everyone knows now, my name's Lisa Wilton, and it's a real honour this year to be asked to be presenting the Equally Well Achievement Awards. This is the exciting, fun part of the conference where we get to celebrate our stars, so I expect to hear lots of big, loud cheers. Now, who is left here from Interstate? Put your hands up if you're from Interstate. Okay, fabulous. Well done. Thanks for coming. You might not know that South Australia is the pageant state and that on the second Saturday of November, the City of Adelaide is overrun by clowns and elves. And we welcome Father Christmas to town with as much sparkle, stars and glitter as we can. So today I dressed to bring some of the stars of the pageant to our stars of Equally Well. So the Equally Well Achievement Awards is an opportunity to formally recognise organisations and individuals who are making an impact on improving the physical health outcomes for people living with mental health challenges. This is the third year we've held the Equally Well Awards, and we have a really inspiring group of award winners to recognise and honour today. The value of the Equally Well Achievement Awards is to be able to bring attention to successful activities, initiatives and programs across Australia that are making an impact in our shared aim of closing the life expectancy gap for people living with mental health conditions. And it is our hope that in recognising the award winners, it may inspire and motivate others to continue this work and encourage key stakeholders and partners that can serve to influence the change we all recognise is so needed to continue the support of the Equally Well movement. Today, we're very pleased to present awards in 6 categories, and unfortunately we don't have time for the program for the acceptance speeches. It's not the Oscars from all of our winners, but you will find out more details about each of them in our blog post on the Equally Well website. I welcome our fabulous conference chair. Can we have a big round of applause for Natasha Mitchell? She's done a brilliant job over these last 2 days to present the certificates to the award winners, our stars. So now when the winners come up, if you could stay here on stage once you've received your award, and we'll get a big group photo at the end of the presentation. So here we go, drum roll. Beautiful, thank you. Award category 1, the Emerging Star Award. This award acknowledges an early career professional or researcher, and the award goes to Abolia Albert, who likes to be called Albert. In recognition of his achievements, contribution and research to implement and embed the Equally Well vision. Albert is an award-winning social worker, researcher and educator who has implemented a series of strategies to build staff capability and embed lifestyle interventions into routine mental health care practice in his role in the Gold Coast Health. Congratulations. Okay. Award Category 2, Outstanding Partnership and Collaboration. Cue the drum roll. Thank you. And the award goes to Cancer Council New South Wales Tackling Tobacco Team. Accepting the award is Professor Billy Boneski. So, acknowledging outstanding impact and collaboration to create Cancer Council's New South Wales Tackling Tobacco program. Evidence from a randomised control trial shows that people are up to 5 times more likely to quit smoking after participating in the program than those who had not. And when asked why, talking about smoking was important, the words of one consumer, because it gives you hope. Congratulations. Okay, award category 3, outstanding team effort. And the winner is the Mental Health Clinical Collaboration, Metro North Health, Queensland Health. Where are you, Justin? Award's been accepted. And the award is... The award has been accepted by Justin Chapman. This award recognises the statewide service improvement initiative which addresses long-standing inequities in the physical health of people living with mental illness by applying collaborative quality improvement methods. Congratulations. Okay, halfway there. Award category 4, outstanding co-design. And the award goes to, cue the drum roll, Simplicity Co-Design and Concept Mapping Team. And this award acknowledges the co-design process undertaken to develop a peer-supported, digitally delivered tool to enable safer, easier self-care of physical health, ensuring accessibility and cultural inclusivity in the design. The award has been accepted by the group, Alyssa Melton, and others from the team. Congratulations. Okay. Now, award category 5, Research Impact Award. And the award goes to Lancet Psychiatry Physical Health Commission Consortium. the award is in recognition of the team's international contribution to physical and mental health research. The 2025 report offers a vital roadmap for embedding lifestyle interventions into mental health care, focusing on practical recommendations for services, outlining several international exemplars to inform widespread implementation. And the award was accepted by the project lead and equally well ambassador, Scott Teasdale. Okay, and our final category, award category number 6, Outstanding Individual Contribution. The award goes to Rebecca Helvig. Congratulations. Rebecca is acknowledged for her outstanding contribution to improving the physical health of people living with mental health challenges through her work advocating on behalf of others and educating the sector on the Equally Well framework. The award recognises Rebecca's dedication and relentless passion for supporting Equally Well best practice through the sharing of new and innovative ways for services to work more collaboratively to enhance the lives of people living with mental health conditions. Congratulations, Rebecca. So congratulations to all the winners and to all the nominees who took the time to submit an entry to the awards. You are all Equally Well stars. We hope that your achievements in recognising the great work happening across all areas of the Equally Well network will continue to have an impact and move us closer to that shared goal and commitment to improving the quality of life for people living with mental illness and the people who care and support them. Can the winners, our stars, please gather at the end of the stage for a group photo? So all on this way. On the stage. The banner. Just quickly come together. Come together. Right now.
Over me. Dun, dun, dun,
This musical interlude will be given by Dave.
Concert.
You've got to go in.
Oh, shit. Sorry, I was recording it.
Yeah, that'd be lovely. John, side on and cuddling. Thank you, Scott. And Catherine, Ian, Joyce and John. Right, nice. Dave. I'm going to take a photo. Thank you.
Please come back.
And now we wrap. And as we wrap, some acknowledgements. Excuse me, we've tried our best with pronunciations. Forgive me if I slightly muck it up. I just want to say it's been my real honour to MC this conference for you over the last 2 days. Thank you for inviting me, Russell and team. I care very much about the work that you do, and can't wait to see how it evolves in all the ways that it can. For the stretch sessions, I'd like to acknowledge Natalia Zupan. Support providers, these are the volunteers who have been available for participants where needed. Gemma Ferraretto, Joe Bensick, thank you, Jane Dewing, Russell Smythe, Sarah Skinner, Amanda Mios, Israel Azigby, Shannon Harwood and Catherine O'Donnell. Thank you so much. To the mighty Conference Organising Committee, Russell Roberts from Equally Well, Charles Sturt University, Lee Cobb also, Victoria Erskine, all from Equally Well at Charles Sturt University, the very mighty, Ben Wells, Nemai National. Yes, I love the applause, let's do it. Catherine O'Connell, Mind Gardens. Dee Backman Hoyle, Lived Experience Carer Representative. Lisa Wilton, South Australia Health. Lynn English, Lived Experience Consumer Representative. Melissa Bond, Country SA PHN. Dave Peters, Lived Experience Consumer Representative. Shannon Harwood, who opened our whole conference with her incredible presentation and panel, Lived Experience Consumer Representative. Vinay Lakra, the Royal Australian New Zealand College of Psychiatry, I think, RANZIP. Is that right? Yeah. RANZIP. The sponsors. In fact, I'm going to get Russell up to do the sponsors for me. Can you do the sponsors? Is that okay? Yes. This is a free event, which is possible due to sponsors, and off you go. There's the list.
It is a free event. It's really important for us to equally well that it is free and everyone has an equal opportunity to come to that. And thank you to all the sponsors and the commissions who've enabled people from right around Australia to travel free of charge, all expenses paid, often the very first conference they've attended in their life. Equality. Thank you for all these sponsors, and they would be Australian Government Department of Health, Disability and Ageing, who really underwrites this whole conference, the Queensland Mental Health Commission, Primary Health Tasmania, Western Australian Mental Health Commission, we had them represented here, Country SA Primary Health Network, South Australian Office of the Chief Psychiatrist, thank you for your support, New South Wales Health, Mental Health Professionals Network, which we have a great partnership with, Nemai National, how fantastic was the launch of the health prompt, and that is that. So thank you so much to make this equality, equal rights, equal status event possible. Let's thank all our sponsors.
And we'd also like to thank Victoria Erskine, Sky Sharp, Zuza Baran, who took all the photos and did a lot of the socials, Justin Chapman, and with that, Lee Cobb and Russell Roberts, the Equally Well team. And thank you all for being here. Have a great Friday night. Enjoy your weekend, and I can't wait to see what you do on Monday. I dare you.